Ashok Kumar Mahapatra to grace the stage. We also welcome our guests of honor, President IRA Odisha, Dr. Sisir Kumar Mahapatra, Patron IRA Odisha, Dr. Bharat Panigrahi, founder of Prachi Education Foundation and renowned gynecologist of Odisha, Professor Dr. Punna Mahapatra, thank you, sir. And as we prepare to embark on today's intellectual journey, it is my pleasure to welcome the minds behind the science and structure of this esteemed gathering. Please join me in welcoming our esteemed scientific chair, Professor Dr. Prasant Kumar Padhan. We also extend a warm invitation to our organizing secretary, Professor Dr. Jyotiranjan Parida, whose dedication and tireless efforts have made today's program a reality. Kindly come forward and grace the stage. As a token of our appreciation and a symbol of growth, sustainability, and enduring legacy, we will now present each guest with a potted plant. From the glow of a single flame, wisdom spreads across minds and time. Let this light shine not only on our stage, but in our hearts also. May I now request our dignitaries to kindly light the lamp. Thank you so much. Before we proceed further, let us rise in collective pride and reverence. I kindly request everyone to please stand for the rendition of Bande Utkala Janani, the soul-stirring anthem of Odisha, a tribute to our motherland, our heritage, and undying spirit of our people.
Charuhasamai, charuhasamai, janani, janani, janani. Utapayodhi vidhauta sarira, talatmala sushobhita tira, subhrakatini kura sikara samira, janani, janani, janani. Ghana ghana vana bhumi rajita ange. ज्ञान विज्ञान प्रदर्शित नेत्र ज्योति रूसी गण उठज पवित्र जननी 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 सुंदर मंदिर मंडित देश चारु कला मणि शोभित वेश पूर्ण तीर्थ जय पूर्ण प्रदेश जननी 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 उत्कल सुरवर दर्पित गेह अरिकुल शोणित चर्चित देह विश्व भूमंडल कृत वर स्नेह जननी 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 कविकुल मौळि सुनंदन वंद्य भुवन विभूषित कीर्ति अनिंद्य धन्ये पुण्ये चिर शरण्ये जननी 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 वंदे उत्कल जननी वंदे उत्कल जननी वंदे उत्कल जननी.
Thank you. Behind the seamless rhythm of this event lies a spirit of quiet leadership and persistent grace. Let us now hear from the one who orchestrated it all, our organizing secretary, Professor Dr. Jyoti Ranjan Parida.
Respected chairpersons, our today's chief guest, Padma Shri Professor Dr. Ashok Mahapatra sir, our guest of honor, President IRA Odisha, Dr. Sisir Mahapatra sir, Patron IRA Odisha, Dr. Bharat Paningrai sir, the founder of Prachi Education Trust, and we all know our teacher, Professor Purna Mahapatra sir, today's scientific chair, Professor Dr. Prashant Pradhan sir, the father of primatology in India is a legendary figure. I think all were our inspiration, Professor Dr. Anand Malabya sir, who is sitting there, and all my teachers, colleagues, friends, seniors, and students. So first of all, I welcome you all and thank you all for joining this meeting. I also welcome my teacher, Professor Ramnath sir, who joined now. So, Odisha Arthritis Rheumatology Foundation Trust was formed in 2021 with an intention, with many aims and objectives. Besides others, the main objective was to take rheumatology beyond its wall and spread the awareness of rheumatology across the state. So for that, for the last 4-5 years, we are continuously trying many, whatever platform we have to educate doctors and particularly students, at least to be aware of this not so new branch, because 10 years back we used to call this is a new branch, but I think now everybody knows about rheumatology. So we have conducted at least 20 to 25 CMEs across the breadth and length of the state. But when to take the education to a higher platform, we thought how we can contribute to the rheumatology education. Then we thought that every day in and out there are conferences, everybody are talking, but there is no cross-talk. So we have taken this agenda and tried, because in daily practice what we are seeing, that if I see a patient, prepare that for pregnancy, I want as a rheumatologist that my patient should be in remission throughout the pregnancy. But if the gynecologist will stop the medicine because of the safety issues, then I think there is a problem. If the disease flares, it became a problem. If the gynecologist is advising some contraception or some hormonal therapy, as a rheumatologist or as a physician, I should be aware that what is the clotting risk and whether the patient can take this or progesterone or estrogen or not. So for that, I think talking among each other, because cross-talk is the basis of immunology. If the T cell and B cell will not cross-talk, then no immune response will happen. So for the last 4 years, this is our this is our best effort to bring different fraternities with rheumatology. And initially we started with 2022 with first topic was on eye, catching the eye in rheumatology. The second one is looking deep into skin rheumatology. The third one is breathing deep into lung rheumatology. And today I am glad to tell you that this year theme is connecting flares and fertility in rheumatology, which is very, very important for both the mother and the baby. And this journey has become quite exciting and satisfying, and this is not possible without the contribution of the national speakers. I think we are very lucky to get a good bunch of national speakers all throughout our journey, and this time also you'll see we have all the very distinguished speakers from across the nation who are going to share their knowledge with you. So without taking much of my rest of the time, I'll now welcome our guest of honor, Dr. Sisir Mahapatra sir, which is President IRA Odisha, to tell few words. Sir.
Thank you, Dr. Jyoti Ranjan. Jai Jagannath, good morning. In the early morning of Sunday, you are all happy and jovial, what I find. Today, we must know the dignitaries and the dais first. Then we will discuss about the scientific agenda prepared by great organizing secretary, Dr. Jyoti Ranjan Parida. Now, respected, most revered chief guest, Dr. Ashok Kumar Mahapatra, the first and the legendary director of AIMS Bhubaneswar, for which today we are proud of having AIMS Bhubaneswar the second place in the country. He is a Padma Shri awardee, a renowned internationally famed neurosurgeon. You must have known the conjoined twins of Jaga and Kalia taking 18 hours separating the brains of the twins, and there was a live telecast. The entire neurosurgeons of the world were observing that. And do you know his philosophy? It is very much applicable for those who are attending this rheumatology conference. Your patient should be your friend. That he declared in our last East Zone conference held at Bhubaneswar a few years back. We are very proud of you, sir. You have spared your time and you have joined and you are gracing this occasion as the chief guest. You must have heard Badya Narayana Hari. What does it mean? That Badya Narayana Hari is today with us, Professor Purnachandra Mahapatra. He is providing you a life fetus through his Prachi IVF center. Do you know, people wait till 2 a.m., 3 a.m. in the night for his darshana, because he is a living God. I respect you, sir. I speak all this biodata because I am the president of IRA Odisha chapter, not as the guest of honor I am speaking. Guest of honor talk is something else. And the great friend of mine who is the creator of IRA Odisha, who has created this IRA? Indian Rheumatology Association Odisha chapter, Dr. Bharat Paningrahi. Some 8 to 9 patrons were there, and today is existing since 2007. He is a great rheumatologist. He was the emeritus professor during COVID-19. Nobody used to know what is happening to a patient. What are the immunological changes that are happening? Dr. Bharat Paningrahi. And you know, the most learned immunologist, rheumatologist, he is so sympathetic. I always say doctors have no doctors. But he is a doctor, Prashant Pradhan, the professor of immunology and clinical and rheumatology, KIMS Bhubaneswar. He is a doctor for doctors, leave about doctors, a doctor for patients. And Jyoti Ranjan is a very brilliant young DM in rheumatology. We are very much proud of him. He is organizing single-handedly. And today we are also proud to have Bhishma Pitamaha of immunology and rheumatology, Professor A.N. Malviya. Sir, when you used to hear Professor Malviya is coming, you were all running to listen to your talk. And the international famed Dr. Ramnath Mishra, a great learned, only in the national IRA conference there will be a fight among Amitabh Agrawal and Dr. Ramnath Mishra. And that credentials, really, we are very, very proud of it. I don't know how I am the President IRA. It's an honor, no doubt, but a great challenge today I am facing. So at the same time, I welcome you to this very important OARC Update 4. Because you know, I am a physician, not a rheumatologist like you. Now, what I find, medicine is ever changing, rheumatology ever challenging. And I remember a word when I was a student of MBBS, and I am fortunate also, I am the alumni where our chief guest also comes from MKCG Medical College. So there was a pathology text to William Boyd. It says, ignorance exceeds our knowledge. And this is the field what I feel today, that this rheumatology and immunology, our ignorance actually exceeds our knowledge. So, this is the conference where if you see about the programs that is set at right, the rheumatology and the gynecology health, that interface, that means the rheumatological diseases, the boundary of it, and the boundary of gynecology diseases, they overlap, meaning which rheumatological diseases affect the women of reproductive age. That is his menstrual health, that is his pregnancy, how to carry out pregnancy, and his hormonal functions. And the theme also he has already described, Dr. Jyoti Ranjan, that the Fertility connects with the fertility. In a disease, you see, there is a threshold, there is a target. Now, what is the target of a immunological disease? Either there is a disease low activity or disease remission. But at the same time, the other phase is the fire is burning too high. So that is the flares. So in an autoimmune disease, when there is flares, what to do? It impairs the ability of a woman to become pregnant, to conceive, how to continue that pregnancy, and what will the hormonal functions later on. That is a point in question. So today we are going to learn that. It is a very complex subject. Only persons with the brilliance, those who are currently updated, those who know about the recent research, because the system in immunology, there is a multiple system involvement. The symptoms are a protean, and the target treatment is also very confusing. You do not have any nuclear or genetic test that is available readily, so it becomes very difficult to diagnose. But once you diagnose, there is a great satisfaction. Do you know what is the problem today in our profession? There is a doctor-patient distrust syndrome. There is a doctor-patient distrust syndrome. But those who are immunologists, those who are clinical rheumatologists, I don't know how much they take care of those patients. There is a excellent relationship, magnetized relationship with the doctor and the patient. Therefore, this immunologist or this immunologist is called, it is the last heaven of a clinician. Ultimately, got a maximum achievement and maximum happiness, and that relationship continues. I don't know what is their divine power do they have. So that is the most achievement part. So you have to have a good last heaven, being a rheumatologist and a immunologist. Now with this, I think I must congratulate Dr. Jyotiranjan for his very vibrant scientific program, and also single-handedly, as the president of IRA, I must also convey my heartfelt thanks for his ability and dexterity to organize such a function, inviting all the guests and the speakers from outside the state. And I would like to request the delegates that we have got very renowned, talented speakers. They will definitely highlight their experience and also produce the clinical pearls, whatever difficulty is there. Therefore, please feel free, discuss your experience, share your experience, and ask questions, and I request you to get updated. With this, be a good immunologist, have a basic knowledge of immunology and clinical immunology and rheumatology. With this, I stop my talk, but Bhubaneswar is a temple city. Everything is sacred and divine here. We follow, observe, Atithi Deva Bhava. Anybody who has come, those speakers outside, we are there to help you. Please, any issue, problem, at least I am here at the IRA State Chapter. Please feel free to discuss with me. And our Professor Sitaram Mahapatra has come from Jajpur Medical College. He is the principal and dean and a very brilliant pathologist. Welcome you, sir, as on behalf of IRA Odisha. So thank you all. Thank you very much.
Now I request our guest of honor, Dr. Punnam Mahapatra sir, to tell few words.
Well, I am fortunate as well as unfortunate. In many of the meetings, by becoming the third or a fourth in the sequence of addressee. And here is also I am a third in the sequence of addressee. So it reminds me of one incident which I have couple of times I have told also. So once in such meeting, academic meeting, Professor Anderson from London was invited to Tokyo by Professor Hashimoto. Professor Anderson was a renowned and voracious orator, and he was the third in that sequence of addressee, like me. Professor Anderson spoke for 15 minutes at a length, But unfortunately, in country like Japan, nobody understands English. So an interpreter is there, and she converted and finished within 5 minutes. The second spell he spoke about 5 minutes, and she completed within 2 minutes. And the third spell he spoke about 2 minutes, and with one word he completed. Professor Anderson became very curious. He asked Professor Hashimoto, till today I knew that English is the best language in the world. Now I find that Japanese is the best language in the world, which can squeeze 15 minutes of English to 5 minutes and 2 minutes of English to only one word. I must learn this language before I leave for London. So Professor Hashimoto smiled. He told that in the lunchtime I will explain what is the secret. In the lunchtime, after inauguration, Professor Hashimoto was called by Anderson. He forgot. And Anderson told that, you told that in lunchtime I will tell the secret. Then he smiled and asked the beautiful lady translator to give the secret, what is that. Then the lady told that for the first 15 minutes, Professor Anderson is speaking this, which has already been spoken by the previous two speakers. The second 5 minutes, he told he is not telling any new things, repeating the same thing again and again. And last 2 minutes, with one word he finished, useless. So I am that useless today to speak in this forum of inauguration in front of the legendary audiences. But I think as a protocol I have to speak something for that. When the dignitaries were there, so honorable dignitaries on the dais, the honorable chief guest of this particular inaugural function, my elder brother, my village mate, a strict disciplinarian and hard task master from the beginning, which I have seen in 1973 in the second hostel of Barampur Medical College when he was a hostel secretary. So till today, you have maintained that strict disciplinary action and a hard task master for that. Apart from that, I think time will not permit me to elaborate the whole of his academic achievements, surgical achievements, research achievements, and last but not the least, the country has rewarded him and given an award, Padma Shri, this year. Professor Ashok Mahapatra, my elder brother. The eloquent speaker, again, there are three idiots, Mahapatra, sitting in the dais. One is Ashok Mahapatra, PC Mahapatra, and Sisir Mahapatra. I think the Sisir Mahapatra has already eloquently described vividly about all these activities led by Jyoti. I congratulate you, sir, for heading this organization and stimulating these youngsters to come up in a very big way. Dr. Panigrahi, I think you are dedicated for the cause of immunology and rheumatology in the state of Odisha. And Dr. Pradhan, the scientific chair, and Jyoti, the one and only one in the conference, a one-man show, Jyoti Ranjan Parida, the organizing secretary. Before welcoming all of you, I must bow down my head today to the father of rheumatology in the world, and what to speak of the country India, Professor Malavya. I hats off to you, sir. Age has not blocked you, and I think you have flown down from Delhi to Orissa. I think that's a great thing, and we must really appreciate all the efforts of coming here. Your presence itself will stimulate a lot of people for that. And another pride of Orissa, again my elder brother when we are doing post-graduation, 1 year senior to me is Professor Ramnath Misra. There are two friends, Ramnath Misra and Aparajit De. They are very good friends from the beginning, from the student career. And both joined in AIMS. But Ramnath Misra wanted to travel in a road less traveled by. He shifted to Lucknow and started a concept of a new department of immuno-inflammatory medicine and rheumatology in SGPGI. And till the retirement, he was there, and we are fortunate that he is there amongst us this particular session for that. And I congratulate all the delegates, the mixture of the delegates, the gynecologist. I'm proud of my gynecologist who has come over here, Girija and other people, and the physicians, the rheumatologist, and orthopedicians, and people interested in the subject on rheumatology for that. I welcome all of you for this particular inaugural ceremony and a whole day scientific deliberation for that. One thing I will tell, when Jyoti called me and came down to me and given a concept of this OARC update 4th, that means already 3 has been already done. And he has really done 3 with interdisciplinary connection with the different departments. I think there's the need of the hour for that. And I also told that my education foundation is always doing that for the last 5 years. We are doing the international conclave with endocrinologist, endogyne conclave, urogyne conclave, and critical care and gynecological conclave here in the city of Bhubaneswar for that also. And I think I have learnt that by this interdisciplinary activities, I think this is a source of information and knowledge sharing by the different faculties practicing various branches of it. And more so, now I think the subspecialty and super specialty has evolved in all branches of medicine. Let it be medicine, let it be surgery, let it be orthopedics, let it be gynecology for that also. And therefore, there is a need of this. And today, I think I will thank Jyoti for bringing infertility into rheumatology for that also. And believe me, unless you involve the ladies, the women power, nothing is successful for that. And that's why you started with this, starting from conception to cremation. I think that's the very idea for that. And I thank all the gynecologists friends present over here. I think this will be really a boost for knowledge for that. Lastly, my experience on rheumatology. I've heard the name of Professor Malabhe before I see him in the rheumatology conference way back, I think a decade before. And at that time, one of my close friend, a prominent physician, when the rheumatoid arthritis patient comes, it was only limited to rheumatoid arthritis. At that time, nothing was seen about the immunology, inflammatory disease, and various manifestations of all this in various sectors, as we see in infertility also. And there were not a single person, immunologist or rheumatologist in Orissa. And therefore, whom to refer? So he was referring to a 70-year-old illiterate gentleman in Nimapada and Kakadpur who was giving the roots and treating the patient for that. And he was appreciating that this is the greatest rheumatologist of Orissa. I have a chance to go and see him. I was not very much impressed on this. Maybe that psychological other thing and all that could be impressed. So at that time, the rheumatology concept was very, very primitive for that. It has expanded now. The spectrum has expanded to gynecology, to dermatology, to orthopedics, to various fractions of the subspecialty. And today, we will be dealing with the infertility, what is the relationship. The flares is a connection for that. And thank you, Jyoti, for connecting with us, the gynecologists and the females, so that your achievement, your target will be really boosted like anything for that. Thank you very much, ladies and gentlemen, for giving me this opportunity. I wish this particular endeavor, academic endeavor, will be really beneficial for all participating here.
Thank you, sir, for your inspiring words and motivating us. Now I request our guest of honor, patron IR Odisha, Dr. Bharat Panigrai, sir, to tell few words.
Thank you, Dr. Jyoti. So, Honorable Chief Guest of this morning, and all the dignitaries on the dais and off the dais. So, friends, I think all my predecessors have talked a lot about our dignitaries. I'll only tell a few words regarding the association and also regarding this conference. So regarding the association, almost 2005, people in Odisha didn't know, actually people in our professionals were not very much aware of these rheumatological problems. So one day in a hotel, Dr. Vidut and met together and I proposed, Vidut, why not we'll have a association and sensitize our professional people about rheumatology in Odisha, and he agreed. Then at that time I was the personal official to the governor of Odisha. So I sat and drafted everything, how to make an association, and I called all my friends and all my colleagues are also there to be members of their association, and all of them are very, very cooperative. And finally, I formed the association, registered it, and started the activities. We covered almost 2/3 of the districts, moving one district to another, and talking about rheumatology, what are the common problems and how to solve it. And by God's grace, today what you have seen, rheumatology in Odisha, it is at the very high altitude. So again, that's another chapter. So what we are now in the OARC update for, this is really great endeavor by Dr. Jyoti. So the days are gone when people were having the misconception of rheumatology means the disease of joints and bones, but that misconception has gone since long. So rheumatology, this autoimmune disorders can affect any organ of the body. So it's a really very good idea by Dr. Jyoti. Started with dermatology, then eye, then pulmonology, and today regarding the obstetric gynecology, the fertility. Really, it's a very good endeavor, and I wish it's a great success. Thank you.
So now I request our scientific chair, Dr. Prashant Pradhan sir, to tell few words.
Respected dignitaries on the dais and off the dais, and dear delegates. And it is my privilege to welcome you again for this very important meeting of OARC 4, Update 4. And here we have tried the main architect behind the scientific agenda was none other than Dr. Jyoti. And we are fortunate and proud to have speakers starting from the top north till the south. So we will be listening to them one by one. And we have 3 important sessions, and one session is the second session is learning from the legends. So please stay with us and learn from all the sessions. And the last, we'll also have the quiz session by one of the faculty. So with this, I welcome you again for this meeting and hope you will enjoy this meeting. Thank you.
So now I'll request all the dignitaries to help us in unveiling our souvenir today. So now we all are eagerly waiting to listen from our today's chief guest, Padma Shri, Professor Dr. Ashok Mahapatra sir. So without delaying any time, I welcome sir to give his address.
Good morning. Jai Jagannath. Jai Jagannath. Om Namah Shivaya. We are the land of Lord Jagannath and city of Lord Shiva. All the dignitaries in Thais, 3 Mahapatras, 1 Panigrahi, 1 Porida and 1 Pradhan. So I thank all the people here, the organizing committee, to call me as a chief guest. I always felt odd man out, but I don't never see my specialty there, being a neurosurgeon, because they are least interested people. So when I was looking at, hardly people know Lord Jagannath. We are proud of ODIs to know Lord. I don't think we know. When Indradumna came in Satyayuga, he came here from Avantika, which now is Ujjayini. So from west coast of India to east coast, to establish Lord Jagannath in Satyayuga. That is by the advisor Brahma, Vishnu, Brahma. So that is how Lord Jagannath was established in Satyayuga at Puri. This temple is from 1131 to 1168. 2 kings did it, Annangad Bhimadev I and Jajati Kesar II. This is between 1831 to 1868. So we are in the place of Lord Jagannath, and coming to Lord Shiva. When Jammu was coming, Jammu was made to stay at here, Bhubaneswar, because Lakshmi said, you cannot cross Shiva to take anybody from Puri. So nobody is going to die in Puri. So everybody who die at Puri go to Swarga. So they create a Swargodwara. The history says that Puri is Sri Khetra, Shankha Khetra, Jagannath Khetra, Nilachal Khetra, there are 10 or 12 names for Puri. So we are in Lord Jagannath's place. May Lord Jagannath bless you healthy, long and happy life. Why I am telling that? Doctors are more unhappy people, more unhealthy people, more obsessed people. The study by the Lancet shows, as way back 1977-78, doctors live less length of life than an ordinary man because of stress, overwork and immunodeficiency. I think we are more immunodeficient because we are stressed. And for immunosufficiency, you have a peaceful mind, calm mind and a quiet mind. What is done by meditation, pranayam, prayer and all spiritual things. We are very unspiritual people. As WHO define what is spiritualism, know yourself. I am not a body, I am not a mind, I am not bones and skin, I am a soul. I am a soul. So if you know soul science, hundreds of books on soul science. I am not going to tell that. Where is soul? People thought it is in Muladhara Chakra, because you can hear the bowel sounds. Then they thought it's Nebhal Chakra, Manipur Chakra, then Sahasrara Chakra, then over. We don't know where the soul exists. Maybe hypothalamus, maybe centromedian nucleus of thalamus, which connects the hypothalamus. The question is that we don't know what is soul. But we all believe we have a soul. Isn't that correct? Life energy. Lord Krishna says, I am life energy. Enter inside as inspiration and come out as expiration. When I stop, Swargodwara is open for you. Thank you very much. I think when Dr. Mahapatra was talking about 2 stories, let me tell one story. I think you must know this story. It is 1932, Sir Sherrington. How many of you know Sir Sherrington? Sherrington hypothesis when doing the cat experiment, cutting through the colliculus, midbrain, where from the consciousness start. And he got Nobel Prize in 1912. So he was one of the first person who got Nobel Prize for medicine by physiological experiment in cat brain between 2 colliculi, which is midbrain session through the intercollicular level. When he was doing a conference at US, he called Alexander Fleming and also Paul Ellis. How many of you know Paul Ellis? Ellis hypothesis. Have you heard? Pharmacology? No. Paul Ellis said that every disease has a cause. That cause, when you repeatedly give it, it will always generate the same immunological disorder and disease process. And if you treat them, they will cure by same medicine. So the concept is that if you have physical stimulus as antigen, it will produce antigen-antibody reaction. You have manifest and cured. That is Paul's hypothesis. And he was thinking, I don't know if you know, stilbene for the syphilis. And he got Nobel Prize. So when they are meeting together in a dining table in 1932 in US, they were discussing, Alexander Fleming say, all will be cured by antibiotics. Antibiotic has not come. He has just found fungus in bread. And he was working on fungus, how the fungus can kill bacteria. As we know, poison kills poison. Bacteria can be killed by fungi. So he was experimenting the fungi, that is called penicillin. So he said, all disease will be cured by penicillin, and Paul Ellis were telling all disease will be cured by heavy metals. So fighting was so much, Sherrington could not make them understand we can have both compromise and have a dinner. So at the end they did not have dinner, both of them disappeared, and Ellis had to sleep without dinner. So the question is that fighting is always there for betterment. And there are hundreds of fights between Harvey Cushing and Walter Dandy. Both you know. Dandy, of course, you know, and Harvey Cushing. Cushing disease, Cushing syndrome, Cushing triad. Cushing did so much of things that every MBBS student must know. So history is full of stories, interest, classics. Every issue once a year, our neurosurgery journal, which was started in 1942. First journal of neurosurgery started in 1942. That's another beautiful story. I am not going to. The person who started is a pathologist, started neurosurgery journal. Harvey Cushing was operating. He started doing operating a lot of operation, and he had no time to maintain record. So his PA, what is it? That lady was keeping, Louis Eisenhart. Louis Eisenhart is typist, steno. All the record of Cushing were keeping, and Cushing said, I have zero mortality. After any guest came to Cushing, he said, everything I do 100% success. Then after the guest left, the PA will come and tell, sir, you have told lie today. You are no 100% mortality. See, I have record. So he says, Dr. Cushing in his comment wrote, but for Louis Eisenhart, my mortality never became zero. And who became Louis Eisenhart? From a steno, she became MBBS student in John Hopkins. She did MD pathology. She became the neuropathologist of Harvey Cushing, and first meningioma classification of 1930s. Meningioma classification, 1930. It is Cushing and Eisenhart. So that lady who is a steno became MBBS student, pathologist and neuropathologist, and first editor of Journal of Neurosurgery from 1942 to 1960. 25 years he remained as the editor of Journal of Neurosurgery. So let us come back to our own ground. I think I am happy that a lot of people are there. Immunology. We always believe immunology, nothing happens to the brain. Brain is an immuno-resistant organ. Is correct? No. Every disease affects the brain is imbalanced immune system. We did when you are doing a subject of monoclonal antibody targeting therapy in a glioblastoma, about 25 years back, 30 years back, we developed a company developed an anthysen compound, a short chain amino acid called oligonucleotide, anthysen. And you go and see what is anthysen means. We were giving a stereotaxically implanting that compound in the brain glioblastoma, and seeing how much glioblastoma regress. Those days, in late 90s, the average survival glioblastoma was 4 to 5 months, and today we are telling with surgery, immunotherapy, radiotherapy, chemotherapy, average survival is around 18 months, and 5% of glioblastoma survive more than 2 years. A glioblastoma person average only 2% survive more than 5% survive 2 years. So if somebody get a glioblastoma, his future is gone. It is more than maybe medulloblastoma. Today we are telling medulloblastoma curable disease. Many things in the brain, now the glioblastoma has the improved. Question is that immunology. There is no body disease which is created without immune system. How strong we are immunologically. Nowadays, my first choice is not make your stomach dustbin. Improve your health standard, change your lifestyle. Many of you don't get up before 7 o'clock, 8 o'clock. Do not see what is Brahma Muhurta. Days converted to Brahma Muhurta, Deva Muhurta, Mana Muhurta, Dana Muhurta. We read, work, eat in a Rakhyas Muhurta. That means when the negative energy is high. Brahma Muhurta is between 4:30 and 5:30, when the Brahmana get up and arrange everything for puja in the temple. Then Deva Muhurta is 5:30 to 6:30, when every temple everywhere in India has the fast prayer to God or goddesses or whatever it may be. Then comes Mana Muhurta, when the people get up, do their daily activity, and we transmit our negative energy to the system, the Mother Earth. And by 9 o'clock to 12 o'clock, the negative energy pick up. That is the reason why in midnight, Kali Puja, Durga Puja, Tantra Sadhana, Masani Sadhana, whatever sadhana you want, it's all midnight at 12 o'clock because negative energy is high. And Tantra Sadhana, you want negative energy. Now you understand why we tell the children not to read after 9 p.m. When I go to hundreds of schools, colleges, I say, please sleep by 9, get up at 4, read 3 hours, 4 to 7. That 3 hours of reading in the Brahma Muhurta is equivalent to 12 hours of reading. 12 hours. In my life, I don't know Dr. Purna knows or not, my room was next to the dining hall. Everybody came and this is the common room. When I used to read between 5 o'clock or 7 o'clock to 8 o'clock, only 2 hours I have to read, 7 to 8 or 9. I used to sleep by 8:30 and get up at 3 o'clock. Today morning I get up 3:30. The question is that, what do you want in life? A book was written by Swami Chidananda. I don't know how many of you know Shivananda. Any taker? Who was Shivananda? What was he? Boliye, let other people know your knowledge. It is not a question answer session, yet we can make it interesting. That everybody knows. Divine life, Divya Jiban Jyoti. Divya, who was he? Yeah. He did MBBS from Madras Medical College in late 19th century, and he practiced in Singapore and Malaysia and got millions and billions of dollars. He was so unhappy with the money, he said, what I'll do with money? So left the money and went to Rishikesh, because Rishikesh was the gold house, golden money of leprosy, Gantaghar, the mine of leprosy. So he went there and started treating leprosy patients. That is how he went there, and 1925 he went there, 1932 started Divya Jivan Jyoti, and 1939 Chidananda joined there. Chidananda was a very, very rich family of Mysore, and he used to go to school and colleges by car. But when he finished his degree in 1939 or 38, he thought life is so bad. I cannot live this artificial life with nothing natural. So he left his family and went to Rishikesh. He wrote a book called Choice is Yours. If you go to Google, there are about 15 books, Choice is Yours. But you have to tell, Choice is Yours by Swami Chidananda. What he talks in that book? Chapter 5 says, Garden of Spiritual Life. तामने आध्यात्म चिंताधारार बगीचा. Are you happy with adhyatma? No. Going to Jagannath temple is not adhyatma. Doing Shiva putting water. In today, this is all Shravan Mas. We worship Lord Shiva. No. What is Adhyatma? That is what he said, connect yourself to God. That is what he said. First part of Adhyatma is Astha, trust. Trust yourself, self-confidence, confidence on other, confidence on God. So what is the first part of Adhyatma? It's trust. If you don't trust anybody, you cannot be a spiritual human being. Second, service. Service to others. And I will say, a man without service is an animal. A man without service to humanity, if a person cannot do service to another human being, he is an animal. There is no difference in man and animal. Third, so trust, service and devotion. We always say nature. So at least have faith in one God. He could be Allah, Jesus, Buddha, Jagannath, Vishnu, doesn't matter, have one faith, devotion. Then satisfaction. Are you all satisfied? That means contentment. We are all dissatisfied soul. When you school, you want a cycle. When you college, you want a motorcycle. When you are in a medical college, you want a car. No? The demand and expectation is ever increasing. That is Lord Buddha said, the kamanar vinasare dukharkanas. All the cause of suffering is your desire, desire and desire. Where do we end? Where do we end? Sachin Tendulkar used to say, when he made a century, he used to go and have party, have several small or big pegs of whiskey and sleep. And when he gets out at zero, he said, zero give me more impetus to learn. So when he gets out zero, he goes and sits down hours and hours, how the ball came, what was the speed, where it dropped, it is drop in the stump, the offside or onside, and what wrong did he do. And that is what he learned from each failure. What Abdul Kalam wrote? Abdul Kalam wrote about 35 to 36 books. One of the books says, fail means first attempt in learning. Nobody is successful everything. Nobody can ever say he succeeded in every attempt he tried. So we have to fail. But fail doesn't should not make you dejected or depressed. That is what Abraham Lincoln, I don't know what was Abraham Lincoln, anybody knows? How many people have read Abraham Lincoln's life history? When he was contesting vice president, he failed 3 times. He did not get. Because he had come from a very poor family, had no money. And 1860, he contested for president and did not. But by 1865, he became the president of America. The man who came from grassroots level and went to the president of the world by dedication, service, honesty and hard work. So what should we learn from them? Hard work, honesty, dedication. What the success? Success for everybody is knowledge. Knowledge. Without knowledge, nothing can happen. Bhagavad Gita says, Shraddhavan labhate jnanam. New education policy, what is new education policy say? Lifelong learning. If all of you look at the medicine book of Davidson or Love and Belly of 1960s, 70s, will you like to read now? When we are MBBS student in Bahrampur Medical College, chest X-ray and barium, nothing else. Was there anything? Nothing else. So we know we have all learned in the process of our journey. Every day we are learning. All the time we are learning. You are learning without your consciousness. Unconsciously, subconsciously, non-intentionally you are learning. So learn one thing, that have a healthy life. 70 years people are taking 10 medicine. 2 for diabetes, 2 for blood pressure, 1 for constipation, 1 for sleep, 1 for joint pain, rheumatic, joint pain, backache. 8 years, when I take a lot of camp for the senior citizen, believe or not, 70 years people taking 10 medicine. and 8 years you are kind, Lord Jagannath kind, you to survive 80 years, 10, 15 medicine. So do you want to make your stomach a dustbin for a medicine? So I tell general public, don't make your stomach dustbin. My first purpose of sitting in OPD, cut down. Please promise today, we will not write unnecessary medicine. There are doctors who write 3B complex, 2 vitamin D, 1 vitamin D3 with something calcium and nothing, another vitamin D1 with zinc and person. Why? Are you really practicing ethical medicine? Please do something that God prevail in our consciousness, that when we write a prescription, we should be ethical. What ethics says? I don't know how many of you read Hippocratic Oath. Hippocratic Oath says, think every patient is your own relative. Second, do not discriminate poor, rich, king or anything. For a doctor, everybody is equal. Try to update your knowledge up to date. Don't practice MBBS medicine after 30 years. 5, 6, every day try to learn and acquire more and more knowledge. MBBS is only the first step of learning. It's not the end of the learning. A lot of people think after MBBS nothing. And last thing, what you should do in the morning. We did a study at AIMS. First PhD, Dr. Malviya may be knowing, Dr. Nandi had a PhD student in 1976. And when she came, we do not know what to give. So we are having tea, and she entered to our tea room at 11, and we said what to do? Do tea test. So what is tea test? So when she came back second time, what is tea test? So we are sitting there second time. We said, everybody get up in the morning and take tea. So first you put a stomach tube, rice tube, and take out juice. That is fasting gastric juice in the morning. Give 50 ml of raw tea without sugar and black tea without sugar and milk, and do the acid test. What happened? 4-fold rise of acid if you take black tea in the morning in empty stomach. It's like red wine is better or white wine. The false concept has gone that if you take black tea in the morning, it's very good. Tea has a lot of anxiety. I agree, tea is good for health. It has a lot of stable antioxidant, immunology, and it doesn't damage with boiling, adding sugar, but what it harms if you take black tea? It produces very high acidity. Today what the people say in the OPD, I have gas, I have indigestion, I have discomfort, this and that, all are hyperacidity. So don't take tea in the morning. What should you take in the morning? I tell, get up in the morning, 1 glass of hot water, 2 chammach of haldi, 2 chammach of honey, and a lemon. Do you know there are 50,000 publications on the health benefit of haldi in the last 100 years? 50,000 publications. Read golden milk sold in America. I had a patient, I know Dr. Mahanti, who was the first dean at our hospital. He is suffering prostate cancer. His doctor came with 1,000 tablets of haldi tablet from America. And when she came to me, she gave a packet of haldi tablet to me. I said, what gift you came in? He said, it is curcumin tablet for you, gift from America. Do you understand? What a tender, very important gift for me, haldi tablet. That is the significance of yellow gold. We say haldi is yellow gold. Forget your gold, take haldi. If you do this thing, my attending this conference is good that I have told you, don't take tea in the morning, take haldi, honey, and now it is your responsibility to go and read what is the effect of haldi from hair of the head to toenail. Go and read what is the effect on the heart, on the liver, in the lungs, in the intestine, on the bone, in the muscle and joint, and aging and skin. Thank you very much.
So before we close the inaugural function, it is never possible to make the journey alone or single-handedly. I think I must thank my organizing team, Professor Dr. Prashant Pradhan as the scientific chair, Joint Organizing Secretary Dr. Devasis Maikaf, scientific member Dr. Sakir Ahmad, and the only woman power in the organizing team, Dr. Preeti Dubey. Please give a big hand for Preeti because she was instrumental in connecting and coordinating with all the gynec faculties. And at last, my family, who is for the last 1-2 months there with me in this time. So thank you very much. So now officially we end this inaugural function. We'll start the academic schedule. Thank you very much.
Thank you very much. So we begin with our first session. We call it Cells to Clinic. For the first talk of this session, may I request our chairpersons, Dr. Sujata Kar, Professor Dr. Samir Sahu, Professor Dr. Anupam De, to grace the dais and guide us into the first presentation of this session.
Thank you. So we start the first talk of this conference, and to deliver the talk, I will invite Dr. Sundaram TG. He is a DM in Clinical Immunology and Rheumatology, currently Assistant Professor, Department of Rheumatology at PSG Institute, Medical Sciences and Research, Coimbatore. He has done his DM from SGPGI Lucknow and is formerly Assistant Professor in KGMU Lucknow. He is board certified in rheumatology from UK and EULAR certified in MSK USG with the H index of 6, and his interests include connective tissue diseases, fibromyalgia, ILD. So he will be delivering the talk, the first talk, which is how pregnancy evades immunosurveillance, and I will request him to start his deliberation.
Thanks a lot to the organizers for giving me the opportunity to deliver a talk on something which is close to my heart, which is basic immunology. Thanks to Dr. Jyoti for inviting me. Thanks to the words of wisdom from all the guests of honors. Let me begin my talk. This conference theme is basically pregnancy and rheumatology. And before we understand what goes wrong in pregnancy, we need to understand what actually happens to have a normal pregnancy, what is the immunology of a normal pregnancy. So let us start with a historical perspective. So in the 1950s and 60s, there was a belief that the fetus is a parasite. This belief comes from the fact that the birth weight of the fetus was not influenced by the protein status of the mother. Like even if the mother is protein allergy malnutrition, the baby will have enough protein in its body. So even on a low plane of nutrition, the fetus has a claim on the nutrients circulating in the maternal stream. So it was considered a parasite. Even if the mother has nothing, the fetus will take everything. So why does, if it's really a parasite, why does the mother's immune system not fight against it? So we'll see what happens to the maternal immune system, particularly the immune system inside the uterus, how it changes in such a way that it can carry a normal fetus. So before we go into the normal immunology of pregnancy, we need to understand that anything foreign, every cell of our body will have a particular identity card. It is called an MHC. There are two different kinds of MHC, MHC class 1 and MHC class 2, and the MHC class 1 molecules are HLA A, B and C, and the MHC class 2 molecules are HLA D, P, DQ and DR. And then there are a bunch of non-polymorphic MHCs which are not as diverse as the MHC class 1 and class 2 molecules. What is the job of this MHC class 1 and class 2 molecules? See, these MHC class 1 and class 2 molecules will be present in the fetus, and the fetus, will carry genes from both the father and mother. So the fetus will have proteins which are derived from the father and the mother will have only the mother's CD8 and CD4 T cells. And these MHCs carrying proteins will be delivered to CD4 and CD8 T cells. In a normal scenario, what happens in such a scenario? The T cells will attack the protein. But in pregnancy, we don't want the T cells to attack the protein. So what happens during pregnancy? See, this is basic transplant immunology. When there is a transplantation of some tissue from strain A to another organism of the same strain, there is no rejection. But if it is transplanted to a different strain, there is rejection. And what decides that rejection? It is the MHC molecules. If you have different MHC molecules, your tissues will be rejected. But in pregnancy, what uniquely happens is that the fetus will have both paternal and maternal genes, but the paternal, for example, if there is a transplantation of father's tissue into a mother's body, it will be rejected. But if the father's proteins are inside the uterus, they are not rejected. To take that point further, you take the case of surrogate pregnancy, where you have a lady who is carrying the baby, and the baby has a father and mother's genes, and the lady who is carrying the baby does not have either of those genes, but even then it is not rejected by the uterus. So what happens inside the uterus is what we are going to see. So I have divided my talk into 5 sections on immune tolerance in the fetus. Basically, how the maternal uterus does not attack the fetus. First, I am going to look at the role of lymphocytes and NK cells, and then the other tolerogenic features of the uterine decidua, and then the role of IDO, the enzyme indolamine 2,3 dioxygenase, which produces kynurenine, and how it induces the formation of TREGs, and then the other minor pathways which are involved in immune tolerance in the fetus. First, we need to understand that inside the uterus, you have certain number of cells, T cells, NK cells and all those cells, but the predominant leukocyte subtype inside the uterus is NK cells. NK cells are, as you know, they are innate cells, and they are all found in the interface between the external environment and the body, and NK cells are the predominant lymphocytes inside the uterus. And what NK cells do in a normal scenario is they produce a lot of interferon gamma. Interferon gamma activates the JAK-STAT pathway, and the JAK-STAT pathway, when it is activated in a normal cell, it will start the expression of MHC class 2. And for the production of this MHC class 2, there is a transcriptional activator called the class 2 transcriptional activator. So this is how a normal cell behaves when it is exposed to interferon gamma. But what happens in the trophoblast cells, which are basically the placental cells, if you stimulate them with interferon gamma, there is no activation of class 2 transcriptional activator. So basically, if you look at the trophoblasts, which are the placental cells, there is absolutely very less expression of MHC class 2. So there is no activation of CD4 positive T cells, but there is also no expression of class 1 MHC molecules HLA A and B. But if you look at this, there is only expression of some HLA C, and HLA C is not as polymorphic as the other HLA A and B, and so it can activate CD8 positive T cells. But the HLA C activated CD8 positive T cells, they are tolerogenic, basically meaning even if they are activated by the MHC class 1 molecule, they don't become activated, they become sort of tolerogenic T cells which support immune tolerance. And then you've got another kind where the MHC class 1 molecules HLA-C and the other non-polymorphic MHCs, they can be taken up by the APCs in the mother's uterus, and even when they are taken up by the APCs, these APCs don't activate the immune system. They become something called tolerogenic phenotype. So what contributes to this tolerogenic phenotype is this receptors called LILRB. This LILRB stands for leukocyte immunoglobulin-like receptor B, and this supports a tolerogenic phenotype. So the placental cells, the trophoblast cells don't activate the T cells. However they activate the T cells, they become tolerogenic T cells. But more important than T cells is the role of NK cells, which is given in the left side of the figure. I'll get into that in detail. The uterine NK cells are the dominant leukocyte population in the first trimester decidua. Like I said, they are innate immune cells, and so they are the maximum cells in the uterine decidua, and they have something called the tissue residence markers. So if you look at T cells, they are cells which roam around in the body. They have to go from the point of contact to the lymph nodes. They can roam around inside the body, but these NK cells are tissue resident cells. They lie there only, and their job is to lie there only. They don't move around, and they recognize HLA-C and other non-polymorphic class 1 HLA molecules in the trophoblast. And this recognition, see, whatever they recognize, the uterine NK cells, they don't activate immune system, and they are necessary to establish a boundary between the mother and the fetal villus trophoblast. How they do it, I'll explain the next few slides. So basically, NK cells always have a bunch of receptors. Some receptors are activating and some receptors are inhibitory. We don't want to activate the NK cells too much. We don't want to inhibit them too much also. So you need that balance of activating and inhibitory receptors. As you see in this slide, the uterine NK cells particularly have this receptor called NKG2A. Just remember NKG2A, and there is another receptor called NKG2C. NKG2A is an inhibitory receptor and NKG2C is an activating receptor. So there is a balance between activating and inhibitory receptors, with the net result more towards NK cell inhibition. So you have more signaling via NKG2A and less signaling via NKG2C. And then there are other kinds of receptors called killer cell immunoglobulin-like receptors, the KARs. And in the NK cells in the uterus, there is more signaling via the inhibitory KARs more than the activating KARs. The net result is there is NK cell inhibition. But you need to understand that you don't need too much inhibition also, you don't need too less inhibition also. You just need the correct amount of inhibition. So what happens when you have too much activation of the inhibitory receptors? When there is too much inhibition, there is poor cytokine production and poor trophoblast invasion. So you don't need immune activation, but you need just some amount of immune activation so that the placenta has to invade the uterine decidua so that it gets the nutrients. So you don't need immunity, but you need that invasion. When there is weak inhibition, you have too much cytokine production and too much remodeling, too much inhibition. What happens when there is this imbalance between the two? You get these two extreme conditions. So in normal pregnancy, which is there in the middle, you'll find that the trophoblasts are invading the matrine. So the spiral thing is called the spiral arteries. The trophoblast has to invade the spiral arteries so that it gets the nutrients. What happens when you have too less inhibition? This does not invade. So you get into a condition like preeclampsia or intrauterine growth restriction. But when there is too much of cytokine production, too much of invasion, you get a condition called placenta accreta. So like everything in life, you need that balance so that the trophoblast correctly invades the uterus but does not stimulate the immune system. Similarly, next, coming to the other tolerogenic features of the decidua and the first trimester, the other factors which make the uterus a place where the immune system is not activated. And in addition to the NK cells which are present in the uterus, you also have some T cells, but all these T cells will have immune inhibitors, immune checkpoints like the PD-1 molecule, which can bind with its ligand, the PD-L1, which is expressed in the trophoblast in the placenta, and that basically causes inhibition of the T cells, and these inhibitory T cells later become into T regulatory cells. So you have a lot of T regulatory cells in the decidua, and the T regulatory cells are the kind of T cells which are not inflammatory. So they cause a lot of immune suppression through the expression of this immunosuppressive cytokine called TGF-beta. And then there are other tolerogenic features in the decidua. Most importantly, there is the activation of a prostaglandin pathway. So prostaglandin pathway can produce a lot of inflammatory mediators as well as immunosuppressive mediators. If COX-1 is activated, you get a lot of inflammatory mediators like PGF2, leukotrienes, thromboxanes and lipoxins, which are inflammatory, but it activates the immunosuppressive COX-2, where there is the production of PGE2, which is a immunosuppressive. What causes the production of EGE2 is the HCG, which is produced by the placenta. Similarly, You would have all heard about the mechanism of methotrexate, how methotrexate stimulates the production of the immunosuppressive mediator adenosine. It does so by two enzymes, CD39 and CD73, which are basically converting ATP to ADP to AMP to adenosine. The same thing happens inside the uterus also. The uterine NK cells express CD39, which converts ATP to ADP and then to AMP. And then together with the CD73 expression in the trophoblast, it converts AMP into adenosine. And adenosine, as you all know, has immunosuppressive properties. So these are all the factors inside the uterine decidua which causes an immunosuppressive phenotype. But you don't want too much immunosuppression also. You need just the right amount of inflammation so that there is invasion of the trophoblast into the uterus. And then there is a role of this enzyme called indolament dioxygenase. You would have all known that tryptophan is an essential amino acid, and essential amino acids are very essential for rapidly proliferating cells, and the leukocytes are all rapidly proliferative cells. And the uterine decidua, the placenta, produces this enzyme called IDO, indolemin 2,3 dioxygenase. And what it does, it converts tryptophan into N-formyl kynurenine and various other kynurenine compounds. And these kynurenine compounds basically deprive the rapidly proliferative cells of the essential amino acid tryptophan, and so they are toxic to cells. So all the T cells and B cells are reduced in the uterus. It has other effects also. Basically what this kynurenine does, it acts on the AHR. AHR is aryl hydrocarbon receptor, and this aryl hydrocarbon receptor activates this transcription factor for FOXP3. And as you all know, FOXP3 is a transcription factor for T regulatory cells, another way in which there is immunosuppression inside the uterus. And the DCs which start expressing this IDO, they become something called tolerogenic DCs. DCs, as you all know, are antigen presenting cells. Their job is to activate the T cells. But the DCs which express this indolemin 2,3 dioxygenase, they become tolerogenic DCs. Basically, they are DCs with a lot of immune checkpoints, CTLA4, PD1, LAG3, TIGIT. These are all immune checkpoints which basically don't become a naive T cell from becoming a good inflammatory effector T cell. They all become T regulatory cells, further causing immunosuppression inside the fetus. And then coming to the role of Fas ligand Fas pathway. This is one of the pathways of extrinsic apoptosis, and this Fas ligand is highly expressed in the trophoblast of the placenta, and this Fas pathway, Fas receptor is expressed on the lymphocytes, and basically what it does, activates the extrinsic pathway of apoptosis through the FAD, Fas associated death domain, death inducing signaling complex, and basically cell death. But like I said, how the NK cells works, you don't need too much inhibition, you don't need too less inhibition also, you just need the right kind of inhibition. Similarly, the Fas ligand Fas pathway also should not be activated too much. It is somewhat needed for the invasion of the placenta into the uterus, so that successful pregnancy continues. And then there is this process of sialylation. You would have read this process of sialylation in the context of complement regulation. So basically all your surfaces, the human surfaces have a lot of proteins, and these proteins have some carbohydrate moieties attached to them. If you look at bacterial surfaces, you have a lot of mannose moieties which are attached to the lipopolysaccharide, which causes complement activation. In human surfaces, attached to the proteins, you have sialic acid moieties. These sialic acid moieties present in the uterus are alpha 2,3 linked sialic acid and alpha 2,6 linked sialic acid. What this sialic acid does is brings in a complement regulatory protein called the factor H. And the factor H is an regulator of the alternate complement pathway. So what has been found is that the uterus which lacks sialylation, it causes activation of the alternate complement pathway, and it causes developmental failure. So basically, if you understand what happens in a normal pregnancy, what is necessary for the sustenance of a normal pregnancy, for the invasion of placenta into the uterus, only then you will understand what happens in a failed pregnancy. Similarly, the placenta also acts as an immunobarrier by producing chemokines. Chemokines, as you all know, they are needed for transfer or the movement of immune cells. And the uterine placenta has something called D6, which is a chemokine decoy receptor. So basically, whatever chemokines come, they are sequestered, they are scavenged in the uterus so that they don't bring in the actual inflammatory lymphocytes. And also there is histone methylation of various genes, various chemokine genes by epigenetic silencing. All the chemokines are suppressed in the uterus, so you don't have the invasion or the movement of inflammatory T cells, B cells into the uterus. And then, as we all know, when we are reading about drugs and what drugs to give in pregnancy, you would have heard that certain drugs don't cross the placenta, so they are safe to give in pregnancy. Certain drugs cross the placenta, so you shouldn't give them in pregnancy. So basically what happens here, the same process happens for T cells and B cells as well. The placenta acts as a cellular barrier. What has been found is that inside the fetus, if you analyze the fetus, inside the blood you will find a lot of cells. The mother's heart cells, the liver cells, kidney cells are found inside the fetus, but the T cells and B cells are not found inside the fetus. What happens? The placenta acts like a physical barrier, limits the transmission of semi-allogenic fetal AGs into the mother. And also it acts as an immunoadsorbent. What happens, like, you know what happens in the anti-Rho syndrome, where the anti-Rho antibodies enter into the fetal heart and cause congenital heart block? In a normal fetus, what happens? The syncytial trophoblast layer, it acts as an immunoadsorbent, basically blocks all the antibodies at the syncytial trophoblast level so that these antibodies don't enter inside the fetus and cause damage. So the placenta passively restricts the movement of cells and also actively blocks these cells by acting as an immunoabsorbent. So to summarize, pregnancy is an immunological paradox. The fetus has the father's and the mother's genes, the father's and the mother's proteins, but the mother has only the mother's proteins. So in an ideal scenario, the mother's immune system has to reject the fetus, but that does not happen. This is because of the unique features of the maternal fetal interface. Like I said, the NK cells, the Treg cells which are present in the uterus, and the interface between the fetus and the uterus helps achieve a normal pregnancy. And imbalance of all these factors, we all know APLA and anti-Rho, which cause a lot of pregnancy loss, but a lot of these features, what happens to the T regulatory cells, what happens to the complementary proteins, what happens to the NK cells, is very less studied, and maybe it contributes to a lot of unexplained repeated pregnancy loss. Once again, I thank the organizers for giving me this opportunity. Thank you.
Thank you so much, Dr. Sundaram, for your excellent talk on this age-old question for which we still don't have all answers. I'm sure there are quite a few questions because of lack of time. We'll allow maybe one or two questions from the audience, if any. Otherwise, even I have lots of questions. If there are none, I'll just ask quickly.
Yes,
so, tolerogenicity of the decidua was one of the major ways in which the fetus, manages to invade. But what about ectopic pregnancy? From that we know that fetus can implant almost anywhere in the body. How do we explain that?
Even in ectopic pregnancy, there is a placenta that forms, right, ma'am? It is the trophoblast cells which basically do all the work. So if it is in the uterus, then it is because there is proper invasion and all those things, this works perfectly. But in ectopic pregnancy, this does not happen properly, ma'am.
Yeah. So why are we calling it tolerogenicity of the decidua? We can call it because ultimately it's the fetus who's driving.
The majority of the work is done by the placenta, ma'am.
Yeah.
But it is the combination, but the stimulus has to come from the decidua, ma'am.
Okay.
Yeah.
So anyway, I guess which means, yeah. And also for the failed pregnancies, do we have any immunological or any biomarkers which can tell us that this pregnancy is likely to fail?
The pathological aspect of it will be discussed in detail in the further slides. My job was to just explain the basics. What happens in a normal pregnancy and what could go wrong possibly that can lead to repeated pregnancy loss.
Yeah.
I think the whole today's session will be about that.
Yeah. So the 90% or 100%, is it the fetus who's driving its own, invasion, or maternal role also is there?
Yeah, the stimulus has to come from the maternal thing, ma'am. Okay. But it is majority of it is the uterine site which helps it, and a lot of the immune tolerance of the fetus is driven by the syncytial trophoblast cells, the cytotrophoblast cells. Like I said, EVT, extravillous trophoblast cells. These are the ones which promote immune tolerance.
Thank you. Thank you for the excellent deliberation, and it has set the stage for all the topics to follow. And I'd say that this pregnancy, which we take it for granted, actually it's a very complex process of immunological tolerance, because 50% of the DNA comes from the father, and in spite of that, this immunological tolerance, which is a very complex process, as explained very nicely by Dr. Sundaram, and there is this placenta which is both a physical and immunological barrier. The basic is that the placenta is both physical and immunological barrier, and a lot of cells in the trophoblast, they act as modulator, like say they modulate the expression of the MHC1, MHC2, and also the NK cells are modified, and a lot of hormones like even the progesterone and the estrogen, they also play a great role in this immunological tolerance. So nice, that's a wonderful deliberation. Thank you for that.
Yeah, okay. Thanks a lot.
Thank you, sir. Thank you, ma'am. Thank you, sir. May I request our speaker and chairpersons to please move towards the poster for the felicitation. May I request our esteemed speakers to felicitate our chairpersons, and our chairpersons to please felicitate our speaker. Meanwhile, we are proceeding for the second talk. May I call upon stage our chairpersons, Professor Dr. L.K. Meher from Some Hospital, Professor Dr. Sanjay Jangid, HOD of Medicine Department, High Tech Medical College, and Dr. Sandeep Kansukar, Consultant Rheumatologist from Pune, to guide us through the second presentation.
Good morning, everyone. Now, after understanding the basic immunology of pregnancy, we come to the next topic, that is when immunity meets femininity. This is another very interesting topic, and the clinical lessons and perspective of it, and it has to be dealt by Dr. Monica Gupta and Dr. Preeti Dubey. May I invite the speakers, please? Dr. Monica Dubey is now working at AIIMS Delhi for last 12 years. He is the clinical examiner for MRCOG Part 3 specialist in infertility and laparoscopy, first super specialty DM reproductive medicine from AIIMS Delhi, Lilavati Salvan Booker Prize for outstanding research during MD at AIIMS, and there are so many accolades to her credit. She is the reviewer for Journal of Obstetrics and Gynecology +1 and Frontiers of Reproductive Health. Now, Dr. Gupta, please.
Thank you, chairpersons, for the warm welcome. And I would like to thank Dr. Jyotiranjan Parida, the organizers, and the esteemed dignitaries here to give me the opportunity to present our experience. So this is just to start the session. We wanted to share with everybody our experience of managing the patients with various autoimmune rheumatic disorders who presented to us either during pregnancy or with infertility or for preconceptional care, and how we managed them through pregnancies and what outcome we had for these patients. So, as we know, these rheumatic diseases predominantly affect women, and mainly during the reproductive years, these diseases are more common. Hence, these autoimmune rheumatic diseases have implications for pregnancy, for fertility, and also there is effect of autoimmunity on pregnancy. Hence, the clinicians are worried when these patients present to us. So this was a series which is an ongoing cohort study of patients of various autoimmune rheumatic diseases who presented to us, and most of these patients were referred from Odisha Arthritic Rheumatic Center by Dr. Jyotiranjan Parida. And at present, we have 13 patients who have already successfully completed treatment with us. So between 2022 to 2023, these patients presented to us, and a detailed evaluation was done regarding the disease activity when these patients were in remission and when they were on drugs which were compatible with pregnancy and childbearing, and after assessing their cardiovascular, kidney function, and all the autoimmune tests, these patients were then started treatment for infertility, either with ovulation induction or in vitro fertilization, and then these were followed during pregnancy through delivery, and the fetal outcome was also assessed. So among these 13 patients, we had a wide variety of patients of Sjogren's syndrome, SLE patients 5, myasthenia gravis patient, and very interestingly, we had 2 patients of ankylosing spondylitis. Both of these patients had undergone bilateral hip replacement, and both of them were more than 40 years of age. We had patients of mixed connective tissue disorders, we had patients of systemic sclerosis and rheumatoid arthritis. So among these patients, the infertile patients, 3 of them were treated with in vitro fertilization, 1 conceived with ovulation induction, and 1 patient who was elderly, more than 40 years age, conceived spontaneously. 4 patients presented in early pregnancy because they were really worried about the pregnancy, how it would go. And 4 had come for preconceptional consultation because they had a previous history of spontaneous miscarriages and bad obstetric outcome. 1 patient was concerned because she was on azathioprine and she was really worried that is it possible to continue pregnancy with azathioprine? What will be the effect of azathioprine on breastfeeding? So among the patients who had undergone IVF, 1 was of Sjogren's syndrome who underwent IVF with her own eggs. The other was of ankylosing spondylitis. Since she was elderly, more than 40 years of age, her ovarian reserve was poor. She underwent a donor oocyte IVF, and another patient also had donor oocyte IVF. And 1 SLE patient conceived with ovulation induction, and 1 patient of ankylosing spondylitis, again with bilateral hip replacement. Although she was more than 40 years of age, but with some assisted medication, she conceived spontaneously. So the mean age of all these patients ranged between the mean age was around 30, and the age range were between 21 to 42 years. The anti-Mullerian hormone, which is actually a hormone which signifies the ovarian reserve, was on the lower side in most of these patients, and the mean anti-Mullerian hormone was 1.36, where we say that more than 1.5 signifies a normal reserve. Most of these patients had a disease duration of more than 6 years, with the range of the disease being 2 to 12 years. So among these 13 patients, we have got successful pregnancy outcome in 90% of these patients. So 12 patients have successfully delivered with us, and the mean gestation at delivery successfully we could carry all of them till term around 36 to 37 weeks, and the mean birth weight of these of the babies was also more than 2 kg of all these patients, except 1 patient of SLE who had a twin pregnancy, and she went into preterm labor at 34 weeks. So as we can see, all these autoimmune diseases are known to harbor other autoimmune factors like hypothyroid. So most of our patients, more than 50% had associated hypothyroidism. 23% of our patients had anti-Ro, anti-Lo antibody positive, but fortunately none of them had a heart block. Fetal echo was normal for all of them. Only 15% of patients had antiphospholipid antibody positive, and they were given ecosprin, and low molecular weight heparin were needed. Among the complications that they had in pregnancy, only 1 patient developed cholestasis of pregnancy, 1 developed gestational diabetes, and 1 had genital warts in pregnancy. 1 patient of Sjogren's syndrome, she developed a very severe frozen shoulder, and then she was treated with intra-articular steroid injection. Some of these babies had growth restriction which was mild and mild oligohydramnios, but none of these patients importantly had disease flare in pregnancy because all of these patients continued with the anti-rheumatic drugs that were compatible with pregnancy. So as we know that there are drugs like mycophenolate mofetil and methotrexate which are contraindicated. So some patients who were on these drugs were stopped 3 months prior to pregnancy. Almost all of our patients were on hydroxychloroquine, sulfasalazine and steroids which were continued during pregnancy. They were monitored for their blood sugars, and only 1 of them developed gestational diabetes. 2 patients who were on azathioprine was continued during pregnancy and during breastfeeding. For 1 of this patient who continued azathioprine during breastfeeding, the baby had some recurrent lung infections and pneumonia and had repeated admissions, but at 2 years of age now the baby is doing quite fine. One patient of ankylosing spondylitis was also on an injection anti-TNF alpha inhibitor adalimumab, and this was continued during pregnancy because it was required. After review of literature, it was considered to be safe, and it was also required to prevent disease flare in this patient of ankylosing spondylitis. So this was our first patient of Sjogren's syndrome who underwent IVF with us. She was 35 years. She was on HCQ, sulfasalazine, deflazacort, and she had a very long duration of infertility with failed infertility treatment in the past. But because of her Sjogren's syndrome, she could not continue with further treatment of infertility because she had so much of pain. She had to undergo all these treatment. And then when she came to us, she was already more than 35 years with a borderline ovarian reserve. And after extensive counseling, because finances is also a lot of issue for these patients, already they are spending so much on the treatment, but she was counseled for IVF, and successfully she conceived in the first cycle of IVF, and she delivered a healthy baby. These are two more interesting cases of ankylosing spondylitis because both of these patients were more than 40 years of age, and both of them had such severe ankylosis of hip that both of them had undergone bilateral hip replacement, which is again very unusual because when we reviewed literature, there were many cases of patients who had bilateral hip replacement during pregnancy, but none of them of ankylosing spondylitis had bilateral hip replacement, and that too at more than 40 years of age. So we were really worried what effect will pregnancy have on the replaced hip, whether they will be able to continue with the pregnancy successfully or not. But one of them was persistent for IVF. She was more than 40 years of age, and she underwent IVF, donor cycle IVF, and she successfully had a cesarean at 38 weeks with a 2.5 kg male baby. The other patient was also 40 years of age with very diminished ovarian reserve, but she conceived successfully, spontaneously with some assisted treatment. And then the adalimumab injection for her was continued during pregnancy. She also continued till term at 38 weeks and successfully had a 2.6 kg baby. So as I said, we did not find any case reports on pregnancies in ankylosing spondylitis with bilateral hip replacement. We have had patients in case reports of young patients who have undergone hip replacement with rheumatoid arthritis or dislocated hip or avascular necrosis, which have been reported in literature. So that is why this series is unique. Also, can this disease affect the males and male infertility? Again is a question. So we have a male patient of ankylosing spondylitis who has a 1-year duration of infertility. This patient also has a history of spinal TB, has taken ATT, but this patient was on sulfasalazine for ankylosing spondylitis, and sulfasalazine is known to affect the sperm count and sperm motility. And when the patient presented to us with infertility, when we analyzed the semen, we found that initially the sperm count was quite low, and when the patient was on treatment with sulfasalazine, the patient was azoospermic. The repeated sperm analysis did not reveal any sperm count. We discontinued sulfasalazine, and 1 year later, when we again reanalyzed the sperm count, we found that we could find few motile sperms, and now the patient is presently undergoing treatment. Also the follicle stimulating hormone, which if it rises, then it signifies that the sperm count will reduce. This also reduced after stopping sulfasalazine. So these were our cases which we successfully managed, and as it is very important that these patients are at risk of infertility and subfertility because of the anti-rheumatic drugs, because of the treatment, prolonged duration of treatment, and ignorance of both the patient and the physician that can this patient be successfully treated with the infertility medications. So it is very important that individualized management is done for these patients depending on the disease type, and also the physician should not fear in referring these patients because medically assisted reproductive technique is safe for these patients if these patients are in remission and they are allowed to continue the anti-rheumatic drugs which will prevent the disease flare in their pregnancies. Thank you so much.
Dr. Monica. So we'll take questions after the next talk. So ladies and gentlemen, let's welcome Dr. Preeti Dubey for the next talk. She is a founder secretary of Society of Fetal Medicine Odisha chapter, and she currently works at Odisha Fetal Medicine Center. She has received multiple awards. She is the recipient of Amrendranath Dan Prize for Best Paper in Maternal and Child Care by Foxy in 2012. and she's first to start fetal medicine as a subject in state of Odisha. We warmly welcome you, Dr. Preeti. My stage is yours.
Thank you, sir, for the warm introduction. Respected all dignitaries, a very good morning to all of you. This is a clinical lessons and perspective when immunity meets femininity. Immunity doesn't meet femininity only, it goes and traverses to the fetus as well. Our previous speaker, Dr. Sundaram, has explained how the fetus protects it. So studies have shown that women are 8 times more likely to get autoimmune diseases such as multiple sclerosis, lupus, and rheumatoid arthritis in compared to men, which they are very prone for cancer. The pregnancy is a compensation hypothesis, suggests that evolution shaped men's and women's immune system differently. And so, in pregnancy, the placenta and the pregnancy are immunologically invasive and the women bear them. This makes our immune system different from man. And basically, women's immune system evolved to facilitate their survival during the presence of an immunologically invasive placenta and the pregnancy to compensate so that they could also survive the assault of parasites and pathogens. So I'm taking to a very important condition that is known as congenital heart block, which is very common in pregnancy with antero-antilla positivity. This is a rhythm heart abnormality. This is the normal conductive system of the heart that we all are aware of. And this is the normal sinus rhythm. That is, the heart rate between 110 to 170 or 180 is taken as normal heart rate, and the rhythms has to be normal. So this is a pulse Doppler mode, and this is the M mode Doppler, which shows the heart rate of 139 beats per minute. That is the normal rate. So this is a retrospective study from 1/1/2020 to 1/1/2025 at Odisha Fetal Medicine Center. We got 23 referrals for fetal bradycardia. So the 2 cases when we got, it was diagnosed in the first trimester. So the first trimester bradycardia is more likely to be genetic and not autoimmune. Rest 21 cases were diagnosed in the second and third trimester. Out of those 21, 1 was twin and 20 were singleton pregnancies. And out of 21, when they referred and came back to us, 1 had intrauterine fetal death with gross effusion. There was ascites, there was pericardial effusion, and the baby was landed in intrauterine fetal death, where we could not find the exact cause. 6 had no evidence of bradycardia. That we need to remember, that even if the patient is referred for bradycardia, there was no evidence of bradycardia, and that could be secondary to probe pressure. The amount of probe pressure can cause vagotonic effect, and which lead to fetal bradycardia, which are always transient. And 7 were associated with other cardiac abnormalities. So as Dr. Monica has previously told, that whenever we are getting a case of bradycardia or antero-antilla positivity, in those patients, fetal echo is a must to rule out any associated malformation. So including, so 7 had associated cardiac abnormalities, and 1 fetus out of that developed hydrops fetalis. The most common heart defect we found is left atrial isomerism, in which the right side of the heart is dominated by the left-sided heart, and so this mechanism does not work properly. 7 had true bradycardia with rhythm abnormality. So what is the normal causes? That is due to pressure over the maternal abdomen, cord compression, sinus node dysfunction, or infiltrate cardiomyopathies. These are the very common causes. What lead to fetal atrioventricular block is either it could be associated with the structural heart defect, like I told, as more commonly seen in left atrial isomerism, or it could be related to the presence of the maternal antero-antilla positivity, that is immune-mediated AV block. So out of those 7, all are offered for anti-La antibodies, and out of which only 4 pregnant women, they have done the test, and 3 of them were positive out of them. And 3 of them, they denied the procedure. They have not done any further testing. So out of those 7, the 1 baby had premature atrial ectopic, 1 baby had first degree AV block, 3 babies have second degree AV block, and 2 babies have complete heart block. So if the baby presented to you with complete heart block, it is actually very difficult to salvage those babies. So this is a 39-year-old G2A1, previous baby terminated at 12 weeks of pregnancy, cause not known. KT was done for the parent and it was found as normal. She was anti-nuclear antibodies negative and she had bradycardia. The bradycardia was having a normal sinus rhythm, so we called the patient, we saw the patient after 2 hours to rule out transient bradycardia and it got corrected. So next is this is the one case which has blocked atrial ectopic. Can you see this is the ventricular flow and this is the atrial flow, and in between the atrium and the ventricle there lies the small a, which is the nothing but the premature atrial ectopic. I'm not going to go for the management, and thus 3 babies has 2:1 AV block. That with 1 ventricle beat, there are 2 atrial beats. So they are 2:1 AV block. Out of those 3 babies, all are doing fine. 1 had pacemaker and 2 were normal. Now they are 1.5 year and 3-year-old and they are doing well. So to conclude, sinus bradycardia is the most common type of bradycardia, secondary to probe pressure or cord compression. So whenever in clinical practice you see the bradycardia, please ask the patient to wait for some time and then redo the scan to see whether it is a persistent bradycardia or it is only due to probe pressure. Second is fetal echocardiography is the must to rule out structural malformation. As we all know that LAI and the tetralogy of Fallot, there are so many conditions which has AV discordance, atrioventricular discordance can cause fetal bradycardia. So we need to rule out by doing fetal echocardiography. If bradycardia is confirmed without any structural anomalies, conduction defects should be suspected, and then we have to classify the types. Team approach, that is obstetrician, rheumatologist, fetal medicine specialist, and the pediatric cardiologist to manage the cases successfully. Thank you for your patience hearing. So usually after this, when there is congenital heart block, if we don't treat the baby, then it will land up in hydrospitalis and they can lead. No, no sir. Few people. Yes sir. That we don't know. No, sir. So actually what is there, whenever we receive a patient with bradycardia, we send for this ANA profile, complete ANA profile, and then we look for if there is a positivity of anti-Rho, anti-La antibodies, and accordingly we treat them. If it is not there, then what is the possibility of again developing this same complete heart block in the subsequent pregnancy? Is it more or less or even same? Definitely more, because they are telling if there is a one case with congenital heart block, the next case again the baby is going to affect more because the antibodies have increased at the subsequent pregnancy. So in those cases when we found that there is SSA and anti-Rho, anti-La positivity, prior to pregnancy only we are referring them to rheumatologists and we begin all the medications from the beginning before conceiving the pregnancy.
Yeah, Dr. Panigrave, please.
Okay, my question is to the previous speaker. So in case of that ankylosing spondylitis, you are given adalimumab. Okay. Adalimumab is not contraindicated in pregnancy. It is safe in pregnancy, but as far as possible, it should be avoided in the third trimester of pregnancy. There are many studies who have showed that there are problems of growth retardation and also more of immune suppression in the fetus. So you should have taken at least you should avoid the live virus vaccines in the first 6 months of for the baby. So these are some disadvantages. What is your opinion on that?
Yes, sir. So we had continued the adalimumab for the first 2 trimesters. In the last trimester, we had discontinued, and we had monitored the pregnancy for the growth of the baby. And fortunately, and we also reviewed the literature, sir. So there is very small increase in the risk of any congenital malformation with adalimumab. And plus, it was required to continue for this patient, especially because the other patient of ankylosing spondylitis was not on any treatment. She was only on painkillers prior to pregnancy, and during pregnancy, she did not require that also. So that patient was not on any treatment, but this patient required her to continue. That is why it was continued. Otherwise, we would not have started. And Dr. Jyoti will say more further about this patient. But
Dr. Malviya will be touching on that. Thank you.
Thank you, sir.
For next question, Manoranjan sir, please.
So what I have learned from this, sinus bradycardia is the most common arrhythmia found in newborn. You have to exclude cord compression and cord compression as well as compression to mother's womb, I think. And after that, you have to do the 2D echocardiography to rule out any congenital abnormality. Third thing, then you will classify. Now, what is the time we will do anti-Ro and anti-La antibody, and whether you want to exclude some inborn errors of metabolism. Most important also inborn errors of metabolism, congenital hypothyroidism, and some other metabolic disorders also can cause fetal bradycardia or conduction abnormality. Is there any idea about that?
Torch infection, some torch infection can, CMV and those can cause heart block. But mostly these autoimmune disorders, if they have associated anti-Ro, anti-La antibodies, then not all will develop heart block, only 2 to 3% will develop heart block, because these antibodies are known to cross the placenta, and then they go and block the conduction defect by causing elastosis in the AV pathways. So it is not known in which patients, in which babies these antibodies will actually go and affect the heart. So it is not in all pregnancies that these antibodies will go and affect the heart. But if there is a history of previous heart block, then there is more chances, around 16 to 20%, that in the next pregnancy they will have a higher chance. There is a higher risk of getting a baby with heart block if it is anti-Ro, anti-La antibody positive. Right, ma'am?
Yeah. Dr. Preeti, based on your experience, would you recommend a first-time pregnancy with pre-existing Ro antibodies to go for fetal echocardiography? We know the incidence is very low, but based on your experience, would you recommend everyone who is having Ro antibodies to go?
Definitely, sir.
Oh, fine.
So even though they are taking treatment prior to conception, then also we would like to do fetal echocardiography at 22 to 24 weeks. Sir.
Okay, sir. I think this is a take-home message for the audience here. Thank you very much, Dr. Preeti and Dr. Monica, for the session. Thank you.
Thank you, sir. Thank you, ma'am. May I request our chairpersons and speakers to move towards the felicitation arena. For the next talk, may I request Professor Dr. Saubhagya Kumar Jana, HOD Gynecology, AIIMS Bhubaneswar, Dr. Jasmeena Begum, Faculty at AIIMS Bhubaneswar, Dr. Debashish Patro, Pediatric Rheumatologist from SOM Hospital, to kindly steer us through the next talk.
Next, we will move on to next lecture. That is impact of anti-Ro antibody in fetal heart development and complete heart block. Screening, management and screening in complete heart block. And I will invite Professor Dr. Ruchika Goyal. She is Professor Clinical Immunology and Rheumatology from CMC Vellore. She has lot of publications in her credentials. Her contribution in textbook chapter, Takayasu arthritis, in textbook of systemic vasculitis, and she has lot of awards for her credential. Madam, welcome to you. And stage is yours. You can start.
Good morning, everyone. Thank you for the kind introduction. I would like to thank the OARC and its organizing committee, the scientific chair, Dr. Prashant, and Jyoti, for inviting me for this talk. So I think we have had a prelude discussion just prior to this on this particular topic. So let's just crack on. So I will start with the story of a patient. So this is like a 26-year-old lady who was recently married, and she presented with on and off arthralgias. So obviously we did ANA profile, which came as high titer anti-SSA, Rho60 positivity. So she wanted to plan pregnancy. So the questions are, of course, will there be any problems during pregnancy? And if at all, what are the medications or preventive measures that can be done? Mind you, she was planning for the first pregnancy. So that brings us to what is the impact of anti-SSA, or what anti-SSA essentially, it has two important epitopes against which these antibodies are directed and are of relevance to us, that is anti-Rho60 and anti-Rho52. So what is the impact? So the spectrum actually, 1% of the pregnant mothers, if you look at all the pregnant ladies, 1% of the pregnant mothers will have anti-SSA positivity, out of which only 25% of them will be presenting with autoimmune rheumatic diseases. The rest of them will be incidentally picked up during their routine investigations. So what is the implication? Basically what we're talking about is the neonatal lupus. So neonatal lupus can be non-cardiac manifestations, which is beyond the scope of this talk, and the other one is the cardiac manifestations. So among the cardiac neonatal lupus, the 80% of them present with essentially the abnormality in the conduction system because of the fibrosis of the AV, atrioventricular node, or SA node, or the Purkinje fibers. And 20% of them will have extranodal cardiac injury, which is characterized by anywhere ranging from myocardial inflammation, endocardial fibroblastosis, dilated cardiomyopathy as a direct injury to the myocardium, or some may present with just AV valve insufficiency. So if we look at the strength of association between, or the pathogenicity of antibodies, then actually anti-Rho52 is the maximally associated with, it has got the maximum impact, followed by anti-Rho60, followed by anti-SSA, anti-SSP, which is popularly known as anti-LA. And rarely nowadays the spectrum is expanding to even UNRNP antibodies. So this is the order of the impact of antibodies or association of antibodies with the congenital heart block. If these antibodies persist together, for example, if you have anti-Rho62, anti-Rho60 and SSB together, then the chances more that the fetus is going to develop the heart block. So as we have already discussed, that among these patients who are positive for any of these antibodies, especially anti-SSA, so 1 to 3% of the fetuses have a probability of developing cardiac abnormality. And this most often occurs between the 18 to 24 weeks of gestation. Sorry. What happened? It's moving on its own. Oh. All right, so approximately 1 to 3% of them develop cardiac abnormality, and which is major chunk of it happens between 18 and 24 weeks of gestation. That is the time when the the maternal antibodies have the maximal transplacental passage. Out of these, what is the outcome? The outcome is up to 29% of fetuses, they experience intrauterine death. And around 60% of them, they require pacemaker implantation at birth. And what is the chance of recurrence? As I think we were discussing, so I'll just say, if a mother has a history of delivering a baby with congenital heart block, then the chance of recurrence in the subsequent pregnancy is up to 18%. Should I wait or continue? Okay. So how does it occur? So this is essentially the pathogenesis. So when we look at the pathogenesis, actually we have the presence of anti-SSA or anti-SSB antibodies in the mother. So what do these antibodies do? The fetal cardiomyocytes have a unique property of increased susceptibility to apoptosis as compared to the adult cardiomyocytes, which are not so very susceptible to apoptosis. So when these apoptotic cardiomyocytes, when they die, what do? They basically externalize or express on their surface the antigens. And these antigens are essentially Rho antigen, La antigen, and so on. So when these antibodies form immune complex with these Rho antigen, which is present on the apoptotic cardiomyocytes, what it leads to? It leads to the activation of macrophages. These macrophages, they produce a lot of pro-inflammatory cytokines by the virtue of various TLR activation and so on and so forth. And these cytokines ultimately lead on to basically conversion of the cardiac fibroblast into myofibroblast, which leads on to scarring of the tissues, essentially the AV node, followed by SA node, and followed by the interventricular septum. And when this fibrosis occurs, it leads on to calcification and thus leads on to the conduction abnormality. The second proposed mechanism is that the cardiomyocytes, they themselves release the type 1 interferon. Now these type 1 interferons can be stimulated, the cardiac myocytes are cardiomyocytes as well as the macrophages. They can release type 1 interferon, which can be stimulated by various insults, including the, as we just discussed, torch infections like CMV. So what happens? These type 1 interferons ultimately cause more apoptosis of the cardiomyocytes and leads on to activation of macrophages, which again leads on to the insult. Now the third proposed theory, which is relatively recent, is basically what they found is that among the antigens which are expressed on the apoptotic cardiomyocytes, they found that it was not anti-Rho52 antigen. Sorry, Rho52 antigen was not the major antigen which was present on cardiomyocytes. So what happens? Then that means you do not have the immune complex formation. So there has to be an alternative mechanism. So what is the alternative mechanism? What they found across various studies, which includes the immunohistopathological studies, the mice experiments, in vitro experiments using fetal cardiomyocytes, is that there is a possibility that these antibodies, they cross-link with another antigen which mimics Rho60 or Rho52. So these actually, the antigens which were found was essentially, the target was the calcium channels. So they found is that these antibodies actually they directly inhibit the certain isotypes of the calcium channels on the cardiomyocytes, which is responsible for inhibition, which is responsible for the cardiac conduction. So when these calcium channels are inhibited, it leads on to loss of aberration in the electrical activity and thus leads on to heart block. So that is why this is the most popular theory which is going on currently. Although I presented this in first the immune complex theory, followed by interferon alpha, type 1 interferon, and then followed by the calcium channel involvement. But if you look at it, the most popular hypothesis currently is that maybe it is Rho52, anti-Rho52 antibody actually leads on to the first insult, which causes the problem in the calcium channels. which leads on to apoptosis of cardiomyocytes, and later on the anti-Rho60 comes into play and causes the further insults and fibrosis. So what is the importance of these antibodies when you look at the titer? Is the titer important? So there are a lot of papers which this is one of the very beautiful papers in which they have looked at the impact of anti-Rho antibody as a prognostic marker in the development of cardiac neonatal lupus. And what they found is that the high positive anti-Rho, which was in their ELISA, it was more than 100 units per ml, it was actually 2.5 times more associated with the development of autoimmune cardiac blocks, conduction block, as compared to the mothers who had very low positive anti-Rho antibody. So none of the mothers with low positive anti-Rho antibodies actually developed the fetal heart block, meaning to say that the titer of antibodies does matter. This was again basically it was endorsed by various other papers in the future, later on. So there was a question as to what leads on, are there any other factors other than the antibodies, because finally only 2% of the mothers in the first pregnancy with these antibodies develop the cardiac block. So there are various genetic factors and there are some non-genetic factors like the presence of beta-2 glycoprotein, the calreticulin, the maternal age, the winter, the season, if the time of 18 to 24 weeks falls during winter time, and hypothyroidism, all those things can contribute to the occurrence of CHB in the susceptible mothers. So now the lady, she asked, okay, so far so good, what can I do? So we are talking about the first pregnancy. So there comes the role of hydroxychloroquine. So the role of hydroxychloroquine in the prevention of autoimmune cardiac heart blocks is basically, it was initially suggested by a case control study followed by a multinational cohort study, wherein they showed that hydroxychloroquine, the mothers who were prescribed hydroxychloroquine, they had a 50 to 60% reduction in the development of heart blocks even in the presence of these antibodies. So meaning to say, HCQ definitely has a preventive role. How does it act? Basically, it acts on those pro-inflammatory macrophages. It prevents the endosomal TLRs from activating and leading on to basically non-activation of the pro-inflammatory macrophages. So this further was actually studied in the PATCH study. PATCH study, basically it was a two-stage design study wherein they assumed the historical rate of recurrent CHB of around 18%. The mothers were given hydroxychloroquine in the dose of 400 milligram from 10 weeks until delivery, and they found in the stage 1, wherein they recruited 19 patients, only 2 patients developed the heart block. I mean, the fetuses of the patients developed cardiac block. Then then they again enrolled 35 pregnant women, and they found another 2 patients developed CHB. When they looked at, so actually out of 54 patients, only 4 patients, fetuses of 4 patients developed the heart block. So meaning to say, when you look at the historical rate of recurrence of CHB in a mother who is anti-SSA positive, for a child to develop heart block, actually HCQ reduced the recurrence by 50%. So essentially, it's a safe drug. It can be given even during the first pregnancy, as well as definitely beyond doubt during the second pregnancy. So, but when do you give? Start early. That is what. I will not go into the experiment because of the interest of time, where they have shown that HCQ, the mediation of effect of HCQ is via TLRs, which acts in the early phase. Once the cytokines have come into play, the TNF, interferons, etc., then HCQ actually loses potential. So better to give it as early as you can, even in the preconception period. So what is the recommendation? The recommendation of ACR, reproductive health and guidelines, they conditionally recommend HCQ in all pregnant women with positive anti-SSA or SSB antibodies, and they recommend HCQ for pregnant women with a previous child with a cardiac neonatal lupus syndrome. So essentially all patients, we can safely give hydroxychloroquine. Now what our patient did, she got pregnant, she got lost to follow-up, and she had a fetal demise But 2 years later, she presents to us directly in the antenatal clinic in 6 weeks of gestation. Now her question is, how do you monitor this pregnancy? Because it is basically we are talking about the prevention of recurrence of CHB in an antibody positive mother. And what can you do to prevent the recurrence? So both AHA as well as the ACR, what the recommendation is that in a patient with SSA, SSB positive mother, you have to do fetal echo surveillance starting from 16 to 18 weeks of gestation. How frequent? They recommend basically what you have to monitor? You have to monitor for a mechanical PR interval with a M mode echo and a pulse Doppler. How frequently? Essentially, they say for the first pregnancy, it should be less than 1 week, but less than 1 week. Whereas in the second pregnancy, it should be every week up to 28 weeks. And for the previous CHB, at least once weekly serial assessment till 28 weeks. So the M-mode fetal echo and pulse Doppler, this was actually proven in the PRIDE study. All of us know it is a PR interval dexamethasone evaluation study in which they studied 98 pregnancies in 95 women, and they found the PR interval of more than 150 milliseconds was considered as prolonged. But this study, with the fetal, when they followed this weekly fetal echo, Doppler echocardiogram, what they found, it could not detect the transition from first degree AV block to the second degree or third degree AV block, in spite of a rigorous echocardiogram monitoring. So what is the message? Basically, the transition from normal fetal cardiac rhythm to third degree AV block often happens overnight, within 12 hours. And the current recommendation of the echocardiogram will only detect the transition period very serendipitously. If you're lucky, you will detect. They found that there are early signs of injury, for example, echo densities and moderate to severe TR, which actually forestall that the child is going to develop a second or third degree heart block. So here we come to the fetal heart rate rhythm monitoring. So this is basically what we were talking about, the home monitoring. Home monitoring is basically you do by there is a fetal heart rate rhythm monitor. So this was a study by Cuneo et al. In which they had studied 315 pregnant women who were positive for the antibodies. And these pregnant women actually underwent from 16 weeks of gestation, they underwent twice daily fetal heart rate monitoring. And along with that, they also underwent weekly or bi-weekly surveillance with fetal echocardiogram. And what they found, just to cut short, is that they did not miss any of the abnormality in the heart rhythms. However, the pickup rate, like only one child, they could deliver with a normal sinus rhythm. The two children still developed the second degree heart block, and in the fetal echocardiogram, none of them developed the congenital heart block. Meaning to say, they did not miss any of the cardiac rhythm abnormalities with this. So this is what ideal monitoring strategy. You monitor thrice daily, the patient monitors thrice daily, calls up the pediatric cardiologist whenever there is a rhythm abnormality. And you do echocardiogram as advised by AHA and ACR. But this is too much. If you look at it, all the time the patient is on the go. Already there's a stress. So what basically now the goal is, how do you stratify the risk for development of this heart block so that you can have a cost-effective and patient-friendly monitoring? I'll just take one moment. So this was basically a very elegant study by Jill Bunyan and essentially recruiting the patients from the neonatal research registry for neonatal lupus at New York University Medical Center, wherein what they did is that the goal was somehow to define a titer which has a 100% negative predictive value for developing AV CHBs, so that you can at least safely exclude those patients from such an intensive, rigorous monitoring. So they did basically the estimation of anti-Rho 52 and anti-Rho 60 antibody by two methods. One is the multiplex bead-based assay and the research ELISA. And what they found is that in both the assays, they had a cutoff. Now this is specific for that particular ELISA. Every ELISA has to have a different cutoff. So what they found is that some antibody titers, in their test it was less than 110 AU units per liter, as well as in the ELISA they have given a liter. If you look at it, if these antibodies were less than this particular titers, it had a 100% negative predictive value. And which antibody did the best? It is anti-Rho52 antibody did the best. So at least these patients probably if you look at it, we will not call ourselves as resource poor. I think we will call us as resource rich, and maybe US as resource poor when it comes to this kind of monitoring. So this is but only problem is that it is restricted to one commercial assay and all patients are tested. Now what about the effect of fluorinated steroids in preventing recurrence? So I'll just, this is basically again a retrospect registry data wherein they have looked at the 71 patients with the 71 fetuses who had already developed the advanced cardiac block. As compared to 85 patients, they were given with dexamethasone 4 milligram per day and not given dexamethasone. And what they found is that giving dexamethasone in a patient who has already have a fetus who has developed a heart block, there was no benefit in reversing the heart block, mortality reduction, as well as preventing the pacemaker implantation. So that is why the recommendation is, there is only a very conditional recommendation against treating these patients with dexamethasone. Again, then came the PRIDE study. Now in the PRIDE study, the gist of the PRIDE study is that the dexamethasone was given in patients who had a prolongation of PR interval and had not developed advanced cardiac block. And what they found is that at least in 2 of them, they could actually revert the heart block. So that was one study which came in positive for at least the first degree heart block, use of dexamethasone first degree heart block. Now what about, then there was another, this is very beautiful study, wherein they had studied 70 fetuses again with first degree heart block. And what they have shown, all normalized with 3 to 14 days of dexamethasone. So we do not basically know whether dexamethasone acts. As of now, yes, it can be given when you are talking about the recurrence. And this was the regime which they had given, dexamethasone followed by prednisolone up to 6 weeks after the birth. And so that is why the recommendation from, again, ACR is that you can conditionally, it's a conditional recommendation, first and second degree heart blocks on echocardiography may be treated with oral dexamethasone 4 milligram. Now, but I'll skip this. Now, there are a lot of concerns regarding the safety of dexamethasone, and there is this study in which they had studied betamethasone, and they found that betamethasone actually did not develop any sort of, the children who were given betamethasone did not develop any sort of learning disability in the future or any complications. So maybe betamethasone is better than dexamethasone. What about IVIG? Now there are 2 studies, one is the retrospective study, a prospective study, and the other one is a trial, open label trial. In both the trials, actually both the studies did IVIG at a dose of 400 milligram per kg per day did not prevent the occurrence of 3rd degree heart block. Do we do the antibodies in the subsequent pregnancies? Actually, there is no point. The titers do not vary between across the different pregnancies. So there is no point in serially monitoring the titers in the subsequent pregnancies as far as the risk of CHP is concerned. Another question is that, do we have something called as the late complete congenital heart blocks? Yes. So there are reports wherein they have shown that there are reports of the fetus developing heart blocks even after 24 weeks of gestation, up to 1 month after the birth, that is in the neonatal period. So monitoring is required even after 24 weeks of gestation. So the moral of the story is 1 to 3% of the fetus with anti-SSA-SSB mothers develop cardiac abnormality. The recurrence risk is 18%. HCQ can be started preconceptionally or at early pregnancy. This is the only preventive measure as of now which is found to be useful across the studies. How do you monitor? We have already discussed by fetal echocardiograms. Along with that, with the fetal heart rate monitoring. However, none of the fetal echocardiograms could detect the transition from 1st to 2nd or 3rd degree heart block. Now, what about the steroids? Fluorinated steroids may help in reversing the first degree heart block, but not the second and third degree, so there is no use in giving on those patients. Monitoring is ideal monitoring, we have already discussed. It's cumbersome, so you can risk stratify the patient depending on the titers of antibodies and develop. So this patient finally developed a normal baby with a normal heart till 1 month, and the PR interval normalized by 20. She did develop the first degree heart block in the second pregnancy. We treated the patient with dexamethasone until delivery. The PR interval normalized by 26 weeks, and the patient developed a normal baby with a normal heart till 1 month. Thank you.
Thank you, ma'am. It was a nice deliberation, ma'am. And any questions from the audience?
Okay, thank you, madam. So, no, my question is, you have shown in the first slide, the pregnant lady of 25 years presented with arthralgia, okay, and you immediately go for ANA profile. So, what are the indications of going for ANA profile anti-Rho in pregnant patients? So, do you mean that all patients who comes with arthralgia, you send them for ANA profile? So, tell what are the real recommended indications of going for Rho and La in pregnant ladies?
So actually there is no consensus regarding this, sir. I have put a slide. Should all patients, actually all pregnant ladies, be actually screened for anti-SSA, SSB antibody? So it depends on what is the cost of the antibodies in your country. However, it is freely available, so there is no consensus. Actually, now what they are trying to do is, they are trying to kind of stratify the patients as to who develops, other than these antibodies, who all develop this kind of. So I would suggest any patient who is coming with any sort of rheumatic symptoms and is planning for a pregnancy, especially if the patient is elderly, has comorbidities like hypothyroidism, I think we should be a liberal on testing these antibodies. However, the prevalence is only 1%. So I don't have an answer for it. I did go through many recommendations, but there is no consensus.
Thank you, ma'am.
As you understand, first degree heart block means it is the prolonged PR interval. By doing a fetal echo, how can we diagnose this first degree heart block? Because this is essentially more important to detect first degree heart block, so that if you intervene, and I think the prognosis is better. So how do we detect a fetal echo?
So I would like to, disclaimer is I am a rheumatologist. I don't do fetal echocardiograms. However, I can tell it only by my understanding of what I have read, and I have talked to a gynecologist. There are some surrogate markers for this first degree heart blocks. They have been able to, for example, I think there's something like echogenicity, the change in the echogenicity which picks up this sort of a heart block. Second thing is that there are some, they call it as a mechanical PR interval, which is basically can be picked up with the help of Doppler, as well as some changes in the mechanical, like the echo densities, the TR, the presence of tricuspid regurgitation and so on. But I think it's better to ask the fetal cardiologist.
I think Preeti,
yes.
Dr. Preeti will be a better person to answer this question.
Sir, when we see third degree or complete heart block, what we do, we put a M mode Doppler traversing the atrium as well as the ventricle, so that we can know both the atrium and the ventricular heart rate together in one plate. So if there is complete dissociation of atrial and the ventricular interaction, that we know that it is a complete heart block.
The sir is asking about the prolonged PR interval.
Yes, sir. So first degree, though, very easy. Sir, in first degree heart block, we take that PR interval. PR interval, we are putting that spectral Doppler, and after that wave, we calculate that PR interval. If it is more than 140 microsecond, then it is significant.
So actually nowadays there are some nice, those called as double mode echocardiograms machines, which actually you just measure the A wave and the V wave, and then after that, it actually records whatever happens some minutes before the missed interval has happened. Real-time imaging. So even if you miss that, actually the machine has already recorded, and you can go back and then you look at. Actually, there are some arrows and all which I wanted to say, but I think it's beyond the scope of this.
Thank you very much, madam. There are few questions from my side also, but due to paucity of time, I will discuss during lunch time or during the break. Thank you very much for the wonderful presentation.
Thank you.
Thank you, sir. Thank you, ma'am. May I please request you to move towards the felicitation arena? So now it's time to pause and honor the visionaries in this field. Time for something that's very close to our heart. The OARFT tribute to the pioneers of rheumatology. May I request Professor Dr. Jyoti Ranjan Parida to kindly shed light upon it.
So when we talk about education and learning, I think this will be not fulfilled until otherwise we know how to respect and how to honor those people who have dedicated their whole life for education and research and training the next generation of doctors. So for this, when we have started this OARC update, every year we try to invite and felicitate one of those pioneers in rheumatology who have significantly contributed and sacrificed their whole lifelong efforts and tapasya to make rheumatology to the forefront. So if I'll name the previous previous teachers and eloquent personnels, Professor Dr. Ramnath Misra sir, who is here, is the first. We have honored him first as OARFT Tribute 2022. Professor Dr. Amita Agrawal ma'am, Professor Dr. Vikas Agrawal sir, Dr. Rohini Anda sir. And today, why I am saying all this? Because today we have somebody who is teacher of teachers. ये जितना नाम मैंने लिया है, everybody have worked and learned from their teacher, and today we all are fortunate to have Professor Dr. Anand Malabya sir for this blessing us and present here, and we are honored to invite him to the stage for honoring him OARFT Tribute 2025. Sir. So, sir.
Thank you so much.
So before lighting upon his academic credential and this thing, I must share what is his role in my life in taking rheumatology as a branch option. When I finished my MD medicine, we were really skeptical because at that time the only option was SGPGI Lucknow and there are only 3 seats. So if you fail, then there is no ground to fall. You will directly fall into. So what happened, then I have actually not given the first entrance exam after finishing my MD medicine. Then somebody suggested me there is one DNB seat at R&R Army Hospital, at Indian Institute of Spinal Injury Center under Dr. Professor Anand Malabya sir. So 2 people have gone. Actually, I was ranked second in that theory exam. And then after reaching there, I knew that there is no role of interview because this is only based on the theory score. But after the interview, I have heard a lot of things about Dr. Malabya sir. But when he told me at the end of the interview that we wish we could have taken both of you both are so good. So that is one word which has inspired me, ignited me that felt me that confidence that I belong to here. And then after 2 months, I cleared SGPJ and this thing. So thank you, sir, for motivating hundreds of people like me. And we have the opportunity, Professor Ramnath Mishra, sir, which is initial students. So I'll invite sir to share his thoughts with and his association with Professor Malave, sir.
Thank you, Jyoti. It was 5th May 1982 when I had the opportunity to be interviewed by Sir and V. Ramalinga Swami, the then Director General of ICMR. Actually, I had taken a different route. I was one of the talent search, and V. Rama, and Sir used to call him Rama, but he is a very tall figure. He was ex-director of AIMS, Ashok Babu would know. He asked me that you have two options, either go for clinical immunology or go for clinical hematology. And we have our hematology center in Mumbai. But accommodation is very difficult in Mumbai, so you better be in Delhi. And then I came under Sir. I would just share what difference, or as a teacher, being from the state medical college, SCB, there is always a sort of inferiority when you go to a place like AIMS and with Sir's name and all that. You find it by karna kya hai yahan. You feel very helpless. I don't know, many people would have felt helpless, but then they become masters. So, three things that have impressed me most of Sir's thing. First, of course, his English was good and ours was not so good. And the clarity of his teaching, the immunology teaching of those days by Sir was probably the best I've had. I mean, subsequently the subject is challenging, it is been overburdened with knowledge, information, but the immunology lectures that were given by Sir was par excellent. And second thing was the time sense, punctuality. Sir was in 4076 room and 4077. The room would open at 9 o'clock, irrespective of anything, and the OPD starts at 9:30 maybe. Invariably, if you are late for many days, Sir would not say, I mean, he doesn't scold like what is deserving to be scolded, but the body language would indicate that aaj ka din to nikal gaya, matlab. So you would not get a place in Sir's OPD opposite Sir. So there were two, me and there was one Banerjee. Of course, he was equally little late like me. But, and the third thing, I was a clinician, so we went for a lab thing. Sir, and we did what many people have not done. I mean, the way immunology labs are there, many people would not, or many students like me, they would not have got that kind of exposure. So, Sir had such a big heart. You know, those chemicals, biologicals, they're very expensive. And we used to do things with our own hand. There was no kit fit thing, these things that are there now, which makes it more pricey, and actually it deters one learning because you don't know what is this. So, Talwar Saab was there in biochemistry, so a big name, and I was associated with one of the PhD students. So we learned the hard way of how to tag antibody to conjugates, how to do ELISA by our own hand. It was Abramius who discovered ELISA, had come to Sir lab, and I was fortunate to learn ELISA from and that was a revolution thing. It makes you different. How you learn to learn laboratory, and Sir had such a big heart. You know, those sigma chemicals, they're very pricey. Where would fund come for? We would play with those chemicals. Of course, by playing and wasting, you learn. I am grateful to you for whatever I am because of you. And the New England Journal of Medicine comes. Sir is the first person, he used to get a copy. Anything related to rheumatology, he would tear off the page and bring it to us and कहेंगे ये भाई इसको discuss करते हैं. So you can know the amount of sincerity, and of course there were students before me. Ramraj came after me, Subhasis Banerjee was there, Kausik Chaudhary was there, they are all there. But these, as a dedicated teacher, they change their life. So, एक चीज़ तो सीखना है, भाई how to create student. It's not easy. It's not easy how to create student. You might have known something, but how to create a student to again have a passion, to again have an interest. And with, of course, it was the year I joined in 82, 83, Professor R.N. Maini had come to Sir. And Sir said, bhai, inko aap Cuttack le jaiye. Cuttack hosted the API. Professor R.N. Maini had come. So, obviously, I had got a more chance to meet with Tiny and Geraldine, and subsequently got exposed in UK, but it's all thanks to you. I wouldn't have dreamed place like Kennedy Institute of Rheumatology, the place where anti-TNF was discovered, in fact. I mean, Sir has got many papers, books and all that, but this teacherly touch, what we call humanly touch, is an exceptional quality. Sir, जो भी हम थे आपकी वजह से, and I must tell something I learned. It is the time that wins. It is the punctuality that wins. Whatever it may be, at 9 o'clock, the room would be opened, and 9:15 or 9:20, the OPD will start. This value of time, it was amazing. We used to take life more carelessly, more seriously. Karna hai to. So by someone coming at 9 o'clock, he must have woken up at 6 o'clock or 5 o'clock. And Sir used to get milk also. It is a traditional practice of AIMS faculty to get milk. There was a milk center, a mother dairy, they used to go. So people who are big really, they have a very normal life. And the clarity of immunology and rheumatology, exceptional. Sir didn't teach that much immunology later on, more into clinical rheumatology, but I still treasure those lectures. Thank you, sir.
And 6:30, sharp, round in the board.
Sharp round at word. And really, if you practice there, you will find there is no difference between what we say between a rich and a poor, or who you are. Line pe dekhna hai. Ranjan can testify whether things have changed over the years, but
Same pedigree. I know Ranjan quite well now.
that is all I have. I could go on saying many things, but that is all.
Thank you, Ram.
So, now I request our scientific chair to read the citation for sir.
Thank you, Jyoti. Now I have the privilege to read the scientific, the OART tribute to Professor A.N. Malviya. And I will start like his initial careers and other details. Born on 27th November 1939, Professor Malviya's journey began at KGMC Lucknow, where he completed his MBBS and MD. But his real turning point came in Boston, USA, where between 1964 and 1968, he trained in autoimmune diseases and under Professor Robert S. Sauer, becoming the first Indian physician formally trained in clinical immunology. Sir, this was before my birth. So, when he returned to India in 1968, he carried back not just his knowledge but a vision. He joined All India Institute of Medical Sciences, New Delhi, and built from scratch the first division of clinical immunology and rheumatology, where what he created went beyond walls and departments. He laid the foundation for a field that had not yet found a name in Indian medicine. He set up the first autoantibody laboratory for diagnosing autoimmune diseases and co-authored a historic Lancet paper on low-dose methotrexate in dermatomyositis, a treatment now used worldwide. Over the years, he played a pivotal role in getting rheumatology formally recognized in India. From AIIMS to SGPGI Lucknow, from Chennai to Hyderabad, he helped shape academic programs, accredit departments, and most importantly, trained more than 60 rheumatologists and immunologists, many of whom led the field today in the country. His students remember him not just as a teacher, but as a guide who challenged them, nurtured their growth, and inspired them to think deeply and compassionately, as rightly told just before me by Professor Ramnath Misra. Even after retiring from AIIMS in 1994, his journey did not slow. He served in Kuwait and returned to India in 2000 and continued to see patients and guide young doctors with the same quiet dedication. With over 500 publications, numerous awards including the first Indian to get ACR Master by the American College of Rheumatology, an Appler Master, and most recently the AIIMS Lifetime Achievement Award presented by the Honorable President of India. Professor Malviya's legacy is unmatched. But beyond the awards, it is his humility, clarity of thought, and unwavering commitment to patients that define him the best. For many of us, he is not just a pioneer, but a symbol of what a life of purpose and integrity can look like. Today, OARFT proudly pays his tribute 2025 to Professor A.N. Malviya to celebrate a life that has touched thousands, not just through medicine, but through mentorship, compassion, and vision. Thank you, sir.
Thank you. Thank you.
So, I'll now invite my wife Amrita, who has written a beautiful poetry for sir. So, this will be last.
Thank you, sir.
I feel very humbled, privileged, and really lucky to write a poetic tribute for every legend. And I don't know, I have no words to express. So kindly forgive me if you find any mistake. From Lucknow's halls to Boston's flame, you carved your path beyond just fame, guiding your students with nuance and stature, call you the healer, the scholar, the ACR master. You sowed the seeds of rheumatology in India. With insight and care, you shaped its idea. Low-dose methotrexate in arthritis care, your pioneering voice, the Lancet chose to share. AIMS, SGPGI, ISIC echo your name. Your vision endures, a lasting acclaim. A mentor's grace, now in 60 minds, your legacy lives in PubMed scholarly finds. Awards and accolades rain upon your frame. Your legacy shines and lives an eternal claim. You saw ahead what few others could see, yet humble, you served like a rooted tree. Now, as the years unfold your story, the winds with pride lift you in their glory. The architect, India's father of rheumatology, OARFT pays tribute to your timeless ideology. Thank you, sir.
Listening to this, I was thinking, who is this person? Because it can't be me. Thank you.
So now I invite our chief guest, Professor Dr. A.K. Mahapatra sir, who is kind enough to sit so long for honoring this, doing this honor. Thanks.
We almost worked together for 20 years. I joined AIMS in 75, sir left in 95. So, okay, chalo, back. Thank you, thank you. You can-
Perfect. So now I think this is the time to listen from Dr. N. Malabya sir.
For the talk, may I request Professor Dr. Ramanath Mishra, Dr. Bharat Panigrahi, and Professor Dr. Manoranjan Behra to chair the session.
May I have the slides, please?
I also request Dr. Bina Panda ma'am, please to come to the chair. Sir. Okay.
I think this all has been done. How to move this slide? Can somebody help me? Can we move this slide, please? Slide. Next slide. How to move?
Sir, this one is the slides. Yes.
Okay. Move the. Okay.
Is it moving? Yes.
Chairpersons, colleague rheumatologists, ladies and gentlemen, it's a pleasure to be speaking with you today on a topic increasing relevance in our practice, that is, balancing disease control with safety for mother and fetus and the child when using disease-modifying anti-rheumatic drugs. I won't like to call them immunosuppressive. Probably the better word will be immunomodulators, but the best word is disease-modifying drugs. That helps to allay much of the anxiety related to these compounds. And that way, we can probably pacify the patient also, because many of them consider that we are going to give them cancer drugs, whereas we are far, far away from any type of cancer drug that we use, by 2 log orders difference. And that I will be talking about in a few slides that I will be showing. The second thing which I would like to mention right in the beginning, we have general physicians here in the room. Just mainly, of course, sir, you are, you know all the younger colleagues who are doing general medicine, a request. You are the first caregiver to come in contact with a person who has problems related to musculoskeletal system. And therefore, you should be very clear in your mind not to delay, to send the patient to the best person who can deliver and relieve the patient of the trouble that the patient is suffering from, mainly pain. And therefore, you should be very clear in your mind what are the 3 major pillars which cause pain in the musculoskeletal system. And if you learn that, it will save a lot of patients' agony. It will save a lot of botheration of the medical world itself, because you will be preventing the long-standing damage that the patient suffers because of delay in reaching the correct doctor. And lastly, the patient will be most satisfied because they know what medicine is harmful and what medicine is helpful, so that throughout life they stick to that medicine. And these 3 pillars I will like to mention. There is a book I have just published. Of course, this was released by the director, All India Institute, recently on 29th of March. The immunoinflammatory rheumatic diseases, which can be autoinflammatory or autoimmune, that's pillar 1, where we, the immunologists, come and play a major role in diagnosis and treatment. Secondly, mechanical structural damage. So if a knee pain person comes at 70 years of age, on telephone you can tell them, this is not for rheumatologists. This is for physiotherapists, occupational therapists, and nutritionists who will ask you to reduce weight by modifying your diet. And if they fail, then the 3rd pillar comes. When our immunomodulation has failed, the patient is not responding, damage has occurred, or mechanical structural damage has reached a stage where no medicine or physiotherapy can help, then the 3rd pillar is orthopedician. On the other hand, the problem which is occurring nowadays is patient has knee pain, plus nobody took the history. Patient also have stiffness and cannot make a fist. And the person's age is 32 years, and she is a female. The patient goes to a general physician, go to the orthopedic surgeon. And the orthopedician will say, oh, it is old age or whatever, at 38 or 32 years of age. And 4 years are gone in all kind of supportive medicine, painkillers, etc., or steroid without thinking. And that has delayed. And that golden period when we could have completely stopped the damage of the body in the musculoskeletal system, that has gone in the past. And then we have to just manage the patient instead of really treating and making the patient completely a normal person. And that's why I will definitely like general physicians to have a clean idea, clear idea of the 3 pillars of musculoskeletal system. And for that, this book might be helpful. Now, then we start with today's talk, evaluating the safety of DMARDs in pregnancy and lactation, risks, benefits, and guidelines. Pleasure speaking to you. I will be telling you our practice, how we can balance disease control with safety in mother and child using disease-modifying drugs. So I will be three objectives mainly: review the rationale for DMARD use in pregnancy and lactation, discuss risks and benefits of each specific important daily use DMARDs, highlight the key international guidelines, because we have to follow them so that we avoid all kind of litigations on doctors and we keep our patients most satisfied. And then in the end, I may share one or two case-based cases on which we can use these recommendations. Why it matters? Autoimmune diseases are common in women and children, and childbearing age women. Active disease risk leads to miscarriage, preterm birth, growth retardation, and therefore our goal is to control with disease control with fetal and neonatal safety. So here we are going to discuss not only the drugs, but their safety both in the mother, during pregnancy, and in the newborn. The classification is quite straightforward. These are disease-modifying drugs. The conventional synthetic DMARDs, in which we have methotrexate. I will like just a minute on methotrexate, because the moment methotrexate name comes, many of the younger physicians will think about one thing, and that is lymphoblastic leukemia or some other malignancy where methotrexate is used. And they will forget the dose. They will just remember the name that it is a cancer drug. And suddenly, the same name is given here in the context of musculoskeletal system diseases. Oh, this is cancer drug. Please, for God's sake, remember there are two methotrexates. They are entirely different. And those who are my age group, or at least around my age group, will remember there is a drug called aspirin. What is it used for nowadays? Can some general physician or anyone can answer? As an antiplatelet agent to prevent clotting in the heart and brain and all. And those who are older, what was it used first? As an anti-inflammatory drug. What was the dose? 6 grams a day. How much? 6 grams of aspirin. And what is the dose now? 75 milligrams of aspirin. 120 milligrams. 2 log orders difference. So that aspirin and today's aspirin, there is no relationship. Neither in its pharmacology nor in its effect on the body. We are dealing with 2 different drugs called methotrexate. Kristen and Krishnan may be similar, but they are 2 different persons. So we are talking about low-dose methotrexate, which is 2 log orders less than that cancer drug which we don't use. So remember, don't say, oh, don't take methotrexate, cancer drug. And when the patient comes to me and patient has rheumatoid and I want to start methotrexate, sir, wo cancer drug nahi lunga. Yeah, cancer drug nahi lungi, because most of them are ladies. So this is where your role becomes very important. Remember, this is not the same methotrexate. This is just the name is similar. So don't confuse between them. And it is amazing. One of the safest drugs known to human being has turned out to be low-dose methotrexate. And yet, I'll tell you something about it in the context of today's talk, maternal and fetal health. So methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, and azathioprine are the conventional synthetic DMARDs. And this digression was important because understanding methotrexate of two types is very important. Now, once they start failing, we have the biologicals, and Professor Ravinder Mani's name was taken, the original person who discovered biologicals for use, and that has become now widespread in medicine. I asked a question to a general medicine person, what specialty the person must have belonged who came up with the first biological used in medicine. Oh, hoga koi biochemist hoga, maybe some pathologist hoga. Humne kaha, sorry sir, you haven't heard the specialty, it's called rheumatology. He is a rheumatologist who discovered the first biological, which is still being used, and that is called infliximab, an anti-TNF inhibitor. So we have biological DMARDs starting with anti-TNF, that is infliximab was the first one. Of course, in the clinical use, its sister called etanercept was the first one to be used in rheumatoid, because the other one was used in inflammatory bowel disease about 6 months before it was used in rheumatoid. Then we come on the third one, the targeted synthetic DMARDs, which are now being sold by Pan Ki Dukaan, and all the chemists are selling it, and doctors are not involved. This is a joke. Tofacitinib is now being misused so widely that we are getting extremely worried that this wonderful, outstanding drug is now going to be a wasteful drug which will kill more human beings and produce more side effects than any other drug has ever done. But for today's talk, these are the three classes of drug. Which one is safe in pregnancy and lactation? I will be discussing with that. So we have TNF inhibitors and some other biologicals, and JAK inhibitor, and tofacitinib is the only one present available in the market. General principles in pregnancy, and I'm scared, I'm talking in front of the great obstetrician sitting here. Preconceptional planning is critical. We must tell the patient that you have to be in good health to become pregnant and then carry through pregnancy. Minimize fetal exposure to all kinds of teratogens. This is our responsibility, both the obstetrician and us. Prefer drugs which have long proved safety. They may have come in last week a paper that this drug is almost safe, but let us not use it for the time being till it is established that yes, it is really true. It is not only a single paper, but several papers and several studies have shown that the drug is safe in the long run. And maintain maternal disease control, because mother's health is much more important. Because if she is not in good health, she cannot deliver a healthy child, and then after delivery, she cannot handle that child's upbringing if she is not well. So maternal disease control for a rheumatologist is paramount. What are the drugs that are safe? In conventional group of 4 drugs that I mentioned, hydroxychloroquine is the safest drug, although it is mild in its action, but you can continue it before, during, after, even while lactation. Hydroxychloroquine, safest. Despite all the bad name it has been given due to wrong usage of the drug in the COVID era. Use of hydroxychloroquine, wrong dosages, wrong schedule to treat COVID disease, COVID-19, was a disaster. It has brought bad name to hydroxychloroquine, and now many physicians, no, please don't give it, as cardiotoxic. I can show you a dozen articles now. Hydroxychloroquine does not have cardiotoxicity except in extremely rare, once in a while case. And in my lifetime of practicing rheumatology, I have seen one case of myocarditis due to the dose that we give as a rheumatologist. So it is safest, as safe as traveling on aeroplane. Second, sulfasalazine, safest during pregnancy, before pregnancy, during lactation. Third, azathioprine is safe except there is a genetic abnormality rarely found that you give azathioprine and they suddenly develop leukopenia. So just be careful, keep doing cell count, the CBC. Then TNF inhibitors. Nuanced. Now, after 25 years of use, we feel that it is probably safe all through pregnancy and lactation. But one of them is completely safe, which does not have the FC component in the monoclonal, and that is certolizumab, which unfortunately is not available in India. Others, etanercept, even I have used almost up to 7th month of pregnancy. And yesterday, day before yesterday, the paper has come from Canada where 25,000 pregnancies have been followed. And for some reason, anti-TNF was continued throughout pregnancy, and they haven't seen major adverse effect. But as I said, this is one paper, and this doesn't mean that everyone should start using. Be careful, but quite safe, and if the need be and the patient is not well controlled, I will continue anti-TNF with the consent of the patient and the family, that it is supposed to be quite safe, and hopefully it will be safe. So that is the DMARD list that are saved. Nuanced decision, I have already mentioned about TNF inhibitors. Just discuss with the family that more or less it is safe. We need a few more papers to confirm this. Rituximab to be avoided. Abatacept and tocilizumab should not be given. The insufficient data, but I will not use it. Avoid it because probably they interfere with the development of fetus. In breastfeeding, hydroxychloroquine and sulfasalazine, as I mentioned, is completely safe. Azathioprine, lowest effective dose, is quite safe and can be given. Methotrexate, nuanced. At present, international guidelines say methotrexate and leflunomide should not be given. But I will discuss, if time permits, there are some issues. Last week came a paper as an editorial also. Leflunomide, 25,000 plus deliveries, nothing has happened, but please don't use it. It's not official. It's only a paper. American College of Rheumatology, ACR guidelines, EULAR guidelines, and BSR don't advise you to use. But papers are coming. Maybe in the next 5 years, leflunomide will be cleared. Methotrexate, I will discuss with Durga and Ramnath why methotrexate has been put in the serious categories and should not be given. Because theoretically, I think we can. But for you, take home lesson, don't prescribe methotrexate. Otherwise, you might get into litigation issues. TNF inhibitors, as I mentioned, very small amount is secreted in breast milk, can be given, but except for certolizumab, which is not available in India, be cautious about it. Discuss with the patient, and then probably you can give it. Safety of DMARDs and corticosteroids during breastfeed. As I mentioned, hydroxychloroquine, azathioprine, sulfasalazine safe. In B-DMARDs, adalimumab likely safe. Etanercept, my choice. Certolizumab, Pegol, completely safe. Glucocorticoids, low dose, quite safe in the beginning. TS-DMARDs, no information available. So tofacitinib, although there is nobody who will say that don't give it, but nobody says give it, not enough information. So I will advise don't use tofacitinib when you are trying for pregnancy, during conception, during pregnancy, and after during breastfeed. Methotrexate and breastfeed. None of them advise that it should be given. ACR, EULAR, as well as Biobank, UK, and BSR. I would like to ask Durga Prasanna and Ramnath and other immunologists and rheumatologists. Methotrexate gets glutamated within 6 to 8 hours. maximum 10 hours, and enters red cells. Breast milk doesn't contain red cells. Then, after 10 hours of a single dose, once a week of small dose of methotrexate, 25 milligrams, why can't we give, after excluding the milk made during that 10-hour period, why can't we give methotrexate to a lady on the next day and next week? So this is a question, it is nuanced. I'm not recommending, but I will like immunologists to think about it. Maybe we can in future clear methotrexate. But today, don't give it. Legally, you will be caught. So methotrexate, no. That is the indication today related to methotrexate. And even in breastfeeding, it is not permitted today. Future, I don't know. So EULAR, HCQ, hydroxychloroquine, sulfasalazine, azathioprine, certolizumab cleared. Other anti-TNF monoclonals, biologicals, probably safe, but wait a little more, then it will be cleared. ASIA guidelines tell avoid methotrexate, leflunomide, but I am not very sure about methotrexate. But for you, don't give it. Mycophenolate, definitely not. Neither during preparation for pregnancy, neither through gestation, after delivery and breastfeeding. Mycophenolate is most toxic, should not be given. Similar is the BSR guideline. So we have a patient of rheumatoid. Under my treatment, she is completely in remission. DAS28 as well as CDI, SDI, they're all in the remission rate. Stop methotrexate, 2 menstrual cycles. Although the guidelines say 3 months. But when you calculate, if you miss 2 menstrual cycles, it almost comes near 3 months. So stop methotrexate 3 months before conception. Start bridging with hydroxychloroquine or sulfasalazine. But if you read the chapter, Rheumatoid Arthritis, written by me in API Textbook of Medicine, I have pleaded that for Indian population, combine hydroxychloroquine and sulfasalazine. The reason for that I can discuss only during discussion. So I give the combination right from the beginning, wait, the patient tolerates it and remains in remission, then I give green flag, go ahead and get pregnant, assess the disease control during pregnancy with all the measures which rheumatologists will know, gynecologists don't have to worry about that. And then this is the time when they conceive, and that's how they progress through pregnancy. Disease control is paramount. Drug avoidance is secondary. Prefer long-established safe agents for pregnancy and lactation and breastfeeding. Document shared decision-making, very important. You must write down in the record because this area is all full of litigation. And once you get into litigation, your whole life becomes difficult. God has been great. I have not been involved in any of these things till today, but who knows, I'm still practicing. So I take precaution, and I always write down these things in my computer, in my EMR. Involve your colleague obstetrician in every case who wants to conceive and go through the pregnancy, and even after delivery, you have to be in touch. I'm sorry to say that there are some, not like you, but some of your colleague obstetricians practicing in isolation, they have objected to even sulfasalazine. They have, of course, don't give hydroxychloroquine, it will destroy your heart. So fortunately, we have mostly good, knowledgeable obstetricians who have learned all this by their own reading and by attending talks like this and interacting with their colleague rheumatologists. And so I'm not worried about such obstetricians. But I request them to teach their colleague obstetricians also that these are important things to understand about drugs which are necessary to keep the disease under control, because as I mentioned right in the beginning, mother's disease control remains paramount for a rheumatologist. So in summary, DMARDs are pregnancy safe, the names I have provided. anti-TNF is going to be safe in near future. Leflunomide is a question. Methotrexate we can discuss. Mycophenolate and cyclophosphamide is definite no-no. Follow these international guidelines and avoid getting somebody taking you to court. Breastfeeding generally safe by most of the agents that are safe during pregnancy. And thank you. I hope the presentation made sense. And here comes my book, which I keep on repeating, will help general physicians understand who should be sent to which category of caregivers. Thank you. Open for questions and discussions.
Thank you, sir, for your nice talk. So now the podium is open. Any questions from the, not only questions, rather clarifications, anything you want from, yes?
In a non-pregnant lady and in a pregnant lady, what should be the dose, and does it differ in trimester wise, and should it be according to weight, or how to know?
Excellent question. There is no difference between before pregnancy and during conception. The same dose remains. 5 milligram per kg is the hydroxychloroquine dose. Just maintain that. And regarding the eye problem, which is the only thing that we worry about, first 5 years, now the recommendation, don't even go to ophthalmologist. First 5 years, 5 milligram per kg is totally safe. After 5 years, once a year retinal examination by an ophthalmologist who knows what is to be looked into. It's amazing, even ophthalmologists, they look at cataract, oh, hydroxychloroquine. Yesterday somebody came, साहब आपकी दवा से हमको कैटरेक्ट हो गया. हमने कहा किसने बताया, उसको एक मेरी तरफ से लगा दो. In my own Delhi style. So just use the same dose, which is recommended, and the same dose also for sulfasalazine. It's a standard dose of 1 gram BD, and we keep on giving the same dose. No problem.
Thank you, sir.
Very much fortunate to listen from a legend like you, in fact. Just I have small doubt. Sir, so far as sulfasalazine is concerned, should we be a little bit more cautious when you are prescribing to premature child who is being breastfed? Because there is a concern for hemolysis, especially if they are G6PD deficient. Should we screen them routinely? Also, there is a possibility of hyperbilirubinemia.
Absolutely.
And sometimes even diarrhea has been reported.
Yes.
So, all these are concerns actually.
Here comes a well-educated and experienced physician. He has brought a point which, because of shortage of time, I didn't include. It's a rare side effect, G6PD deficiency. If it is present, they will have problems. And therefore, there was a time when G6PD screening was necessary in every case where we started sulfasalazine. But then it became clear that it is actually a very rare thing to have a G6PD. And therefore now, internationally, it is not recommended to do G6PD screening. But if take the family history, at least check there are some rare diseases, and the educated families usually will tell you. But what you said is absolutely right. But international guidelines have eliminated necessity for G6PD screening before starting sulfasalazine. So I will stick to that. And the amount of sulfasalazine excreted in milk, breast milk, is so small that it has been repeatedly shown it will not affect the newborn. Of course, I'm not talking of G6PD family. That I have excluded because international guidelines has removed that. It's a rare thing. And by history taking, family history, most of those who are G6PD deficient, they know that their family has it. But I leave it at that. The rest is, of course, every patient is different and we have to be very careful. But internationally
Thank you, sir.
accepted.
So one question from my side. So as you have told that this is a food for thought, that low dose methotrexate may or may not be this thing. So obviously we will not give if the patient is pregnant or breastfeeding. But suppose there is a very precious pregnancy, not followed that 3 months to 6 months of that gap period. And now because after so many years, our mother is already 40, that kind of scenario. So what is your suggestion to the patient? Obviously we'll explain everything, but I think we can go ahead by stopping methotrexate, or we'll tell the patient to abort or something.
Sorry, I didn't get the point you are asking.
So a patient on methotrexate get
Okay.
pregnant
Oh,
accidentally.
becomes pregnant.
Becomes
oh, well. Oh, this is a very, thank you for that. This problem is extremely serious. On every prescription, unmarried lady, you can quietly tell if you are having relationship and you are going to get married. But those who are married, then you can officially write down, while taking the medicines prescribed below, do not get pregnant, take all precautions. That will save you. Sometimes they get pregnant, and not the husband, but the father-in-law, the sasur, the boy's father. साहब आपने ऐसी दवा दी, अब क्या होगा? Threatening me. हमने कहा मैं कुछ नहीं करूँगा, सीधे जाइए abortion करा दीजिए. That is the standard advice we have to give. I have advice, it's on my record, it's on my computer, it's on my prescription, and if still, it's your responsibility. Now, my advice is go and get abortion done. You have to do that. But if you say, go ahead and try and dekho shayad ho jaye, and if something goes wrong, you will be caught. So I am very strict on that. ऐसे साहब कैसे होगा? हमने कहा देखो हमारी राय जानते हो. I am very straightforward. आपको कराना पड़ेगा. अगर नहीं कराना है तो कुछ होगा बच्चे में, that's your responsibility. And make it in writing, and see you will never have any problem.
No, sir, that is,
I have faced this several times.
that is true from legal point of view and for routine cases. I am thinking there is a case scenario when this is a very precious pregnancy. The mother is already very late. There are multiple history of abortions. And
I understand.
That's a...
I understand this has happened, and at my age I have gone through this several times, and with all Modi's and Ambani's type of patients coming to me and very precious something, I will tell them my advice is against it. If you have to take chance, at your risk. Be very firm about it.
Thank you, sir. But yes, what Dr. Jyoti told, I have got also one experience like that. And patient was not other, and patient came only after 7-8 months and telephoned me, sir, I am pregnant 2 months. मैंने बोला अरे यार, you are pregnant now, you didn't go. So I told, as sir told, you get aborted. He told, no sir, I will not. Well, then it is up to you, that is your responsibility. But she continued, and fortunately she got a
majority will go through without any
normal baby. Okay, so that happens. That is we should do our job, and responsibility is theirs. Thank you, sir. Thank you very much. We'll close this session.
Done? Thank you.
Thank you, sir. Thank you, sir. May I please request you to move towards the felicitation area? For the next talk, may I please request Professor Dr. Sujata, HOD, Department of CHR, Some Hospital, Dr. Satish Pradhan, Physician, Railway Hospital, Dr. Anupama Mundu, Consultant Rheumatologist from Rourkela. Please kindly chair the session.
Good afternoon, everyone. We know that autoimmune diseases are more common in young females, and at that age everybody may like to go for pregnancy and DA, but in this age, the contraception is very important. What you will continue with the autoimmune diseases and DA. To deliver this lecture, we have Professor Dr. Gauri Dorai Rajan, Madam, who is Professor and HOD of Gynec in Jipmar, Pondicherry. She has 30 years teaching and clinical experience, undergraduate and postgraduate examiner, DNB appraiser, 97 publications, authored 2 books, and guided more than 50 projects. So it is a lot to say now, but we'll continue with the lecture because of sort of time. Thank you, ma'am.
My greetings to all. At the outset, I would like to thank the organizers for taking me on board for this topic, and my humble respects and prayers to sir. I feel extremely jittery and humbled to talk after a global legend. I'll be talking about contraception and autoimmune disorders, balancing safety and efficacy. We have all heard since morning that women suffer more than men, 6.4%, and we also know that the musculoskeletal disorders are probably the commonest among them all. They can be systemic disorders involving many organs, or there could be local disorders pertaining to a specific organ. So let us look at what would the woman hormone do, what is their effect. Estrogen and progesterone are the so-called feminine hormones. Estrogen has been shown to enhance the immune response under certain conditions, especially the slightly higher doses of estrogen. Estrogen therapy has been shown to reduce the synovial nerve fiber neurotropins in animal models, and it probably modulates and can reduce the pain perception. While progesterone can exert immunosuppressive effects, progesterone enhances the T helper 2 and the TREG activity and decreases the TH1 and TH17 activity. And so some of the diseases which have that as the pathophysiology, like rheumatoid arthritis and multiple sclerosis, are going to become better during pregnancy. So there is a need for contraception. We have to advise delay of the pregnancy in a recent onset disease, in a disease which is active or which has developed complications like thromboembolic phenomena, till the disease has achieved a stable remission for 6 to 12 months, before which pregnancy should be avoided. Converting them over in those who have got married or are planning a pregnancy to a more specific, potentially less or safe, as sir has enumerated the list of it, teratogenic, non-teratogenic medications, before we can advise her to embark on a pregnancy. And of course, she should avoid a pregnancy altogether, probably for a life, if that may be so, if in case of a severe organ involvement which has got irreversibly damaged. Family planning in general promotes healthier behaviors and enhances pregnancy outcomes. So there is a definite need for contraception to plan a pregnancy. There are existing gaps. Studies have shown that 70% of women are likely to be on a teratogenic drug, and probably only 7.9% in a particular study are using a highly effective contraceptive method. It has been also seen that women who have got the advice from the gynecologists or the primary care providers and not probably from the specialists are more likely to use the prescription contraception. So there is a gap, and each one of us should be aware of it, should be able to advise the patients so that the contraception needs can be met. I'll take you through a few contraceptive methods so that we are all on the same platform of learning about them as well. Contraceptive options, we all know, are the natural methods and the barrier methods to begin with. Most easily available and doable and pretty safe. 2 steroids combined, estrogen and progesterone only. Intrauterine contraceptive devices, there are a lot of emergency contraception, and of course the male part of it, which I'm not going to touch upon today, and permanent methods are the various options available. The rhythm method or the natural method basically would involve calculating the fertile period, and it's very easy to calculate if one knows the shortest and the longest cycle of that woman in the last 12 months. The fertile period can be calculated. It can also be calculated with the help of the dry and the mucus time of the entire month, and the mucus period is taken as the fertile period. Taking, a barrier method or an abstinence in the fertile period could reduce a pregnancy. It is low cost, it has no side effects, but it can be confusing in women who have leukorrhea or discharges postpartum, etc., for any other reason which could confuse the mucus method. It has a high failure rate, so that is a downside of it. Barrier methods, we are all aware of male condoms. Advantages are plenty. One of the important advantages also is that it can protect against sexually transmitted disease and pelvic inflammatory disease, which becomes relevant when a patient is on the drug modifying treatment. So it is very favorable for women who are having infrequent coital acts. There are no side effects, no contraindications, but again, the user failure, that means the day-to-day user failure is pretty high to the tune of 14 to 28 per 100 women year. There are a lot of female barriers available, which are very much available in India. Female condom, there are 3 varieties of it, which is available in India, and they are very useful. The sponge, which is available in India as today, has a nonoxynol 9 or a spermicide impregnated in it, which can be inserted into the vagina. The important aspect to realize here is that double barrier method can reduce the failure rate to a large extent. So a male barrier along with a female barrier along with a spermicidal cream would definitely reduce the failure rates. A word about the cervical caps. Femicam is available in some parts of India but not favored. Diaphragms have gone out of repute in any Indian public facility. Intrauterine contraceptive devices, basically it started off with the plastic, the Lippes loop in the early 40s and 50s, has got replaced with a T-shaped ethylene or vinyl acetate copolymer with titanium oxide, which is impregnated with barium sulfate to locate it. And when it is wound with copper, which is the second generation IUCD, 200 square meter gave an efficacy for 3 years, and it has gone on to increase to 380, including the copper in the arms of it. As you can see in the figure on the right side extreme down, when you have the copper wound on the arm, it increases the square meter and increases the efficacy as well as the lifespan for which it can be used. Impregnation with progesterone, Progestacert, which was the first one to be marketed, went out of disrepute because it has to be changed every year and has been found to have higher rates of ectopic pregnancy. Vis-a-vis LNG IU system, the Mirena, and many more names like that, which have been very, very effective and have a life of up to 5 to 10 years. The Copper T380A, which has a silver core, has 10 to 15 years of life, contraceptive life. For reasons, we leave it only at 5 years and ask them to change after that. The slimmer versions like FlexiGuard, Q-Fix for the postpartum woman are also available, and we all should know that there are these methods which, sorry, it's not working. You can see on the right side, there are silver balls available which can be put even for adolescent contraception. In our country, adolescent contraception has not taken so much of, what do I say, can I use the word legalization or can I use the word advertisement for probably social reasons, but it is available globally and it is very useful because the traditional teaching for all undergraduates is IUCDs should not be given for an unmarried or a nulliparous lady. Not any longer when you have the silver balls or the extremely slim ones which would not harm the patient and would be very useful for her. Advantages of the third generation, which includes the copper 380A as well as the LNG IUCD systems, are that they have a high efficacy. The failure rate is as much as that of a permanent method. As you know, permanent method also has a failure rate of about 0.2 per 100 women year, and we can achieve a similar one with these long-acting third generations. So the pregnancy rates are low, the duration of action is pretty long, up to 5 years, and the progesterone systems have an advantage that they could also take care of the excessive bleeding that happens, especially a worry when there is an APLA positive patient who is on anticoagulants. So the intrauterine contraceptive devices are considered to be the safest option and pretty effective. We must keep in mind that the efficacy of a copper IUCD might be reduced when a patient is on immunosuppressive or a drug-modifying treatment. The reason is that the immune response mounted in the uterus by the copper becomes a little suppressed. So breakthrough pregnancy could happen in them. So a double barrier along with IUCD is advocated till they are on the DMT. And similarly, because of the reduced immunity in the reproductive organs, they could also have a higher risk of infection, which we need to keep in mind. So standard IUDs, which are not stainless steel, which is available only in China. In India, there is no stainless steel preparation, are safe with MRI because these patients might need MRI for various reasons over a period of time. So the copper IUD and if you ask a radiologist, they'll always ask the woman to upfront say whether she's on an IUCD, but studies have shown that the deflection of the progesterone system or of the copper IUCD isn't much with an MRI. And the CDC has recommended levonorgestrel IU systems, copper IUCDs, and the progesterone base, which I'll talk about a little later, as the drug of choice, or the contraceptive choice for most of the autoimmune disorders, including inflammatory bowel disease. Centroman, developed in our own country, a non-steroidal estrogen antagonist with weak estrogenic action, 60 milligram to start with for 12 weeks, followed by 60 milligram once in 2 weeks, is another very important method which is available in all public facilities even today, sold as Chaya or Saheli. It is safe in all autoimmune disorders. It does not modulate immunity, and it is safe in SLE as well. It does not increase the risk of thromboembolism. We need to be careful in women with liver diseases and PCOS when we are prescribing Centroman. Going on to the steroidal contraception, it is important to understand that the steroidal contraception could be oral or parenteral or as devices. The oral could be combined or single. When we say combined, means it has both estrogen and progesterone, versus single means it has only progesterone. Parenteral would be either an injectable or an implant. On the right side, you can see a monophasic one where all the drugs are the same composition. In the middle, you can see a triphasic one, so that at the end of the cycle, the amount of estrogen and the progesterone delivered to the woman would be much less than a monophasic one. All these are oral pills. The lowermost one, Mala N, is the one which is freely available in all public facilities. See, it's also important to understand and know that the first ever pill in the 1950s contained, look at the stark reduction now, contained 10 milligram of norethinorelvir as the progesterone and 150 micrograms of menestrol, which was the estrogen, which has now come down to a standard low-dose pill of 30 micrograms of ethinyl estradiol, a synthetic estrogen, and 0.3 milligram of norgestrel or 0.15 milligram of levonorgestrel. It's important to know this. We have also come down in the formulation from low dose to very low dose to newer pills which are mini dose. That means up to 15 micrograms of ethinyl estradiol is enough per day to achieve contraception over a month. It's important to know this because I had said that estrogen will enhance immunity. So those who are on OC pills, which are low dose pill, that means the 30 micrograms, are likely to benefit of going into the remission, but probably not with the mini dose. Progesterones again have changed from first to fourth generation. The fourth generations like the drospirenone and the Dynogest are much more user-friendly with minimal anti-mineralocorticoids or anti-androgenic side effects. The third generations are the standard levonorgestrel, desogestrel and the etonorgestrel. It's important to know this because the progesterone-related problems are more likely to be seen with levonorgestrel. That means if progesterone were to worsen a disease, it is more related to levonorgestrel. So we could always choose another preparation which has a different progesterone in it. The transdermal delivery, the delivery through a patch or a gel or a spray is available globally but not available as of now in India. What is available is a newer ring which is a vaginal ring worn inside the vagina once in 28 days, changed every 28 days, containing etonorgestrel and ethinyl estradiol, which is also available in India, which would do the same with, and the advantage of bypassing the hepatic first pass metabolism. Injectables, we can have a combined one or a progesterone only. The progesterone only dipomethylhydroxyprogesterone acetate, called as Antra, is available in all public facilities, contains 150 milligram of dipomethylhydroxyprogesterone acetate, norethistron enanthate is the other one. The monthly cyclophem is not available, which contains both progesterone and estradiol. Once daily spray neosporin is available globally but not in India. So the injectable ones could also have either progesterone only or estrogen and progesterone. In our country, only the progesterone only preparations are available. The implants, which would deliver only progesterone through a small little rod kept for standard recognition on the left arm in the inner aspect of the arm, Started as Norplant, 6 rods, came down to 2 rods of Norplant, and is now available as Implenon or Nexplanon, which has only single rod of 68 milligram of etonorgestrel. It is very much available in all public facilities, and the process of insertion is very easy because it is available with an inserter. Contains only progesterone. Progesterone only pills are every day to be taken one pill each. The problem here is that the period of time with which there could be a breakthrough pregnancy is as short as 3 hours. That means if a patient is used to taking it 8 a.m. every day, and if she misses it up to 12 noon, she is likely to have a breakthrough pregnancy, because not all of them are going to inhibit ovulation. So that is the downside of the progesterone only pill. It is very much available in Indian market and is very useful in patients where we do not want to give estrogens, and even in pubertal patients has a slightly higher failure rate. Let's look at the adverse effects of the hormone contraception. The ethinyl estradiol is a potent activator of hepatic enzyme production, can come with drug interaction, especially with methotrexate and mycophenolate. It can reduce its efficacy, and these drugs can reduce the efficacy of the OC pills, resulting in a breakthrough pregnancy. And of course, it increases the risk of arterial and venous thrombosis, which is the biggest downside for us when we have patients who are APLA positive with any of the autoimmune disorders. Progesterone, synthetic, are safe. They do not increase thromboembolic phenomena. To be remembered is that the 4th generation drospirenone unfortunately has a 2 to 3-fold greater risk of venous thromboembolism. Dipomedroxyprogesterone on a long-term use can cause thrombosis, should be avoided in patients who are APLA positive and in patients who are osteoporosis, because it is associated with worsening of the same. And of course, they can also cause carbohydrate intolerance in patients. Looking at the specific disease flare in contraception, rheumatoid arthritis, anti-CCP negative, benefit with high doses or low dose but not very low dose of COCs. As I mentioned, the 30 microgram ethinyl estradiol would put the patient into remission. Stable SLE without APLA, the disease flares have not been reported and have been recommended by most of the bodies that it can be used without increasing the disease flare. Autoimmune thyroiditis can be undergo temporary remission with high or low but not very low dose. Multiple sclerosis, the disease can get exaggerated. Here progesterone makes a difference, and progesterone with levonorgestrel should be avoided in them. Inflammatory bowel disease, also the disease can get flared. Skin diseases, please avoid progesterone whenever there is a skin manifestation of the autoimmune disorder. Long-acting reversible contraception, LARC, includes copper T380A, the implants and the LNG IUS. That means they would have either copper or only progesterone. And they have been advocated, they have been found to be the most superior, most safe and efficacious contraceptive use for a patient with autoimmune disorder. About the copper IUCD, I already mentioned the do's and don'ts in patients who are on immunosuppressive drugs. And in that case, a double barrier along with the copper IUCD to tide over the time that she is on DMT may be used. Emergency contraception, we have various methods. The progesterone only can be used even without a problem in patients of autoimmune disorders. The catch line is we should not deny a patient emergency contraception if she seeks for, but please avoid high-dose COC method, which is the USUPS method. Permanent method, of course, remains the best method if she is decided to understand that evolving disease and the problems would be detrimental to her own health and limits herself to one child or has completed a family, should be seriously offered, and all anesthesia consultation before we can make them fit, and converting them over from the anticoagulants oral to the heparin, etc., to tide over the operative time. Medical eligibility criteria puts each of these contraceptive either into 1, that means no restriction of use, to 4, where it is unacceptable health risk. So let us look at SLE. Copper IUD in a patient who is positive for anti-phospholipid antibodies is the only one. All others are either 3 or 4. Whereas in a patient who is completely stable SLE without APLA, all of others are 2 and copper remains 1. Rheumatoid arthritis, most of them are either 2 or 1. So look at the implants. They are very, very user-friendly, safe and efficacious even for multiple sclerosis as well as rheumatoid arthritis. The American College of Rheumatology guidelines have divided these methods into highly effective, effective and less effective. As you can see, the highly effective are only the LARCs. not even the combined oral contraceptive pills, which are only effective because we have to make provision for patient forgetting one pill or some drug interaction happening and so on. So the failure rates is less than what is traditionally mentioned here. This is what is relevant for a patient with autoimmune disorder. So for a positive APLA test, use IUCDs or progesterone only pill, which are however less effective. Avoid combined estrogen-progesterone contraceptive. And for those who are negative for APLA, non-SLE rheumatoid disease, any of the LARC, including the implants and even the OC pills are recommended. For SLE low disease activity, SLE IUDs, the progesterone implants are recommended along with even the progesterone only pills or the OC pills, but OC pills would be a second choice. And in SLE with moderate high disease activity, better to avoid OC pills as well. Avoid DMPA in patients who are having osteoporosis or are at a higher risk for osteoporosis. In patients who are on immunosuppressants, use IUCD along with barriers, and at no point of time deny them an emergency contraception. Use barrier, double barrier, if cannot use any other method for any other reason. It's very important for counseling and guiding and a guiding hand for the patients who are suffering to provide a support structure. Absence of counseling can result in misconceptions, suboptimal treatment choices. They may miss out on the effective treatment and remain unaware of the potential side effects. Beyond the physical aspects, the emotional and the psychological strain of living with an autoimmune disorder and its own problems also needs the counseling and handholding. The contraceptive counseling has been emphasized even by the American College of Rheumatology's guidelines and must be initiated so that the patients get sensitized and could be referred to a gynecologist when the service arises. So to end, I would say the decision on the contraceptive method should be a collaborative effort between the multidisciplinary team and the patient. Most important is the patient's wishes and her choice and her ability to comply with a particular method. And of course, the balance has to be between the type of the disease, the drug interactions, the teratogenic drugs, and the immunosuppression. Thank you very much for your patient listening. These are my references. Thank you and greetings from the Women and Child Block of JIPMO.
Thank you, Madam, for your elaborative discussion on the much needed topic, because this discussion will inspire the physicians who are dealing with the disease to think of counseling, counseling the patients for need of contraception, and as well as the gynecologist who will counsel them for contraception. They will be aware of the deeper insights of this, the different aspects of the disease. Thank you, Madam.
Thank you. Thank you very much.
Due to paucity of time, we will proceed to the next session. Any queries will be like discussed in the lunch time in one-to-one discussion with the faculty. Thank you.
Thank you, ma'am. Please proceed towards the felicitation arena. For the next talk, may I request Dr. Sisir Kumar Mahapatra, President IRA Odisha, Dr. Babita Panda, Consultant and Founder, Future Fertility Center, Dr. M.K. Chotrai, Ex-President IRA Odisha, to kindly chair the session.
Don't worry, sir. So, dear friends, you will have another talk that will suppress your hunger and you will never feel sleepy. In the continuum of this session, we have another legendary and luminary speaker. if you have gone to airport after your security checkup, you find a room that is waiting for the flight. So also if you go to Prachi Research Center, eyes closed, if you open your eyes, you will find you are in that airport. And that is 24 hours open, and that is a IVF research center leading to a intrauterine life. That a life is produced and life is given to the couples who have no issues. So for that we have a very prominent speaker, nationally acclaimed. He is none other than Professor Purnachandra Mahapatra. And I will request my co-chairman Dr. M.K. Chottai to kindly in one word can say about his CV. And Madam is here also, if she likes can speak on, or you can give the concluding remark. Thank you.
I think Dr. Mahapatra need not require any introduction because people know him. He's a prolific speaker, he's a good teacher, he's a good human being, and he is the ex-president of FOCGI, and he has got many awards. To the most revered doctor of Cuttack and the state, he is regarded as a god to many couples who are infertile or who are anxious of child. Anyway, he has no time. At 3 a.m., 2 a.m., you will see Dr. Mahapatra in his clinic with a laugh in his smile, the smile in his face. So I'd request him to start his talk on navigating infertility in autoimmune diseases, impacts and the therapeutic approaches. Whatever subject you give, he is a prolific speaker. I remember in IMA we had given him old age and some impact. He talks so nicely, it was spellbound. So I request Professor Mahapatra to talk it. Thank you.
Revered chairpersons, distinguished star speakers from various parts of the country, organizers, particularly Jyoti, I am really impressed with the academic activities today. From morning, 4.5 hours were discussed on various aspects related to the gynecology. I bring greetings from the place of Lord Jagannath. Today, I don't know about the Indian Rheumatology Society. I know about the FOXI, Federation of Obstetric and Gynecology Society of India, where many of my members are there. Today, there are 13 international and national CMEs and conferences across the country. I always say, gynecologist, please refrain from academic obesity for that. You do less for that. And what is the difference between this conference and the other conference? I must say one thing, that the definition of a conference is a conglomeration of elite people where one alone knows nothing. And together with the group, after knowing many, many things, cannot do anything. But this conference is something different. As rightly pointed out by Jyoti, it is a crosstalk. It is a crosstalk between the rheumatologist and the infertility specialist. And that is the main concern today. And for the last 4.5 hours, we have heard legendary speakers telling about the various topics. I think it is a spellbound. Many gynecologists might not be knowing that, and today they have benefited out of it. At the same time, I must say that when I was a student and in the early part of my teachership, when the topic related to immunology, genetics, endocrinology was being taught, it's a very good hypnotic dose for the audience. I don't think that this will be repeated today because all star speakers have all kept you awake. Even they have skipped the lunch also for the talk for that. I'm really grateful to you. It is said that if you are not able to convince, at least confuse. I'm not standing here to confuse you people. You know a lot about the autoimmune diseases by the various speakers, and my job has been very simple after the talk. And I will just narrate what is the relationship between autoimmune diseases to the gynecologist and the fertility specialist, and few situational analysis of my own observation of the cases I will cite it, so that it will be beneficial for the clinicians. We are researchers, not from the beginning, we are clinicians. And the research will follow the clinicians thing basically for that, and therefore I will just elaborate as a clinician's perspective whatever the content of my talk today. So navigating infertility and autoimmune diseases, impacts and therapeutic approaches, I have not selected. The organizing secretary and the only one, Jyoti, has given this talk to me, and I see various topics. Impact is a word he is there. Many times he is employing that. So ultimately, he wants what is the impact. Not that theoretically everything will be done that. And what is the impact on the fertility specialist as well as the rheumatologist. That is the main concern of today's. Now, autoimmune infertility, what do you mean by that? When the body's immune system adversely affects the reproductive organs or interferes with the process of successful conception. These things we are not, early days we are not finding out. Now, when we do all investigations and 15% of the cases, we find that there is a unexplained infertility. Everything is normal. Why she is not conceiving? Second important aspect, she is conceiving, but an embryonic pregnancy, missed abortion, all these, and recurrent pregnancy loss. These are mainly the concerns of today. I remember in early days, when there is an embryonic pregnancy, we say that it's a defective germplasm. It is a defective germplasm for which, from the beginning, either the sperm or the ovum or the fertilized embryo is defective. It is just a brainwashing to the patient. I think we were just telling the patients wrong things because we do not have some gadgets available in that time. Now, these infertility specialists, this rheumatologist has given some insight as to the diagnosis, as to the detailed investigations protocol, as well as the various compounds, the treatment modality for that also. I remember when I was a teacher in the early 1980s, the patient come with rheumatoid arthritis with pain or SLE. The only thing is that two drugs, prednisolone and anti-inflammatory analgesics, that's all. We don't go for other drugs. Now you have seen the great doyen of rheumatologists has explained what are the different spectrum of the drugs that are used, starting from the HCQ to the cyclophosphamide to the methotrexate, all range of DMRDs. I think that is very important, and we must select what is important for us for relation with the infertility, and more important, once she is pregnant, how the effect of pregnancy on the fetus and mother would be. And that should be the ultimate thing, and that is the impact. And it can affect both male and female infertility for that. So the spectrum of affection female infertility, I must say there are a lot of legendary fertility specialists, Bhavita is there. This is a very common thing nowadays, premature ovarian insufficiency. We know that the female's age are one of the most important determining factors for female infertility. So we say that after 30, it declines. After 35, it declines much more. If you do an AMH, it's there. And this is the social change when we find the career-seeking women, late age of marriage. These are mainly found for that. But there are some sect of population, even less than 30 years, we found that there is a premature ovarian insufficiency. And this we have seen. You do an AMH, it will be hardly 1.2. Borderline AMH will be there for that. That is the main concern for that. More important is the quality and quantity of eggs. The quality of eggs should be there first. So even if there is an ovulation, you do an ultrasound, you need an ovulation for that. And there is a pregnancy, patient become very happy, UPD positive, and then after 15 days, bleeding. So I always say, I'm not happy with pregnancy test. I'm happy when the healthy baby will come in the lap of the mother, then only I will be happy for that. So the quality and quantity of eggs is important determining factors for that. And this is cannot be detected as earlier we told about the defective germplasm. There is something which is there, our booster antenna is not able to capture that, and now the gadgets have really improved it. And I think the way forward, after 10 years, it will be revolution. Many other things could be coming, but artificial intelligence will come. Then implantation failure. It's a headache for the fertility specialist. Implantation failure is really an enigma for that. And of course, miscarriage. All these are the spectrum of affection of autoimmune diseases in female. And male, either a sperm production or count and motility, these are the main factors in male infertility for that. And about the pregnancy complications, a lot have been told. RPL is a common thing. Preeclampsia, GDM, preterm birth, IUGR, IUFD. All obstetricians must see that. One word about the preeclampsia. We were read that preeclampsia is a disease of the third trimester. But if it is removed from term, think autoimmune disease, think Apla syndrome. And if it is second trimester, at 26, 28 weeks there is a preeclampsia, or 20 weeks there is a preeclampsia, it is not related to the conventional preeclampsia pathology. It is something related to the autoimmune disease. That's a very important factor. I will tell about the clinicians to understand that. IUGR, IUFD also a spectrum of manifestations for that. So now, what are the autoimmune diseases and infertility you see? Thyroid, autoimmunity. We do a TSH everywhere. Normally, in early case of infertility comes, we do a TSH, and if the oligomeric cycle is there, we do a prolactin. But what is the role of anti-TPO antibody? I think there is a now growing evidence that the anti-TPO antibody is a very important factor, particularly in infertility for that. And Hashimoto's thyroiditis and Graves' disease are examples of this also. TSH, T3, T4 absolutely normal, and anti-TPO antibody is high. You treat it and get a result for that also. Type 1 diabetes, we don't very often see, but it is seen. Then the most common is SLE. We see a lot of SLE. Many patients come with SLE for that, and I have seen a lot of SLE. And the impact of the pregnancy on the mother as well as the fetus, we understand that. Apla syndrome, day in and day out we discuss Apla syndrome for that. And now Apla syndrome, the treatment management of Apla syndrome and diagnosis, there are the two diagnostic criteria. One is a laboratory diagnosis, one is a clinical criteria. We give more importance as a clinician to the clinical criteria. The clinical criteria is much more important than the laboratory criteria. Even if the Apla is negative, if the clinical criteria suggested that treatment starts and the rewarding treatment of combination of aspirin with heparin, either a unfractionated heparin or low molecular weight heparin. Nowadays, low molecular weight heparin is very commonly used for that. And there is a really evidence shows that this Apla syndrome, these two combinations, the perinatal outcome is much more for that. I remember in 2005, when we proposed this low molecular weight heparin, Dr. Meher is there, all the physicians are there. I say from angina to vagina. See, we always say when we strike that Apla syndrome, you give a low molecular weight heparin. The pharma people are very much happy about that because you people, physicians, prescribe this drug for 5 days, 10 days. We prescribe even at the onset of pregnancy, once UPT is positive, not up to cardiac activity. Earlier the recommendation was cardiac activity. Now UPT positive, you start that, or even in fertility doing an IVF, the day of ET, you start this, and that will be continued up to 34 weeks. Every day up to 34 weeks or alternate day up to 34 weeks. The company people are all happy about it for that. So Apla syndrome is a rewarding thing for that. Now, the recent evidence in 2023 have analyzed whether we are right or whether we are over-treating it by the enoxaparin or not. That's a point which is going on. An ongoing trial is continuing whether we are justified in that also. Celiac disease we do not see, or even if we see, we cannot be able to diagnose that. We are not Dr. Mahapatra as a physician that you will diagnose. It's very, my mind doesn't catch that celiac disease for that. And others, rheumatoid arthritis. Yes, we have seen rheumatoid arthritis, multiple sclerosis, IBD or inflammatory bowel disease, Soren's syndrome, I've heard that. I don't know if you ask me what is Sjögren's syndrome, I don't know. And endometriosis. This is a very common problem. And at the present context, I will tell all the gynecologists. Endometriosis, the disease is really an enigma. And this endometriosis, we do not, till date, we do not find a cause. But now it has been proved that it is an inflammatory, immuno-inflammatory component is predominant in endometriosis, and that is giving rise to the pain, growth of the tumor, endometrial affection, and suffering, and also infertility. If you do, because in endometriosis, without surgery also, before surgery, if you do an AMH, AMH is borderline, AMH is low. Why? So these researchers have found out that because it is an immuno-inflammatory reaction is associated with endometrial lesion, I think this is more important to know about it. And a lot of researchers from Jyoti will benefit us in solving endometriosis. I'm waiting for your research on endometriosis to find out what is the immunoinflammatory reaction and give us a recommendation of treatment for that so that the patients will be happy and patient will be pregnant for that. And immune thrombocytopenic purpura. Again, I will tell, 15% is unexplained infertility. As we go, the conventional investigations for female and male, absolutely normal. We say that even if it's normal, unexplained infertility, that is found about 15% of the cases. And we are satisfied. All faculties of medicine, physicians, surgeons, and gynecologists say, very consoling word we use is idiopathic. So it's an idiopathic term for that. I am averse with the term idiopathic. I feel that idiopathic should be obsolete from medical dictionary and it should be replaced by what is known as cryptogenic. Even our booster antenna is not able to capture that, and we are happy by selling that it's idiopathic. My definition of idiopathic is that when a doctor is an idiot and patient's condition becomes pathetic, it is idiopathic for that also. Think about it. Think about it seriously and you can find out a cause for that. Now, diagnosis. Clinical presentation, most important. In the era of tech and touch, we are forgetting the clinical sense. I still say that clinical examination, clinical presentation, history and examination is very, very important for that. We always say that nowadays gynecologists have forgotten 2 fingers and replaced by what is known as transvaginal sonography and a telescope. We all say physicians, surgeons and gynecologists. We have the same temperament. I think the main aim is same, to relieve the suffering of the humanity. But the temperament is different. A physician says that we have got 2 brains. We can think and think anything in the world and win the world by thinking also. The surgeon tells that we have got 2 hands, we can explore and find out, win the world by 2 hands. But we gynecologists, the whole universe rests with our 2 fingers. And therefore, my dear fellows, important if the technology has improved, but tech versus touch, there should be a blend for that if you want that. And exclusion criteria, laboratory investigations, you do it as usual for that. Now management. Pre-pregnancy counseling, establishing diagnosis, I have already been told for that. But for us, the pre-pregnancy counseling must be in accordance with the rheumatologist for that. Don't forget, you cannot give a counseling alone. And in my practice, if any patient comes with rheumatoid arthritis or SLE or some other immunodeficiency, immunological disorders, autoimmunity, I will refer to the rheumatologist for that. And 6 months you will evaluate, and the rheumatologist clearance will be there, then only I will allow for pregnancy to continue for that. That is the main pattern for that. So therefore, need for interdisciplinary approach, and this is the purpose of this conference. Medical management, yes, a lot of drugs have been spoken there, but most important is the tailoring the dose and alternate medication. As a lot of questions came, whether she was taking tablets once pregnancy is there, whether you can tailor the dose or change to some other medications. That is their discussion. We cannot. We are all idiots. The rheumatologist can suggest us and guide us whether you change the drug or some other things for that. Stress and lifestyle management, this is usual in all cases for that. And need for ART, I think there are a lot of cases when the ART is increasing, IUI and IVF, there is a lot of scope for this. Counseling again, management during pregnancy to achieve a healthy mother and a healthy baby for that. That should be our main aim. And peculiarly, if you find the 2 diseases, rheumatoid arthritis and lupus, rheumatoid arthritis symptoms improve during pregnancy, but lupus worsen during pregnancy. That every gynecologist should know that. So mechanism of infertility in autoimmune disease. What are the mechanism? Hormonal imbalance, dysovulatory infertility, either ovulation disruption or implantation problem for that. And inflammation, I think this is a very important thing. So inflammatory cytokines are increased, and this cause both infertility as well as the pregnancy loss. Antibody production, adverse effect of medication should be there for that. We should know what are the adverse effect of medication for that, for the medical legal purpose and for the patient also, and increased risk of miscarriage. Male factor antibody infertility. Anti-sperm antibody is an impact on infertility, sperm motility and cervical mucus interaction. We do at that time earlier in 1980s, I was doing routinely the postcoital test. Within 6 hours of the coitus, I take a sample from the cervical mucus and see what are the, how many motile sperms are there for them. Because at that time, no ELISA test was there, nothing was there and all that. And now it is there for that. And tests like sperm, MAR, mixed agglutination reaction, immunobit tests are available for that. And the treatment when we find a male factor infertility, the immunosuppressive therapy, the corticosteroids, seminal washing and IUI and IVF are the treatment modality for that. Now, I will give a real life situations which I have come across in that this is a situation one. Mrs. X, 30 years, my own classmate, doctor, she presented, wife presented in 1990s with primary infertility 5 years. And it was investigated, stamped as unexplained infertility. At that time, ultrasound was also not available for that. So clinical examination, HSG, seminogram, all these are routine tests for that. And planned for IVF. But he told that yes, unrewarding results at that time, 10 to 20%. Now Babita is giving 80-90% result. At that time, 10 to 20%. So she was not keen. So routinely, out of curiosity, I thought, this sperm, let us see the postcoital test. At that time, I was doing it. I find the postcoital test 20 sperms per high power field, all immotile. That gives a suspicion to me. An anti-sperm antibody was not available, on steroids for 3 months. At that time, we were giving it steroids for 3 months, but no effect. Then I called both of them. I told that you adopt a barrier method of contraception. They reacted. We have come for conception, you are advising contraception? I told that yes, you are just barrier method of contraception for 3 months and then report after 4 months for that. And she agreed, but spontaneous conception after 4 months, she presented and a term female child was delivered. And this is the reason why simple clinical acumen, you can know that it is something defective on immunological factors on infertility, a cervical mucus test. And therefore, this, I was very happy. They were also happy that a female child was delivered. But now when I see 2 months back she has come, she's a successful fertility specialist in UK. I was so happy and corroborating with my postcoital test for that. So the message, immunological factor infertility to be ruled out in unexplained infertility. Clinical acumen with simple tests can augment fertility. Situation 2, Mrs. Y, 28 years, diagnosed and treated for SLE by rheumatologist. Primary infertility 3 years, and she came to me. I again refer back to the rheumatologist for that also. For counseling as well as the modified medications and advice to plan for pregnancy after 6 months. She evaluated for 6 months, modified and alternate medicines can be given for that. So conceived following ovulation induction, aneuploidy screening normal, PLGF was raised, color Doppler increased risk for PIH, given aspirin 150, TIFA was normal, early onset IUGR, developed PIH in second trimester, on antihypertensive interval growth scan at 26th week, gross IUGR, oligamenous, estimated fetal weight is 500 grams. AFI is 3 centimeter, and this is a classical example of immunological factor giving rise to the pregnancy complications for that also. And the next day, IUFD following the day, and termination of pregnancy was done, macerated fetus of 480 grams delivered. Then I asked, where is my mistake? What could have been done for that? Again came back after 1.5 years, the same patient, she didn't leave me. Very keen for conception, trying period is 6 months, conceived following second cycle of IUI, put on aspirin and LMWH. I combined this. And she was on HCQ also. First trimester normal, aneuploidy screening low risk, TIFA normal, developed PIH and antihypertensive medication. Even if that's the message which I am giving, even if you are giving antihypertensive, even if you are giving heparin or aspirin, hypertension will bound to occur in these type of cases for that, and that's important. At 30th week, reduced fetal movement with severe PIH. Sonography, gross IUGR, oligoamnios, EFW 900 grams, AFI 4 cent. I was little happy under. I took a challenge, LSS was done. IUGR male baby of 950 grams delivered, and I shifted to the NICU, and she stayed for 1 month and discharged with healthy mother and healthy baby for that. I got the results out of it also with that. And that is the message which I am giving. Don't take it easy. In SLE or immunological factors in infertility, pregnancy complications are bound to occur even if we take along any antihypertensive or any other drugs for that. So SLE, a cause for infertility and pregnancy loss. Pre-pregnancy planning is significant. Frequent monitoring during pregnancy is essential. Aspirin, low molecular weight heparin, antihypertensive is rational treatment. Serial sonographic monitoring and decision for delivery important for perinatal outcome. Need for NICU and persistent effort, and clinicians' acumen augments the results for that also. Situation 3. Mrs. Z, 32 years, A3, all first trimester abortion. First, missed abortion at 10th week. Second, single live fetus by sonography at 6 to 7 weeks. Repeat scan after 4 weeks, absent cardiac activity. Third, single live fetus 7.5 weeks. Repeat scan after 3 weeks, absent cardiac activity. You need not do any test. These rheumatologists will do many tests, the LA, ACA, beta-2 glycoprotein. We also do that. But clinical criteria are very important for that. Remember, if the cardiac activity was initially present and after 15 days the cardiac activity is lost, only apply. Think about this particular case. When the cardiac activity was not there from the beginning, you think of other defective germplasm or something like that for that. So this is a very important clinician's history and find out the topic for that. Because you see the ultrasound report, you do, I always tell you, do the ultrasound report for that as a clinician and find if the cardiac activity was there and subsequently after a few weeks it has disappeared. This is definitely apply, and I will definitely treat in the next pregnancy. You cannot salvage this pregnancy. In the next pregnancy, start aspirin and the low molecular heparin, you will get a rewarding results for that also. So third was a single live fetus 7.5 repeat scan. Presented with second infertility 1 year, APLA normal, 3D pelvic scan normal cavity, DHL normal, AMH is 2.9. Conceived following ovulation induction, 5 days overdue, UPT positive, beta ICG 500. On aspirin and LMWH. The controversy is there. We were also teaching students, when you start LMWH, the recommendation in the textbook says that in APLA syndrome, when the cardiac activity is demonstrated on ultrasound, then start LMWH. Before that, only aspirin is there. The concept is changed now. Now, as soon as the UPT is positive, I think you start both. Even after ET also, we start both these things. And that the cardiac activity which is not supposed to come will appear. I have seen in few cases for that. And that's why it should be started right from the time where pregnancy is positive for that. NT scan, NIPS normal, cervical and size 14th week, uneventful pregnancy, aspirin and low molecular weight withdrawn after 34th week. We are normally give up to 34th week. In two conditions we give till delivery. One is the purpura, I think hereditary thrombocytopenia is one, and if there is a previous history of DVT, those are the cases we continue it till labor, till delivery for that also. Otherwise, you stop it at 34 weeks because with 34 weeks, we find the viability is good. An elective cesarean at 36 weeks for mild PIH, decreased fetal movement, male baby weighing 2.8 kg delivered, post-op period was uneventful for that. So the message, the classical example of APLA syndrome, clinical criteria significant than laboratory criteria, APLA syndrome cause of infertility as well as adverse pregnancy outcomes, aspirin, LMWH improves the perinatal outcome, evidence also shows for that. So, message here, this is another case, 26 years primary infertility, 5 years, unexplained infertility, history of intolerance to cold, a healthy baby and a healthy mother for that. Autoimmune thyroiditis is a cause of infertility, usually associated with unexplained infertility, anti-TPO antibody testing clinches the diagnosis. Simple supplementation of thyroid extract can yield very good results for that. So the hard facts, Jyoti, autoimmune disease 5 times more common in women. And that's why it is more common in women. That's why you have called the healthcare providers of women here in this conference for that also. And commonly seen during reproductive period. In the past, frequently counseled against conception. We were practicing against conception. Now, yesterday's contraindications are today's indication. Better understanding of the subject and need for baby in recent age has grown a new concept. Growing subspecialty of rheumatology and infertility, its impact and therapeutic approaches revealed much better, and concern about subsequent pregnancy to achieve healthy mother and a healthy baby for that. And therefore, link between autoimmunity and infertility is complex and requires a continued research. More of research is necessary. Early diagnosis and treatment of autoimmune disease can improve fertility outcomes. An interdisciplinary approach is the need of the hour. And therefore, Jyoti, this is a happy marriage between the gynecologist and the rheumatologist. I don't know who is the husband, who is the father, who is the wife, but we'll have a role reversal in subsequent seminar for that also. Thank you very much. And all, I'm really obliged to find.
Thank you so much, sir. It's always an honor and privilege to listen to the mesmerizing talk by our beloved Punna sir. And thank you so much, sir, for emphasizing this important aspect that it should be an interdisciplinary approach. And another clinical scenario, sir, describes situation 3, even if APLA negative. And when a case of RPL is coming, recurrent pregnancy loss, we should go for the previous records. As rightly said, pointed out by sir, if there was cardiac activity and it is lost after 1 or 2 weeks, then even if one case of like that, APLA negative, we should start heparin at the UPT positive, and in case of IVF embryo transfer from the 24 hours before embryo transfer. Thank you, sir. Thank you so much.
Thank you.
Sir, one thing, sir, just I would like to say, we heard only about angina in the heart. Acute angina, chronic angina, unstable angina, but today you learned there is a vaginal angina. That, huh? Yeah, you are giving. Yes, sir. And Dhanvantari is the doctor of gods. You are the representative of Dhanvantari. Thank you, sir, very much.
So I must thank all the audience for their support. I think one session will do before lunch because of paucity, and this is a very, very important topic because which I have given this topic because all the time patients come to us and tell us either oligomenorrhea or menorrhagia, we don't have any answer. We don't know which drug is causing what. So I'll like to invite our chairpersons, Professor Dr. Sujata Pradhan, sorry, Professor Dr. Madhumita Madam, sorry, Professor Dr. Sangamitra Madam from MKCG Medical College, Professor Dr. Manisha Sahu, Head of the Department, Sham Hospital, and Dr. Pratyush Rai. Please come to the stage.
A very good afternoon. Now I welcome you to this topic of autoimmune disease and menstrual irregularity. Yes, autoimmune disease is usually associated with menstrual disturbance. It usually affects the hormones, it causes a hormone imbalance. It affects the ovary, it causes autoimmune uveitis, and overall it affects the whole immune system of the body. So and I welcome Dr. Girija Wag to enlighten us on this topic of menstrual irregularity, its cause, consequence, and management. I request Dr. Manisha to introduce.
It's okay, I think.
So, no, Madam doesn't need any introduction. Madam, proceed for your talk.
Thank you so much, because I think I'm coming in between the lunch and academics have to supersede. I am Professor Girija Wag. I head the Department of Bharati Vidyapeeth University Medical College, Pune. And today I'm going to speak on a very important topic, and that's abnormal uterine bleeding and autoimmune disorders, because we both, rheumatologists and ourselves, are always dealing with this. And this has been beautifully coined by the organizers as causes, consequences, and management. Now, what are these menstrual irregularities? If you look at the FIGO system, it has defined it absolutely perfectly as normal and abnormal limits of menstrual bleeding, and this is always important to refer to this chart so that sometimes patients out of anxiety may say that the bleeding is too much, or she may say there's too much of pain, but you must understand whether it is within the normal limits or not, and it's always useful to use this particular chart. And it's also important that while you're giving treatment for rheumatological conditions, you're using the period tracker or any applications where women can track their periods, and then you can guide them appropriately. So when we look at abnormal uterine bleeding, in our gynecological jargon, we are classifying it based on structural and non-structural or functional causes. And this is a very common gynec problem. About 10 to 35% of women suffer from this, and they will present with anemia, interference with daily activities, and then a lot of anxiety whether they are having any underlying cancerous condition. Now, the common reason for referral to a gynecologist, and 5% of women between the ages of 30 and 49 years, is AUB, and iron deficiency anemia and your rheumatological conditions would all be in association contributing to anemia very commonly in these women. Actually, I would like to say that women are very lucky because they menstruate. Because the menstrual cycle is a sensitive and a dynamic reflection of a woman's health, and it serves as a window into her hormonal balance, immune function, and reproductive well-being, often revealing systemic disturbances before any other symptoms appear. Now let's look at, in tandem, the autoimmune diseases in context and how they affect. Now we all know that they occur when the body's immune system mistakenly attacks its own healthy tissues, thinking they are foreign invaders. And it affects over 80% of women, often during their reproductive years, and the mechanism is loss of immune tolerance, production of autoantibodies, and chronic inflammation. SLE, rheumatoid arthritis, autoimmune thyroiditis, diabetes, and celiac disease are very common. And why it would matter in gynecology? Because hormone fluctuations influence immune activity, menstrual irregularities may be early signs, and fertility and pregnancy, we saw wonderful presentations, outcomes can get affected. Now, when we look at this gynecological perspective on autoimmune diseases and AUB, the female reproductive system is highly sensitive to immune dysregulation. Estrogen and progesterone modulate these immune responses, and they influence the disease activity and also the menstrual patterns. And autoimmune flares often coincide with hormonal shifts, especially in the luteal phase. So if you decide to look at the common gynecological manifestations in autoimmune diseases, this is a wonderful reference table which you can use. SLE and RA will be having irregular cycles, menorrhagia, amenorrhea. Autoimmune thyroiditis would have menorrhagia and oligomenorrhea. Type 1 diabetes would have delayed menarche and early menopause. Celiac disease would have amenorrhea, infertility. Sojourn syndrome would have vaginal dryness, sexual dysfunction, and so on. And what we are concerned today is of these 4 conditions, and of course, PCOS with an autoimmune overlap would have irregular cycles and infertility. So AUB probably may be the first sign of underlying autoimmune pathology with inflammatory cytokines and autoantibodies which can disrupt the endometrial stability, and especially immunosuppressive therapies such as corticosteroids and methotrexate may exacerbate or mask the AUB symptoms. And usually it is misattributed, and rheumatologists should therefore consider autoimmune etiologies in persistence of unexplained menstrual irregularities, and here is a place for collaborative evaluation with gynacs. And autoimmune diseases also can impair ovulation, implantation, and placental function. And therefore, if you have a woman in reproductive age group, it's important that she's guided for preconceptional care in case she's planning her future pregnancy. Now, why are women more affected by autoimmune diseases? We have already studied, and this is a wonderful publication from Nature 2024. that 2 X chromosomes in females can lead to immune overactivity. Estrogen enhances immune response and hormonal fluctuations, and there is a greater immune system sensitivity in women. And because of these 2 chromosomes, instead of 1 in men, there is an overproduction of proteins. 1 X chromosome is inactivated in each female, and X chromosome inactivation creates unusual molecular structure that can trigger immune responses. So the ZIST molecule attracts proteins that are often targeted by autoantibodies, and some genes would escape inactivation to higher expression of immune-related genes in women. Now, estrogen is known to enhance immune activity, increasing susceptibility to autoimmune reactions, and hormonal fluctuations during the menstrual cycle can modulate these disease activity. So what is the clinical impact? Women would represent 80% of autoimmune disease cases, and diseases like SLE and Sjögren's show extreme gender disparity. So now let's look at Reshma, 28 years, presented with irregular cycles, fatigue, and dysmenorrhea. Initially was treated as PCOS, but symptoms worsened. Then she started developing joint stiffness and cyclical skin rashes, and she was referred to rheumatologists, diagnosed with SLE. Menstrual issues were part of a systemic autoimmune process, managed with immunosuppressants for hormonal therapy, and then she was suggested for fertility preservations, cycle stabilized, and pregnancy planned under joint care. So the questions today are, why are there menstrual irregularities or AUB? What are the consequences, and how are they to be managed in women with autoimmune conditions? Now, HPO axis is known to regulate the menstrual cycle via hormonal signaling from the CNS through GABA and KND cell peptides, influencing the GnRH release from hypothalamus. And GnRH is known to stimulate the pituitary to release FSH and LH, which act on the ovary, and the ovary secretes estrogen, progesterone, and inhibin, which feed back to the brain to modulate hormone release. And the mechanisms of AUB in autoimmune diseases would be also at a regional, local level at endometrial inflammation, where there is autoimmune activation, which leads to chronic endometrial inflammation, increased cytokines and immune cell infiltration, which will destabilize the endometrial lining. Autoimmune diseases such as thyroiditis would affect the HPO axis, leading to anovulation and unopposed estrogen, which causes endometrial hyperplasia and irregular shedding. And there can be problems with coagulopathy and vascular fragility as seen in APS. And vasculitis in diseases like SLE can cause fragile endometrial vessels. And there can be autoimmune linked adenomyosis, where there is ectopic endometrial and myometrial infiltration of the endometrial cells, precluding the processes of hemostasis during menstruation. So the composition of menstrual fluid has been recently studied, and the recent advances to understand the endometrial environment, a narrative review, and it has found that there is a lot of tissue repair and inflammation sequencing which is responsible for these various diseases, which give rise to hypoxia, increased inflammation, hemostasis, and reduction in vasoconstriction. Now, if you look at SLE, the contributory factors causing menstrual irregularity and ovarian failure and infertility in women, it involves many organ systems. The ovarian function is compromised with autoimmune oophorytis and by gonadotoxic effects of cyclophosphamide. In addition, hormonal imbalances and altered HPO axis can further contribute to ovarian dysfunction, culminating in menstrual irregularity, infertility, and sometimes premature ovarian insufficiency. Similarly, in autoimmune thyroiditis, there is an inflammatory damage to the ovaries, and with aging, these autoantibodies may impair both thyroid and ovarian function, reducing the ovarian reserve, and lower ovarian reserve may be associated with milder PCOS phenotypes, and the key markers would be AMH, anti-TPO, and anti-TG antibodies, which can help us in understanding these conditions better. Menstrual homeostasis can get affected in APS and SLE, where there is impaired clotting, increasing the risk of HMB, that is heavy menstrual bleeding, and vasculitis, causing endometrial vessels to become fragile. So if you decide to map the autoimmune diseases and menstrual abnormalities, you will find that each one of them would have a peculiar presentation from pain to altered bleeding, to irregularity, to heavy menstrual bleeding, and these have to be properly factored for and understood, and this can be done with a collaborative care towards their needs in medicine. Now, how do immunosuppressants and corticosteroids affect menstrual cycles? Now, the mechanism would be at the HPO axis suppression, and this would disrupt follicular development and ovulation. There can be a direct ovarian effect and causing ovarian toxicity and premature ovarian insufficiency. And there can be alteration in the estrogen-progesterone balance, and systemic effects such as weight changes, insulin resistance, and adrenal suppression can be responsible for these conditions. Now, the question is about the DMARDs. They may also influence menstrual cycles through immune modulation and hormonal shifts of systemic effects, and all these various abnormalities in menstruation can be influenced by DMARDs. So let's look at certain drug-specific insights. For example, methotrexate will cause possible amenorrhea and hormonal disruption. Luflunomide variable may affect hormone metabolism. Azathioprine potential hormonal modulation. HCQS general cycle can be neutral, and sulfasalazine may cause minimal direct effect on menstruation. So contributing factors and clinical tips are underlying autoimmune disease, stress and nutritional status, liver metabolism, affects hormonal clearance, and concurrent meds can influence, and it's therefore important to encourage cycle tracking during these therapies, counsel patients on possible variability, and refer for evaluation if persistent irregularities occur. So when we look at this management, always identify the underlying cause, why there is hormonal imbalance, or is it because of the medication effect, and screen for all these disorders. And whenever there is a hormonal regulation to be taken into account, you can use the combined pill, progestin therapy only, either locally, injectable, or orally. GnRH analogs can be used as they suppress the HPO axis and can be used temporarily at the time of serious flare. Egolix is a new block on the kit, the GnRH antagonist, which is known to reduce estrogen progesterone and reduce heavy bleeding with fibroid, and this can be overlapped. And there can be ormaloxifene, which is known to be an estrogen receptor modulator, which can be considered in non-structural AUB or autoimmune thyroiditis without any other influences with the medicines that are used for the patient's condition. Immunomodulatory therapy would it's essential to optimize to control disease flare, and it's important to avoid gonadotoxic agents when fertility preservation is a concern. And it's very important to discuss all these things with the patient if she wants to freeze her embryos or optimize her preconceptional health. Lifestyle and supportive care is very important through interventions on stress and a healthy weight, regular physical activity, sleep hygiene, psychological support through as she's going to suffer from a chronic illness and have reproductive challenges, and joint management by rheumatologists and gynecologists would ensure holistic care by regular cycle tracking, disease monitoring, and treatment adjustments. So we gynecologists can assist in hormonal regulation, managing AUB and fertility issues, and monitoring reproductive health, while you, rheumatology specialists, could screen for menstrual and reproductive symptoms, refer early for gynec evaluation, and adjust therapy based on reproductive goals. So in the end, I would like to thank you for this wonderful invitation and give a message that collaborative and preservative care for women is not just a clinical approach, it is the need of the hour. And by uniting specialties, we safeguard not only health, but hope, dignity, and the future of feminine well-being. Thank you so much for this time.
Thank you very much, madam. You have finished before time itself.
Because there was lunch.
And that too, what we find that AUB, what is the classification, ultimate result is actually inflammation and some sorts of immunological effect. And when the patient is with established any rheumatological condition, we should think about what drugs they are taking, and for that whether they are having irregular cycle or not.
It works for us also, madam. Sometimes we have patients presenting with AUB and they are not responding to regular treatments. Always consult a rheumatologist. Maybe she is having an underlying disease, especially in young girls, in puberty, menorrhagia, or peri-adolescence. When we have ruled out everything, it's always a good practice to consult a rheumatologist. It could be something else.
Thank you, madam, very much.
Okay, thank you, madam. As we know that in RPL or infertility, this immunological part is very much established. But in menstrual irregularity also, we should, as clinicians, we should keep in mind that there might be some factors like immunological factors. So we should have that in mind during treatment. Thank you, madam.
Thank you.
So thanks to all participants for staying with us, and thanks to ma'am for finishing in time. So we'll have a quick launch. Before that, I'll request all the poster participants to be there with the posters because the judges are ready. And after their evaluation, they can go to the lunch area. And we'll have a quick lunch and we'll start the session by 3. Now we'll have a half an hour lunch session. So please cooperate us and be here by 3 o'clock so that at least we can catch the time. Thank you. And all the faculties are requested to go upstairs. Section, which is management of recurrent pregnancy loss. So, Professor Dr. Sitaram Mahapatra sir. Next chairperson, Professor Dr. Sanjay Jangid. Sanjay, you are here. And Dr. Prashant Kumar Nayak from Oasis Infertility. I think he has not reached. Okay. Sir,
so, may I have the privilege to invite Dr. Durga Prasanna Misra, Additional Professor Clinical Immunology and Rheumatology, SGP GIMS, Lucknow, for the next talk. Dr. Mishra is Editor-in-Chief, Indian Journal of Rheumatology, research interest in Takashau arthritis and ANCA vasculitis, cardiovascular risk in rheumatic diseases, a systemic reviews and guideline development, more than 300 peer-reviewed publications. That's very high. It's quite a good number. H index is 40 and I-10 index is 141. IRA Young Rheumatologist Oration Award in 2019. Dr. Surveer Singh Trust Visiting Professorship in 2020. Dr. Rathin Velu Subramanian Endowment Oration in 2020. This is wrongly typed, I think, 2026. Member Steering Committee 2025 update on the ellular recommendations for LVV and PMR. Is Member Executive Committee of the Indian Rheumatology Association from 2021 to 2025. Dr. Misra, please start your talk.
Thank you, sir, and it's a great privilege to come here on the invitation of Jyoti Bhai to speak, and more so because Sanjay and myself trained together. Seems like more than 15 years back, and for him to chair this session is a great privilege for me. So without much ado, I'll start my talk. So the remit of my talk today is to discuss management of recurrent pregnancy loss in antiphospholipid antibody syndrome, anticoagulation therapy and beyond. I do not have any disclosures. We shall briefly discuss what antiphospholipid antibodies are, what are the definitions of obstetric APS and how they lead on to pregnancy loss. How can one predict adverse feto-maternal outcomes in recurrent pregnancy loss in the presence of antiphospholipid antibodies, and how can we manage this condition with anticoagulation and other measures, some experimental, before we conclude. So what is the association between antiphospholipid antibodies and recurrent pregnancy loss? So antiphospholipid antibodies are broadly three types of antibodies: anti-cardiolipin antibodies, anti-beta-2-GP1 antibodies, which may be IgM or IgG, and something called as lupus anticoagulant, and then there are various others, amongst which the important one is anti-phosphatidylserine phosphatidylthreonine antibodies. What is important to understand is that they are associated with a variety of clinical manifestations, some of which include thrombosis and others which include recurrent pregnancy loss, amongst other features. Now, these antibodies, if they are persistently present in the circulation, then the risk of thrombosis and adverse obstetric outcomes is higher. However, even when these antibodies are present in the circulation, very many times the patient is silent. So that's why it is proposed that alone the presence of antibodies is not sufficient. A second hit, such as an infection, to cause an endothelial injury, and in the presence of such an endothelial injury, these antibodies lead on to further thrombosis. This beta-2-GP1 is something which is expressed by the endothelium at times of stress, but interestingly the placental endothelium expresses it constitutively. That's why the presence of antiphospholipid antibodies leads on to adverse pregnancy outcomes. And in patients with pregnancy losses who otherwise do not have any autoimmune disease, the prevalence of lupus anticoagulant, cardiolipin and anti-beta-2-GP antibodies is as high as 1 in 6. And it is the persistent presence of antiphospholipid antibodies that characterizes antiphospholipid antibody syndrome. So please mark the persistent presence. So pregnancy outcomes in patients with antiphospholipid antibody syndrome, which is per se a rare disease. So in this long-term cohort of 55 pregnancies after a diagnosis of antiphospholipid antibodies, one can see that the composite outcome of preterm live delivery less than equal to 37 weeks, preeclampsia, eclampsia small for gestational age or placental insufficiency or unexplained fetal death after 10 weeks was 9 out of 40. So that's quite a high proportion of pregnancy morbidity. And the pathogenic mechanisms involved are reduced invasion, altered vascular effects on the trophoblast, as well as local inflammation, in which interleukin 1 beta has been one of the molecules that has been implicated, and also complement activation that occurs at the site of the placenta and the trophoblast. So what is obstetric APS? Is defined as presence of at least 3 consecutive miscarriages before week 10, or at least 1 fetal loss after week 10, or a premature birth at 34 weeks or before due to preeclampsia, eclampsia or placental insufficiency. And there are times when such patients may not meet these criteria. For example, there are 2 consecutive fetal losses, but if you have presence of antiphospholipid antibodies persistently, then also you might need to consider whether these patients have features to suggestive of obstetric APS. And the recent classification criteria from the American College of Rheumatology and the EULAR again reiterate these features as suggestive of obstetric APS, that is pre-fetal death, death less than 10 weeks of gestation, or fetal death greater than 10 weeks of gestation, preeclampsia with severe features, or placental insufficiency with severe features. And how can one predict adverse feto-maternal outcomes in recurrent pregnancy loss with antiphospholipid antibodies? So in this study of 33 women with antiphospholipid antibody syndrome, it was found that if they had an umbilical artery end diastolic flow that was abnormal at 24 weeks, it had a positive predictive value for later IUGR or preeclampsia of 67%. And if it was normal, then the negative predictive value was 93%. So this is per se in pregnancies, umbilical artery end diastolic flow in mid-pregnancy is assessed, and this is an important prognostic indicator. Again, in this large cohort of 100 individuals with lupus and APS, the predictors of adverse pregnancy outcomes, if you look at the highlighted box, you can see that abnormal second trimester Doppler ultrasound had the highest odds ratios for a prediction of an adverse pregnancy outcome, as well as for prediction of neonatal and fetal deaths. So this is one test that can help predict in patients with lupus or with antiphospholipid antibodies whether they are going to have an adverse pregnancy outcome. And as we had alluded to, complement pathway activation plays an important role in antiphospholipid antibody syndrome. And here, the important perturbations are in the alternative pathway, which can be identified through elevated levels of a molecule called as BB and a complex of C5b to C9, which indicates overall complement activation. And this is what they found in a study, a large study of patients with lupus with or without antiphospholipid antibodies, compared with pregnant healthy controls. The presence of this alternative complement activation at 12 to 15 weeks was a strong indicator of an adverse pregnancy outcome in these individuals. So also in patients with antiphospholipid antibody syndrome alone. So now coming to the management of this condition. The mainstay of the management is low dose aspirin. It is recommended for all patients with antiphospholipid antibodies, whether they have antiphospholipid antibody syndrome or not, and also for all patients with systemic lupus erythematosus during pregnancy with a high risk APL profile. So what is a high risk APL profile? That is, these antibodies need to be present persistently at least twice, documented 12 weeks apart. The presence of lupus anticoagulant alone, double or triple positivity for lupus anticoagulant, anti-cardiolipin antibodies and anti-beta-2-GP1 antibodies, or persistent high titers of IgG or IgM anti-cardiolipin antibodies or anti-beta-2-GP1 antibodies greater than the 99th percentile. The evidence base for recommending low dose aspirin in this population of patients is based on meta-analysis of observational studies, some of which were retrospective. So the evidence base is not great, but in individuals who have presence of antiphospholipid antibodies, irrespective of whether they have had previous adverse pregnancy outcomes or not, and also in all patients with lupus, particularly those with a high risk antiphospholipid antibody profile, one should treat them during pregnancy with low dose aspirin. Now, what is the data to support the use of heparin in addition to low dose aspirin in patients with recurrent pregnancy loss and antiphospholipid antibodies? So in this randomized controlled trial, we shall be discussing 4 trials, 2 of which are positive and 2 of which are negative. So in this particular randomized controlled trial of patients with recurrent pregnancy loss with persistent anti-cardiolipin antibody positivity, the use of low dose aspirin with heparin was superior in terms of live births to low dose aspirin alone. In the second study, which was again individuals with recurrent pregnancy loss with persistent anti-cardiolipin antibody positivity, and it was a RCT comparing low dose aspirin plus heparin versus low dose aspirin alone. As you can see in the graph also, the proportion of live births was higher with low dose aspirin versus when combined with heparin versus low dose aspirin alone. These were studies from 96 and 97. However, more recent studies have not confirmed these findings. This was another study from 96 which took individuals with recurrent pregnancy loss with persistent lupus anticoagulant or anti-cardiolipin antibody positivity, and the proportion of live births was 78% in the combination group versus 72% in low dose aspirin group. However, overall near about 75 to 80% of pregnancies had a good outcome in this study, which is relatively high for this risk population. And this was another RCT published in 2009, where again 45 patients with recurrent pregnancy loss with antiphospholipid antibodies or thrombophilias or simply antinuclear antibody positive were randomized to receive low dose aspirin plus heparin or 43 with low dose aspirin alone. Again, the proportion of live births was not dissimilar between the two groups, but near about 80% had good pregnancy outcomes, which is relatively high for this risk population. Now, whether to use unfractionated heparin or low molecular weight heparin, this was a prospective cohort study which showed similar pregnancy outcomes when these patients were treated with low molecular weight heparin or unfractionated heparin. And this was a randomized controlled trial of 30 individuals each, randomized to receive enoxaparin, that is low molecular weight heparin plus low dose aspirin, or unfractionated heparin plus low dose aspirin. And as you can see here, the proportion of live births and the odds ratio for a live birth was not statistically different between the two groups. So they were associated with similar outcomes. Therefore, it can be concluded that you can use either unfractionated heparin or low molecular weight heparin for prevention of recurrent pregnancy loss in the presence of antiphospholipid antibodies. Now, the dose of heparin that is recommended is, if you have a prior thrombosis, then you need to give a therapeutic dose of heparin. There is no doubt about that. But if you do not have a prior thrombotic event and you simply have obstetric APS, then you need to give a prophylactic dose of heparin along with low dose aspirin. However, if such a strategy results in an adverse pregnancy outcome in the index pregnancy, then in subsequent pregnancies you can consider a higher dose of heparin, that is a therapeutic dose of heparin. In individuals with recurrent pregnancy loss, it has been noted in multiple randomized controlled trials held since the 1990s that the outcome of live births was higher in those who had received IVIG as opposed to those receiving a controlled treatment. So it was also hypothesized that this might hold true in individuals with antiphospholipid antibodies or antiphospholipid antibody syndrome. 2 studies have looked at this. This was a randomized controlled trial wherein IVIG was given to 7 patients with antiphospholipid antibodies from 4 weekly till 36 weeks from conception, and 9 not on IVIG. The pregnancy outcomes were similar in either group, and the neonatal outcomes were also similar with or without IVIG. And this was this other RCT which compared a strategy of giving low molecular weight heparin plus low dose aspirin versus IVIG. And actually the proportion of live births was higher in those receiving low dose aspirin plus low molecular weight heparin rather than those receiving IVIG. So IVIG is not a substitute. Now this is a meta-analysis done from the Cochrane group which compares low dose aspirin or IVIG alone versus low dose aspirin plus heparin from 4 studies. And if you look at the forest plot, the summary estimate is of risk ratio of 0.46. That is a 54% chance of a better pregnancy outcome with low dose aspirin plus heparin when compared with low dose aspirin or IVIG alone. Hydroxychloroquine is something that we routinely give to patients with antiphospholipid antibody syndrome, and in obstetric APS also cohort studies have shown its role. In this retrospective cohort, the proportion of live births was higher in those receiving hydroxychloroquine versus those not receiving hydroxychloroquine, although the absolute risk estimates were not very different. And this study also shows that pregnancy losses before hydroxychloroquine, 80% of these ladies had pregnancy loss, whereas after hydroxychloroquine only 20%, which is quite a large effect size. And hence hydroxychloroquine being an innocuous, safe drug, it is preferable to give it in patients with antiphospholipid antibodies syndrome, particularly when they are planning pregnancies. One study has looked at statins. This was published in the Journal of Clinical Investigation, wherein patients were treated with pravastatin 20 milligram OD, or 10 patients were compared not on pravastatin, and the proportion of live births was higher in those on pravastatin and the preterm deliveries were fewer, and the duration of pregnancy after the onset of preeclampsia was 13 weeks in the group receiving pravastatin as opposed to 4.5 weeks in the group not receiving pravastatin. So statins may also be used when you are up against the wall in this condition. Low dose prednisolone, given the immune activation that occurs in the placenta, particularly in the presence of antiphospholipid antibodies, this prospective cohort study used prednisolone at a dose of 10 milligram daily from conception till week 14. And before the use of prednisolone, that is historically, there were 4/97 live births amongst pregnancies, whereas after the use of prednisolone in this group which already had so much adverse outcomes, 61% had a live birth. So in this particular situation, you may give prednisolone early on during pregnancy. As we have seen, complement activation plays a role in the placental pathology of antiphospholipid antibody syndrome, and we have targets that directly target C5 such as eculizumab, and case reports have shown that in refractory obstetric APS, eculizumab may have a role, but we don't have further evidence from any cohort studies or randomized controlled trials. What about mTORC inhibition? This paper came in New England Journal of Medicine about a decade back, wherein they showed that those kidney transplant patients who had antiphospholipid antibodies, if they were treated with sirolimus, they had better graft survival and better graft function. Nobody has studied this in obstetric APS, so its relevance is unknown, but anecdotally, sirolimus has been used in pregnant patients, so this is an area for further exploration. B cell depletion, one would think that by depleting the B cells, one would get rid of the antiphospholipid antibodies. However, unfortunately, although rituximab in a cohort study demonstrated effectiveness for non-criteria manifestations of antiphospholipid antibody syndrome, there was no reduction in antiphospholipid antibody titers following treatment with rituximab. And also the safety of rituximab during pregnancy is not established. So also for obinutuzumab and also for belimumab, which is a BAFF inhibitor. So we cannot conclusively make a choice as to whether these drugs may be useful. Literature is emerging about the use of TNF inhibitors in this group of patients with obstetric APS who were 12 and obstetric morbidity related to antiphospholipid antibodies who were treated with adalimumab or certolizumab pegol. The 2/3 of patients had a good pregnancy outcome. So this is something which may be useful in the future. A word of caution would be that it has also been reported that anti-TNF antibodies can induce antiphospholipid antibody syndrome. And there are trials interrogating these treatments. There are trials of certolizumab, there are trials of hydroxychloroquine, and also for warfarin, which we know is embryotoxic in early pregnancy. People are looking at whether we can give this later on. So one would look at these trials with interest in the future. To conclude, this is a suggested management algorithm based largely on the EULAR recommendations. All antiphospholipid antibody positive females should be given low dose aspirin during pregnancy, and those with a prior thrombosis definitely need therapeutic heparin with low dose aspirin and hydroxychloroquine. Those with antiphospholipid antibodies with recurrent pregnancy loss, or those who meet the criteria for obstetric APS or have obstetric morbidity associated with antiphospholipid antibody syndrome, should receive prophylactic heparin with low dose aspirin and hydroxychloroquine, intensifying to therapeutic heparin if recurrent pregnancy loss occurs despite this. And if still recurrent pregnancy loss occurs, then you might consider experimental therapies like statins, eculizumab, TNF inhibitors, and potentially in the future one would have to look at strategies like sirolimus and whether some B-cell depleting agents which may be safe during pregnancy if they come up. And if you have recurrent early pregnancy losses until week 10, then prednisolone 10 milligram from conception until week 14 is a strategy that can be used. Thank you.
Thank you, Durga. Glad to hear from you after so long. You covered the topic very crisp and clear. We can take one or two quick questions.
Sir, my personal belief is that it very well does exist, and I think the next debate is focused on this topic, so we'll wait for it. Sir, people have used it during pregnancy, but up against the wall when you are having recurrent pregnancy losses and you have nothing that is working, then one might try it. Maybe, sir, I mean, in refractory situations, one can give it a trial.
My question was about statin being
teratogenic.
Thank you. We would like to close the session.
Thank you, Dr. Mishra.
So next is actually, as per the routine, it was a debate, but I think the debaters, they need some energy for that, so that's why they are preparing their debate. Another time, I'll invite all the panelists and the moderator and the panel expert, please come. And this panel discussion is going to be very, so please arrange the chairs accordingly. Kisko bolo? Chair dalo. So every OARC update we do this panel just to summarize whatever you have listened from the morning. So now you will have different case scenarios and you will have a complete type of revision. So please all are requested to enjoy the panel discussion. And I'll invite Dr. Arghya, who is our moderator, to come here and start the proceedings.
Very good afternoon, and at the outset I extend my sincere thanks to Jyoti sir for inviting me here. So this will be a panel discussion focusing on the different pregnancy issues in rheumatic diseases. So we have panel expert Dr. Pradeep Kumar Sharma, request sir to be on the dais. We have eminent panelists both from as rheumatologist and gynecologist. Request Dr. Deoni Zes to be on dais, Dr. Abro Chaudhary and Dr. Rashmi Ranjan Shahu from rheumatological aspects, And as a panelist from the gynecological part, request Dr. Indira Palu, Dr. Dipti Balakrishnan, and Dr. Deepa Shetty. Need one more chair. और एक चेयर चाहिए 7 chairs. चेयर अरे इधर से दे दो ना, इधर से दे दो ना, इधर से दे दो ना एक. Can I have my slides? So we'll start, go through few cases, and these are all live cases. So this is the outline why we need to discuss this and what are the red flags, how to plan and how to execute. So the first case of the Mr. L and Mr. P, Mrs. P recently presented the unexplained fever, polyarthritis, oral ulcer and alopecia, and a house physician advised for the battery of tests, after which ANA turned out to be positive. A diagnosis of SLE was made, and they had an impression this is a life-threatening disease. She will have to be on steroid for the rest of the life, and she can never become pregnant. So you know the best of the team for rheumatology and gynecology at present in India is sitting here. So the family visited to our team for a second opinion. Is lupus always a life-threatening? Have an opinion from the Devanis sir.
No, lupus is not always life-threatening conditions. It is, though it is a serious condition and having a severe life-threatening complications with the involvement of the vital organ involvement like brain, kidney, lungs, and heart involvement. Although an individual can have a normal lifespan who have a milder form of the disease, but those who having a severe organ involvement with the advancement of the treatment and proper monitoring and management, there is a change in the outlook of the lupus patients. So there is some studies which quoting that a survival analysis of the mortality and development of the lupus nephritis, which has been published in Rheumatology in 2023, which says a patient who has been diagnosed under the age of the 28 having a significant increase in the risk of the development of the lupus nephritis, but less chances to die, but having a less with this study and 5-year survival rate of these patients, and there is a significant improvement in the survival of this patient who have been diagnosed between the years of the 1978 and 89 as diagnosed between 2006 and 11. And another studies which signified the mortality and the cause of the lupus nephritis in the last decades, along data from the population-based studies which highlighted that a standardized mortality ratio.
So our take home is that there is significant improvement in the survival. And this is not always life-threatening. So, so second query was, will she be on steroid for the rest of the life? Resmi boss.
So, you're going to show the, okay. So the current practice is to cut down the steroid. We all know steroids have a faster onset of action, life-saving in organ-threatening conditions. But what was that? This was studied in prospective cohort and clinical trials, that a lower cumulative dose of pulse methylprednisolone, that is 1.5 gram over 3 days, compared to more than 1.5 gram, is equally effective. and rapid taper up to 5 milligram as early as possible is equally effective. So cutting down the steroid would benefit in the sense that a higher cumulative dose of pulse methylprednisolone and higher mean average dose of oral prednisolone would have a adverse outcome in the form of cataract, osteoporosis, cardiovascular outcome. So it is recommended in current EULAR guideline that to cut down the steroid as early as possible and keep at a low dose, 5 milligram per day.
So the newer concept is a lower dose or no steroid. So can a lupus patient become pregnant? I think there is a time then we think that no lupus patient can become pregnant.
Yeah, like 20 to 30 years back, it was told that lupus patients can never become pregnant, but nowadays with improved therapy, this is absolutely false. So what we counsel the lupus patient that there should be absolute disease control 6 months before the patient plans pregnancy. And if a patient has lupus nephritis, they should be on a pregnancy compatible drug like azathioprine or tacrolimus at least 3 months before pregnancy. 3 months we'll observe if the disease does not flare up, and then if the patient is in remission, patient can become pregnant. There is no issue in pregnancy.
So the single line answer is yes, lupus patient can become pregnant, and how to plan, we'll go through the cases. So how lupus affect the pregnancy?
Lupus can affect pregnancy in different types. It can cause like preterm birth, it can cause early fetal death, it can cause intrauterine growth retardation, it can cause fetal cardiac conduction blockade as well as neonatal lupus.
So exactly, these are the issues when we can face when we are planning for the lupus patients with the pregnancy. Then, and on the other hand, how pregnancy affects the lupus? Devani sir?
During conception and after pregnancies, there is a 25% flare rate in the pregnancies, and adverse outcome may be because of the pregnancy loss, pregnancy-induced hypertension, and IUGR, low birth weight, and preterm delivery, the pregnancy-induced hypertension, and also there is small for the gestational age, and most importantly, it's the need of the cesarean sections and heart block, and sometimes neonatal lupus, and some risk factors which increase the pregnancy bad outcome, active disease during 6 months of the pregnancies, and hypertension in betweens, and presence of the antiphospholipid antibodies, anti-ROLA antibodies. These are some of the risk factors.
So the major concern being a rheumatologist for lupus patient becoming pregnant is whether there will be a disease flare or not. So for ease of remember, we used to follow the rule of 1/3. 1/3 of the lupus patient, even with a pre-planned pregnancy, can land up into the flare-up. 1/3 will remain same, and 1/3 even go into the remission. So is there any contraindication specific still, though we have told that each and every lupus patient can become pregnant, but still there is any contraindication where lupus patient cannot become pregnant?
So active disease at the time of conception, a organ flare in the recent past, in the last 6 months, any conditions that preclude the mother would sustain the pregnancy, like a severe heart failure, pulmonary artery hypertension, advanced renal failure, restrictive lung disease, and uncontrolled hypertension, and current medications which are need to be changed well ahead of time, like cyclophosphamide, mycophenolate, methotrexate. So these things are taken to be consideration, and pregnancy can be planned well ahead once the disease goes into remission. In lupus, 6 months of disease remission is usually acceptable to plan pregnancy.
So there are some modifiable things, like we need to have a good disease control at least 6 months before we plan pregnancy, but there are some non-modifiable entities. So these are 10 major points which are apparent or absolute contraindication for lupus patient getting pregnant. So there is lots of discussion from since morning regarding different autoantibodies in pregnancy-related pregnancy outcome in the lupus patients. Obrosen's opinion regarding what all antibodies we should be very much cautious or concerned regarding lupus patient becoming pregnant.
So before a lupus patient becomes pregnant, we need to check for mainly 2 groups of antibodies. One is the antibody associated with the antiphospholipid syndrome. So these antibodies, the mechanism is during the process of placentation, there is a expression of the anionic phospholipids on the trophoblast surface, and the antibodies against the beta 2 GP1 like lupus anticoagulant, anticardiolipin, these acts on these antibodies, the anionic phospholipids, and this complex leads to further trophoblast inflammatory cascade leading to cytokine expression, disruption of the trophoblast, defective implantation, and activation of complement cascade. The second group of antibodies is the anti-SSA antibodies. So this is two theories. One theory is that this SSA antibodies derived by the apoptosis of the fetal cardiomyocyte, they can cause the fibrosis of the conduction system, and second theory is that it can cause blockade of the different calcium channels. So these are the two mechanisms by which it can cause conduction disturbances.
So these are the two major antibodies we need to check. There's a must check antibodies before someone plan for the pregnancy, because that can impact the outcome. So another major concern being the lupus patient getting pregnant, the drugs. So what all drugs we need to be very skeptic before someone planning for pregnancy?
Malbio sir has already provided a summary slide in the morning session. So, and the drugs which are compatible with pregnancy and lactation. So corticosteroid, yes, it is compatible, but the lowest effective dose and rapid taper up to minimum dose where a relapse can be prevented. Antimalarials are compatible. Methotrexate and leflunomide are contraindicated. Methotrexate has to be stopped 1 month before conception is planned. Sulfasalazine, azathioprine, and calcineurin inhibitors are compatible with pregnancy. Among the biologics, the TNF inhibitors, sir has already summarized some biologics, some TNF inhibitor can
I think
be given
Rashmi sir, if you
pregnancy.
tell us in other way, 2-3 drugs which are compatible during the pregnancy, that will be more take home for all of us.
Hydroxychloroquine is safe.
So one is hydroxychloroquine, we should not
Sulfasalazine
stop.
is safe.
Sulfasalazine is safe.
Azathioprine
Is safe.
Yes.
And CNIs are safe.
CNIs are
So these are the medicines which are absolutely safe during pregnancy, because we often encounter, we are advised our patient to continue with hydroxychloroquine. So when patient become pregnant, then there is some inhibition from the other part. They ask to stop the hydroxychloroquine from the gynec part or some other people. So as this is a category B drug, because that's why, but it is absolutely safe in a setting of the lupus. So hydroxychloroquine, CNI, sulfasalazine, and low dose steroid, these are the drugs which can be used safely. So from this case, as of now, what are the take homes from our chair of the panel discussion?
Most of the things actually discussed already, so I won't take
very
much
short
time.
1 or 2
so
points.
one thing is the first question, whether SLE is always life-threatening. So always we discuss about this lupus nephritis survival, but we tend to forget that there are many patients actually who don't have major organ involvement. They have only minor organ involvement like musculoskeletal or skin. So those patients' survival are different from who has major organ involvement. Whether steroid will be continued lifelong or not, again depend upon the conditions. A minor organ, probably we can think about stopping steroids early. Then regarding this counseling, always we are concerned about the kidney, then whether remission or low disease activity. We actually tend to forgetting in our OPD to counseling about pregnancy and contraceptives. So nowadays, after discussions and all, nowadays we have made a habit, and this discussion should be actually with regarding pregnancy and contraception in the initial visits, not later on. So patient should not come that I am pregnant now, patient is already on mycophenol. That should not happen. So pregnancy counseling, contraceptive counseling from the very beginning. Then this checkup during pregnancy, and that should be frequent. At least one visit if the patient is okay, at least one visit in each trimester. Then if roll-up positive, question of those ultrasounds will come.
So in our case, the couple decided not to go for pregnancy because they were just married and they want to plan it next 1 to 2 years. So team advised to assess the disease state and they referred to gynec team for the contraception planning, as sir was telling. So do you feel the contraceptive services are being largely underutilized in women living with different connective tissue disease, including lupus? Dr. Indira Pala's opinion.
Thank you, sir. Actually, contraceptive practice in general also it is very much underutilized. So in Odisha, if you tell that it is only 5 to 10% people are utilizing the proper contraceptive use in proper way. So it is so the knowledge regarding contraception is very low in the rural population, and so similar to all the population, it is also low in the these patients who are suffering from SLE.
So that's a major drawback from the rheumatologist point of view, because we are more concerned with the disease assessment, disease state and disease management. But as we often forget, these patients are in the childbearing age, and we often fail to refer to the patients to the gynec for the proper contraceptive planning. So what are the various contraceptive measures used in the connective tissue disease? Over to ma'am, because just there is a discussion, I think we can have a very short.
In real life situation,
Yeah.
the patients who come to us, we don't actually know whether they are in the active phase or in the active stage of the disease or whether they are in remission. So what happens is that any patient who comes in, all the gynecologists can straight away prescribe barrier contraception with or without spermicides to the patient. And after that, the patient can further be evaluated whether the antiphospholipid antibodies are positive or not. So the second thing which all the gynecologists should know is that intrauterine contraceptive devices can be prescribed for all, irrespective of the type of the connective tissue disorder the patient is. If the patient is having menstrual irregularity, you can go for Mirena or LNG-IUS. And now all the gynecologists know that as soon as the patient comes in, you are prescribed IUCDs, the first expression is no. So they will ask, madam, can we have any pill? So progesterone only pill is a good option, but the problem is that the failure rate is very, very high for those type of patients. And it is almost about 5 to 8%. They has to be taken at the same period of time, and because of that, the efficiency is low. So the next thing they will ask, Antara is there, DMPA, it's a good option. It's freely available across in the government centers. Can't we use it? Again, at that point of time, we have to see whether the antiphospholipid antibody is positive or not. If APLA is positive, definitely you should not give DMPA. But in all the other conditions, SLE as well as in the other connective tissue disorders, you can give DMPA. But the main problem is that the patients with high stages or highly active disorders, connective tissue disorders, may be on corticosteroids, and those patients will be having osteoporosis, and these DMPA is contraindicated. And as before, we have already told, osteoporosis.
So was the next question, like what are the various concerns regarding these contraceptive measures? If ma'am can tell us very.
The concerns are really high in background of CTDs. When we use hormonal contraception, disease flares are relatively high in these patients. Thromboembolic events are very high as these are hormonal contraception. So progesterone-only contraceptions are usually recommended, and DMPA is usually category 3 and 4 drug and not to be used in Aplar syndrome and antiphospholipid positivity. Drug interactions are quite high with CNI and mycophenolate and anticonvulsants. It will decrease both the efficacy of either drugs or increase the toxicity and side effect. Infections like reproductive and urinary tract infections are high in some studies, and DMPA usually leads to osteoporosis when used over more than 2 years.
So IUD-related infections was like more in latest studies is shown that more of theoretical risk than the practical risk.
Sir, for all practical purposes to avoid the intrauterine contraceptive, because steroid taking there is chance of infection, vaginal infection high. But recently the implanon, which you usually give in the arm, and that is a progesterone, and people also accept it, and now the acceptance of implanon over the intrauterine contraceptive.
That was our next question, ma'am, that how to choose choice for the contraceptive in the connective tissue disease, like.
Actually, we have to give a basket of choice. What, according to her choice, will what are the safer? Safer is the LARC, that is intrauterine device, and POP can be given. But for all practical purpose, if you see that implanon, which is not written here, implanon that is available in our hospital, and we are giving it in the underarm, that is a progesterone containing implanon, and the acceptance of the people are very good, and you can remain for 3 years.
So what is the prevalence of the subfertility and fecundity in the connective tissue disease?
Per se, connective tissue disorders don't affect fertility as such. If the patient is in an active stage, or if the patient is having chronic renal disease, probably there will be it will be affected. Or in those conditions in which the patient is subjected to cyclophosphamide, patient may be having amenorrhea, or the patient is subjected to NSAIDs in the previous, which might affect ovulation. Even it was discussed, sulfasalazine, all these can affect. And in males also, the quality of the sperm, the hormones, all these can also be affected. They can have erectile dysfunction in certain conditions like Ehlers-Danlos syndrome and all those, rheumatoid arthritis and sexual performing problems. So these are the reasons, but mostly fertility is maintained.
So next question to Deepa ma'am, like what all measures for this preserving fertility if you are planning for
Yes,
same.
if the patient is suffering from any kind of import sexual dysfunction or lack of parenting abilities, then a preconceptional counseling regarding their anxieties and fears and tailored interventions will mostly help the patient. If there is heightened disease activity, we need to control them with drugs. Before starting gonadotoxic drug like cyclophosphamide, we need to give GnRH agonist. This will mostly prevent ovarian damage and preserve fertility. If the patient is on sulfasalazine as it causes azoospermia, it should be stopped if patient is unable to conceive. And other ART procedures like preservation is available. And in cases of autoimmune euphoritis, steroids, B-cell depletion therapy, IVM and other ART ovum donation will really help and will preserve fertility.
Thank you. So ARTs in CTDs, what are the options, ma'am?
Actually, these are the women who are more prone for premature ovarian insufficiency or premature ovarian failure. So they should be counseled before starting. They have an option to preserve their ovocytes. They can have ovum retrieval and they can have a preservation whenever they are disease free. They can be given. That is an option. And second option is surrogacy. If it is the disease condition is very high, they can go for a surrogacy. Means mother will be another. They can donate the oocyte and the husband's sperm, and they can. That is a better option. If there is a, you have discussed there are conditions where you cannot allow pregnancy, lupus nephritis or anything, who are not able to, or any vulvopathy in a higher disorder.
Ma'am, what is the legal status of surrogacy in India?
Yes, it is now it is in the court of law in the Indian ART law is there, but still we are doing surrogacy, and surrogacy is a better option. We have a counsel, you can go for surrogacy.
So you're almost done with the lupus thing. The similar looking disease are the mixed connective tissue disease and spectrum disease or systemic sclerosis, and there are lots of adverse pregnancy outcome in these disease. As a rheumatologist, Dionis, your opinion, how frequently you encounter this kind of adverse pregnancy outcome in your patients of systemic sclerosis and mixed connective tissue disease?
Adverse pregnancy outcome is a serious concern in patient with MCTD and a patient with systemic sclerosis. But many of the females, they can have a normal pregnancy provided that should be treated with the proper planning and monitoring and treatment with the gynecologist. Then we can have a successful pregnancy, and pregnant patients with this disease can have a normal baby delivery.
So again, it's the same
closing,
thing, like
yeah.
we need to have good control
Yeah,
over the
yeah.
disease. We need to look for the pulmonary hypertension, which is one of the major concern for this group of the disease. That can have an adverse pregnancy outcome, and the renal involvement, like for the lupus also.
Yeah.
So from the gynecologist's point of view, how frequently we encounter, ma'am, this kind of adverse pregnancy outcome in patients?
As a gynecologist, I think we are really in trouble because this is a very severe disease. Especially this MCTD is a combination of multiple disorders, and the patient will be having all the vital organs may be affected in these conditions. So when the vital organs are affected, definitely, as you have told in the previous slide, a lot of things are there which really will, if there is a pregnancy, is actually contraindicated, like pulmonary hypertension. So when the patient initially comes to us, it's important for us to first evaluate whether the heart is involved, whether the patient is having lung fibrosis, whether she is having a chronic renal disease, or whether she is having early scleroderma, or if the patient is diagnosed within 4 years. So all these conditions, if it is there, is definitely a contraindication for pregnancy. And the first thing is that we have to advise termination for these type of patients. So once you know that the patient is already can't continue pregnancy, probably can start the patient on aspirin. Then you have to check with the other two antibodies, antiphospholipid antibodies, as well as anti-Ro and La antibodies in order to rule out that the patient, so that the patient can be followed up in pregnancy for the fetus, for congenital heart block from 16 to 28. All these things have been discussed, and heparin as well as low-dose aspirin can be started for these patients.
Any special comments from Pradeep, sir?
Yeah, or probably we have gone too fast. Even I am getting difficult to follow up actually. So actually what we have discussed is that IUD is the ideal method for everyone. But actually we thought rheumatologists that, but actually hearing to you, I have realized that acceptance of IUD in the first visit is difficult. So at that point of time, they may need oral contraceptive, but we should avoid estrogen when, especially in SLE, APLA positivity. Then regarding scleroderma and MCD, I want to highlight these are the two conditions, especially scleroderma. When patient has ILD, when patient has pulmonary hypertension, these are the patients actually we counsel they should not become pregnant. We have
Anesthetic
seen
needs
it.
to be
Yeah.
involved, sir. That is
Yeah.
one thing which is important
Yeah.
to be conveyed to the obstetrician. Anesthetists, they may have difficulty with IV lines, with intubation. So that is something which is very, very important in scleroderma. Even though thankfully, we don't see it much.
As we are running short of time, that's why I'm running very fast. So moving to a second case of, we are done with the connective tissue disease. This 35-year-old woman, mother of 3 years child, planning for a second baby. She has been diagnosed with a rheumatoid for last 2 years. She was on methotrexate and under follow-up in orthopedic surgeon. This is a live case. If someone is there, don't mind. He rightly advised to stop methotrexate pregnancy, but advised for leflunomide to continue during the pregnancy. Patient did some Google search and found something wrong and visited rheumatology team. So was leflunomide an appropriate choice in this situation? Deonis sir.
Leflunomide is a potential it is contraindicated for preconception, whole trimester of the pregnancy, and even in the breastfeeding. So cholesterol elimination protocol is required, as without elimination protocols, this leflunomide can stay in the body for more than 2 years, almost to the non-detectable level with the various clearance differences between the individuals. So it is contraindicated for the preconception, whole trimester of the pregnancy, and even breastfeeding.
So as of date, though there are some contradicting data on leflunomide, there are some positive outcomes, even patients were on leflunomide. But as of date, from legal point of view, as the guidelines says, so it's better to avoid or just avoid leflunomide during preconception, first trimester, second trimester, even during breastfeeding. So drug elimination protocol, there is that, it's available everywhere, so I'm not going to go through. Again, for rheumatoid, any specific drugs which should be avoided is the same or something different?
No. Apart from the leflunomide, like cyclophosphamide is also except in the special consideration, and also like methotrexate to be avoided, like it should be stopped preconception 3 months earlier, and also we are using a lot of JAK2 inhibitors like tofacitinib that needs to be stopped at least 2 weeks prior to the preconceptions, and also mycophenolate mofetil more than 6 weeks preconception, it should be stopped. So
but for rheumatoid, we have options with the anti-TNFs. These are the options which are not available for the lupus group or connective tissue disease patients. We can use safely, like for the disease management, anti-TNF are the good options for them.
Yeah.
So with this, we will be moving to a third case of 34-year male, known case of ankylosing spondylitis with axial involvement and the uveitis, doing well on sulfasalazine 2 gram a day, married for 2 years but yet to have child. While consultation with gynae, she found to have azoospermia. How notorious is sulfasalazine for azoospermia?
So sulfasalazine is compatible with males planning to father a child. It is associated with azoospermia and abnormal spore morphology, decreased motility, but it is reversible. If there is a problem in conception, you stop the drug and the semen analysis can be advised after 3 months.
So what all alternatives are there in this patient?
So the drugs are not an issue as per the mother. Almost all the drugs are safe for the males planning to father a child, except cyclophosphamide. Cyclophosphamide is associated with infertility and teratogenicity, and also thalidomide. So cyclophosphamide at a dose of 7.5 gram per meter square body surface area, it is almost 90% toxic. It is associated with infertility, male infertility.
So for a male, it's easier job. Other than cyclophosphamide, you can use every possible medicine for if they are planning for pregnancy. Even sulfasalazine is otherwise safe if it is not causing azoospermia. So while planning pregnancy, couple wants to know what are the risk of transmitting disease to the next generation. Is there any preventive measures? Sir.
So most of the rheumatic diseases are transmissible. That is, if the family history is there, the next generation can have. All we know that monozygotic twins have higher risk of developing than the general population, and all first degree relatives of the index patient has increased risk. But there is nothing that we can do to prevent. Only early diagnosis of the disease is of utmost importance.
So, so nothing to prevent, and there is a chance, and as it is like HLA-B27 has a strong connection, so there are chances of getting transmitted is higher than the rest of the connective tissue disease. If the disease was in the mother, how to plan pregnancy in ankylosing spondylitis?
There is a key consideration in the patient planning for the pregnancy in AS patients, like disease activity and medication management, and also folic acid supplementation as per in a normal individual to prevent the neural tooth defect in AS patient also, And also there should be a bone and the spine health, overall health and medication management, and also like the predictions of the increased complications. Some of the recommendations which required are pre-conceptual counselings and the close monitoring for the disease activity and overall health, like the
It's
constitution
same
of
for the other
yeah.
connective tissue disease and
Yeah, yeah.
arthritis disease.
And most importantly, during delivery. So delivery management is very important in patient with the AS because of the spinal stiffness and
I think
yeah,
Deepa
that's it.
ma'am
Yeah.
can take the question, like if there is any specific concern with ankylosing spondylosis patients getting delivered.
Yes, adverse pregnancy outcomes are a little bit more as compared to general population. Fetal adverse outcomes like preterm birth, IUGR and small for gestational age babies are common. And in mothers, we see increased rate of cesarean section as compared to general population, and increased risk of pregnancy-induced hypertension like preeclampsia, and increased risk of gestational diabetes mellitus.
Thank you. Thank you. So moving to our next case of the recurrent second trimester abortions, Durga said just talk about during the work of found antiphospholipid antibody positive, she has no other history of thrombosis. So how frequently as a gynecologist you incur this situation, and do you advise APLA testing for all patients with recurrent abortions?
Definitely, we are getting a lot number of cases of recurrent pregnancy loss, but most of the time we do not get a antibody titer positive cases. But there are clinical criteria which will suffice. Then we are prescribing, if the patient next time conceives, we plan aspirin and low dose heparin. And many times without any antibody titer also we are giving, and we are getting good results. But thing is that those who are APLA positive, antibody positive, we are having very bad outcome. Whatever we do, we are getting only 80 to 90% cases either we lose the mother or lose the baby. We are having high mortality.
That must
and
be due
morbidity.
to the poor
But if
planning,
it is
poor coordination between the rheumatologist and gynecologist. Non-criteria APS manifestation, what all should we remember?
So these criteria were derived from a large cohort of the European group of this obstetric antiphospholipid syndrome. Pregnancies with this condition have a higher frequency of antiphospholipid antibodies. So if you can remember the clinical criteria, the criteria is a 3 spontaneous consecutive pregnancy loss. So if it is non-consecutive, if it is 1 or 2 early pregnancy losses, if there is a preterm birth beyond 34 weeks, or if there is a late onset preeclampsia, eclampsia or placental insufficiency, and infertility with a recurrent implantation failure, 2 or more implantation failure, these pregnancies could be benefited by advising the
So we should also remember these non-criteria manifestation, because they always may not read the book. This is never read the book. So these can be the answer possible. So how to advise for the APLA testing and what all specific antibodies?
So this has to be ensured actually, because the most often.
Sorry, it's to you.
Should I continue?
Sure, please.
Okay.
Like what is practical problem, what we feel, like we have seen patient who is advised for the APLA antiphospholipid antibody in general. So what exactly we need to advise, that is the question.
So that
how to advise testing for APLA?
So the tests that have been standardized as per the as per the recommendations include anti-cardiolipin antibody IgM, IgG, or anti-beta-2-GP1 IgM, Ig. That should be done by ELISA. Actually, the other methods are available, but those are not standardized. So one is to ensure that these tests were done with ELISA. The next one is the lupus anticoagulant. That has to be done by 2 methods actually. That has to be cross-checked. One is the phospholipid sensitive APTT and a dilute Russell Viper venom test, ensuring 3 steps of this test, like a screening, the mixing, and the confirmation test.
So that is very important, because commercially there is something test called available antiphospholipid antibody testing. So we should not do that. We should advise specifically for the 3 tests he mentioned. How to manage the obstetric APLA? Any specific point?
If the patient has only recurrent abortion obstetric manifestation, then we go for low dose aspirin and prophylactic dose of heparin, either low molecular weight heparin or unfractionated heparin. And if patient has previous history of a thrombotic episode, then we add this low dose heparin in therapeutic doses.
That's very straightforward answer. Managing APLA from a gynecologist point of view, anything special, madam?
Clinically, we get 3 types of APLAs. One is just APLA positive without clinical manifestations. You just have to start aspirin for them. The second group is you have a primary as well as secondary. Primary is in which you don't have a connective tissue disorder, and in both these conditions, if it is associated with obstetric APS, The same thing, aspirin has to be started 1 month before, continue till 36 weeks, low molecular weight, prophylactic dose that is being given. And when it is whether it is secondary APLA or primary, if it is associated with thrombotic, then you have to switch on to therapeutic dosage. That is the only difference.
Sure. Right. So I think last. While following up the visit during pregnancy, a 35-year-old woman who was mother of a 5-year-old boy found to have secondary heart block on scanning. On evaluations, found to have anti-SSA positive in higher titer. On questioning, she gave history of the polyarthralgia for last 6 months, and also she is on eye drops for dry eye symptoms for last 1.5 years. How frequently, as a gynecologist, you encounter this kind of situation, and do you advise ANA testing for all patients with heart block?
In my experience of last 6 years, I would say it was an uncommon situation. I have seen hardly 4 to 5 patients. But if we see a patient whose fetus is having a heart block, we do advise antinuclear ANA and specifically anti-Rho and anti-La antibodies because early diagnosis will help in risk stratification, management and monitoring of the baby.
Perfect. So how to manage this congenital heart block? I think there is a detailed discussion. If you can give in 1 or 2 summary points for this heart block management.
Madam has nicely discussed this one. So this one is an algorithm from the Euler group. Madam has discussed every point, the rationale behind giving the drug, the fetal heart rate monitoring. So the risk is, let's say, 2%. The risk increases 10 times with a serial echo monitoring weekly from 16 weeks onwards. If there is a first degree heart block, then you consider giving fluorinated glucocorticoids like dexamethasone 4 mg per day. If there is a second degree heart block, start fluorinated glucocorticoid along with IVIG, particularly in pregnancies who had a previous history of neonatal lupus or complete heart block. So you start IVIG simultaneously. And in third degree heart block, as per this Euler recommendation, if there is high drops or there is a poor cardiac function or if there is a endocardial fibroelastosis, consider giving IVIG plus plasma exchange along with this steroid.
So, fine. The most important, you need to have giving hydroxychloroquine for each and every patient. That should not be forgotten. So, while taking vitals, a 25 years pregnant lady resident found to have absent pulse on the left side. She never consulted any doctor before pregnancy. On further evaluation, she was found to have Takayama type 5. How frequently as a gynecologist you encounter this situation?
Many times I might have encountered 6-7 cases because when my staff reports me that is I'm not able to measure the blood pressure of the patient, then I first thing struck to mind, could it be Takayama disease? But we have a very good outcome with Takayama, though we do not get the blood pressure in the hand. But we are trying to get, but we are, that is
so
the only thing we are
this situation is not
able,
as uncommon as
we are
heart
getting
block
a lot
situation.
of cases.
So good. So how will you plan for the management of this patient as a rheumatologist, and is pregnancy outcome different in Takayama arthritis than other diseases? Deonis sir, 1 or 2 specific line.
Yes, because pregnancy with Takayama arthritis, there is an increased risk of the hypertension and due to increased intravascular volume, and that led into the impairment of the circulation, that led into the like worsening of the hemodynamic and cardiovascular status of the mothers, and that led into sometimes cardiac failure also and rupture of the aneurysm also. So monitoring of the BP is very important to to prevent the rupture of the aneurysm, and even the low BP also can cause them increase in the ischemic the problems in the brain of the mother.
So what we feel the major concern is the BP, hypertension we often fail to measure because of the loss of pulses.
This is the most difficult part.
So
after delivery we are not able to measure whether the patient is having any problem.
Pulses, even if you lost the peripheral pulses of the lower limbs also, then it becomes more difficult, especially in the type 5. So that is the major concern with the Takayama patients. And so moving to the last case of 26-year-old pregnant woman, 20 weeks gestation, presented with a 3 months history of fever, cough, dyspnea, epistaxis, nasal crusting, hemoptysis, and hearing loss. She had a palpable purpura over her legs, serum inflammatory markers was elevated, chest X-ray showed this kind of cannonball opacities. This is a very classical X-ray for cannonball opacities. We have taken this X-ray with all precautions. There was the most likely diagnosis in this case, choriocarcinoma, lung, CA, GPA, and pulmonary tuberculosis. So definitely in this rheumatology setting, this is a typical presentation of the GPA. So how to manage this case? During pregnancy, patient presented with this kind of flare of the GPA from any rheumatologist. Abro sir?
This is a life-threatening condition, so we will give IV pulse, methylpred just to save the patient. And if the patient normalizes, then we can continue on azathioprine. And if the patient does not normalize, we have to take the risk and give rituximab, even though it is contraindicated.
So rituximab is in this situation maybe a relative contraindication, and this is our live case, and we treated these patients with rituximab, and the pregnancy outcome was a positive outcome. Thank you.
Thank you.
Sir, any final comment from Pradeep sir? Sorry.
Congratulations to Arga and all the panelists, actually, though it was fast, but we were able to finish it on time. But just one last question to Rosmi or Arga. So one of the non-criteria manifestation for APS is infertility. So if a patient, we have done twice, any of the antibody is positive, so she fulfills lab criteria, as she is infertile, referred to you, what you are going to do now?
So she should be offered anticoagulation. Actually, it has been seen that these the pregnancies with the infertile women had a higher frequency of antiphospholipids antibodies. So she should be offered a chance with anticoagulation so that she can conceive. No, anticoagulation, low molecular heparin.
Heparin.
Yes.
Aspirin and heparin, I think
Yes,
this is the
yes.
usual protocol in infertile patients.
The
what we have.
prevalence of antiphospholipid in such condition is seen to be 6%. Well, yes.
Thank you every panelist for their active participation. Thank you.
Thank you all the panelists, moderator and panel expert to help us to finish in time and save our 10 minutes. Thank you, ma'am. Thank you, sir. So, सफर का फल मीठा होता है. It's very heartening to see the full house, although this is already 4 o'clock, 4:15. So this is the most exciting, we are going to have the most exciting session. जो बुक में लिखा था ये सब पढ़ लिया आपने. अभी जो बताएंगे हमारे एक्सपर्ट, that is out of the textbook. I think you know what is the debate topic, and हमको अंपायरिंग के लिए गुवाहाटी मेडिकल कॉलेज से उनका हेड द डिपार्टमेंट ऑफ मेडिसिन और एक्स ईस्ट जोन रिमेटोलॉजी एसोसिएशन प्रेसिडेंट प्रोफेसर डॉक्टर मधुमिता दास मैडम प्लीज आ जाइए. एंड द सेकेंड umpire is Professor Dr. Mausumi Acharya. She is my classmate. Mausumi, please come. She is head of the Department of CHR, Reproductive Medicine in KIMS. And third is Dr. Pradeep Paningrai, sir. So, sir is a professor in gynecology in High Tech Medical College.
Everything. Just not at all. So now we are headed for the most interesting debate, the use of immunosuppressants and anticoagulants in seronegative RPL, whether it's a lifeline or a leap of faith. Of course, it's going to be a very interesting session. There aren't laid down guidelines. And to speak on this very controversial issue, we have the speaker for the motion, Dr. Kunal Chandwar, who is a DM Rheumat, and you can see his CV right in front of you, a talented speaker. So let's hear from him what he has to say for the motion.
Thank you so very much, ma'am, and a very good evening to all those who are present here. Thanks for staying back this long. And gratitudes from the land of setting sun. So I come from Gujarat, the farthest possible place from possibly Orissa can be. And I'm here today to talk on whether you need to anticoagulate or immunosuppress or immunomodulate patients who have come to you with recurrent pregnancy losses. So, I'll start with a quote. The pain of a single miscarriage is a grief that whispers, and the pain of recurrent loss is a grief that screams. Every child that a woman conceives comes with a future that is conceived of how things might be once the child comes in their life, and every child or fetus that is lost in the womb comes with a lot of disappointment. So I come from Gujarat and sir comes from Delhi, and we have political stalwarts mostly looking like these. So I look more like an Amit Shah, less hair, more fat, possible graying, and sir is more fit and fine like a Kejriwal. So sir, as would be expected, पूछेंगे evidence क्या है? What is the evidence behind it? And I can then say that even absence of evidence is not an evidence of absence. फिर भी सर पूछ रहे हैं evidence तो बता. And then I can then say in the classical Amit Shah manner, चलो chronology समझते हैं. So this is how we'll talk in this session. So we'll be discussing what is the most anticipated seronegative antiphospholipid antibody syndrome. We'll discuss what are the usual immunological dysfunctions that are seen in patients with recurrent pregnancy losses. What are the data that is available for the therapeutic management of recurrent pregnancy losses, and can there be a way forward in understanding these aspects better? So the usual definition, there are each society that there is defines recurrent pregnancy loss in its own way. The most common definition usually is if a person or a female has had 2 or more failed clinical pregnancies. This is called as recurrent pregnancy loss. Usually this is seen in about 2 to 5% of patients, representing a significant clinical and emotional burden. And almost 50% of these cases are never identified. This leads to what is called as a case of unexplained recurrent pregnancy loss. The common, again, causes could be genetic, endocrine, uterine, and all of those. The gynecologist, before referring to an immunologist, would have ruled out the most important structural, genetic, thrombophilic causes before they come to us. And my argument is a lot of these unexplained cases may actually be treatable immunothrombotic mechanisms. So a patient that had come to me and I told her that, or Ranjan sir told her that I can't explain your recurrent pregnancy losses and I don't have much to offer for you. The patient then says that, doctor, each time you tell me it's unexplained, it feels like you are telling me my grief is unreasonable. No, no patient's grief is unreasonable, and we'll find a possible reasonable solution to their grief. So what is seronegative antiphospholipid antibody syndrome? This is a case where you have a clinical picture of a classical antiphospholipid antibody syndrome, more characteristically an obstetric presentation. You would have recurrent early pregnancy losses, late fetal deaths, severe preeclampsia. As the obstetricians did discuss, you could have presence of fetal heart beat that is there and then an absence. And you would not have either the antibodies are not persistent, or you have non-criteria antibodies present, or you don't have any antibodies at all. And now we have found that there are a lot of other antibodies other than the classical antibodies that are defined in the criteria. You could have the antibodies against the domain 1 of the beta-2 GPI, the IgA isotypes, the anti-PSPT antibodies, and even there are antibodies such as the anti-annexin 5 antibodies that have been described. Seronegativity is often a failure of a standard test panel, not an absence of an actual pathology. And there have been clinical studies to say how do these seronegative patients present. So they present classically more commonly with the obstetric symptoms. So almost 86% of these would have obstetric manifestations as compared to the thrombotic ones. And when you treat these patients, so if you treat the seronegative patients with either aspirin or aspirin plus heparin, they have much better maternal outcomes. They reach full-term pregnancies, and you see both a happy mother and a happy child. Same way, what they have found is if you have something, compare primary antiphospholipid antibody syndrome with non-criteria antiphospholipid antibody syndrome, the chances of both maternal vascular malformations or fetal vascular malformations are equal. There have been multiple studies comparing non-criteria or seronegative antiphospholipid antibody syndrome with primary positive antiphospholipid antibody syndrome, and yellow means that the outcomes were similar for both antiphospholipid and seronegative patients, and you see that treatment frequency is almost similar in most studies. So is pregnancy outcomes. There are cases where actually the pregnancy outcomes in the seronegative patients are much worse, and obstetric morbidity is again quite common or similar in most of these studies that we have had. So the standard of care works. What we did find is studies show that patients who of seronegative antiphospholipid antibody syndrome or non-criteria APS respond well to the standard therapy. There have been multiple meta-analyses and systematic reviews to show that. And even if you have a clinical phenotype of antiphospholipid antibody syndrome with seronegativity, they likely will respond to therapy. Now, hope is a thing with feathers that perches in the soul and sings the tune without the words and never stops at all. So we never stop hoping that a patient might respond to therapy. We have had a discussion on what are possible immunological important cells that are there, and natural killer cells form a very important milieu in the endometrium. There are different cells. There could be decidual natural killer cells. These are of two types, NK1, NK2. The NK1 is more immunomodulatory and NK2 is more immunoinflammatory. There are uterine natural killer cells, and then there are peripheral natural killer cells. And in case of patients who have recurrent pregnancy losses, you find that as compared to M2 macrophages, you have higher number of M1 macrophages, you have dysfunctional T regulatory cells, you have increased activity of T effector cells, and at the same time, the natural killer cells become ineffective. So there have been various studies, and what they have found is that you might have higher levels of uterine natural killer cells that are more cytotoxic as they would be otherwise. You would have elevated peripheral natural killer cells. You could have higher numbers or higher cytotoxicity in them. You could have altered NK1 to NK cell 2 ratio. You could even find hypocomplementemia in patients who have come to you with recurrent pregnancy losses, and the ratio between T regulatory cells and Th17 cells also changes. So there might be a lot of immunological mechanisms that would be going on in these set of patients. And what are our therapeutic arsenals? So we have all talked about corticosteroids. Now there have been multiple studies or meta-analysis that have been done, and they show that there is improvement in live birth ratio with corticosteroids if they have been continued, even for patients who have had unknown recurrent pregnancy losses. There have been certain immunological criteria that these studies have used. If there are more than 3 consecutive pregnancy losses, or if the uterine natural killer cell percentage is more than 5% of the entire decidual cell that are seen, you usually see a good outcome in these pregnancies. Even the recent systematic reviews for IVIG. So what we have seen is there have been a lot of systematic reviews, and probably sir would be showing some, but the recent ones, the ones that have been done after 2019, have consistently shown that IVIG works well in patients who have had recurrent pregnancy losses that are of unknown etiology or of unexplained character. Even CNIs, so calcineurin inhibitors in systematic reviews show benefit. The term idiopathic is often a confession of ignorance. It is what we call a disease when we are too idiotic to figure out what caused it. So often what we need is probably a more comprehensive look at what the possible etiology of the pregnancy loss here is. And there are multiple immunological causes that have been identified. We have found that there are anti-C1q antibody mediated recurrent pregnancy losses. There are anti-PP1 PK antibody mediated recurrent pregnancy losses. We have found hypocomplementemia again in patients who have had recurrent pregnancy losses, and there is a very interesting cause of chronic histiocytic intervillosis. CHI is a rare severe inflammatory placental disease, massive infiltration of the placenta by maternal macrophages leading to an aggressive antifetal rejection, and without immunosuppression or immunomodulation the chances of pregnancy loss are almost 100%. So the standard of care in this disease again is low dose aspirin along with LMWH, prednisolone and hydroxychloroquine. And if you can actually see that the patient who have received immunomodulatory therapy, their chances of having a live birth, their chances of reaching term with therapy, their chances of having reduced severity or no recurrence of symptoms, and their chances of living throughout with much decreased severity is much higher if they have received immunosuppression as compared to if they have not. So, since my time is up, seronegative antiphospholipid antibody syndrome is real and treatable, like seronegative rheumatoid arthritis or seronegative vasculitis or seronegative myositis that exists in rheumatology. So does seronegative APS. There are multiple immune abnormalities that we find in patients who have recurrent pregnancy losses. Immunomodulation is often a lifeline for selected patients. The term important here is selected. We probably need to better immunophenotype our patients. We probably need to ask our obstetricians to give us a possible biopsy of the decidual or uterine tissue once the fetus is lost. And a stratified personalized approach is much better for better outcomes in our patients. And since this has been a day of poems, I'll end with one. So, real generosity towards the future lies in giving all to the present. And for a couple in our clinic today, our present is all they have. We owe them more than just our caution. We owe them our courage. The courage to look at growing evidence for seronegative APS, to engage with the evolving science of reproductive immunology, and to offer a therapy that is not a wild leap into the dark, but a carefully constructed bridge towards the future they so desperately want. That is not a leap of faith, that is a lifeline. Thank you.
So thank you, Dr. Chandwa. So now we request Dr. Ranjan Gupta, who is an additional professor, Department of Rheumatology, AIIMS, New Delhi. Sir will be speaking about against whether we should go or not. So sir, stage is yours.
Thank you, chairpersons. So first of all, my question to Dr. Kunal. Okay. So आपकी presentation में evidence कहाँ है जी? There is no evidence. What I saw was only set of emotions and of course your own arguments that probably we have possible immunopathogenic, possible immunothrombotic mechanism. We don't have any evidence. And unless until I know what I am treating, there's no point giving anything. So if I go by your example of treating patients with steroids or by say anticoagulants and treating them well, probably a patient who has had 3 children with the congenital heart block, I should be able to treat them with high dose steroids. That doesn't happen because the pathogenesis, the things are different once we come to these set of patients. So I'll start with that, and Dr. Kunal has already told you that this is a problem that affects 2 to 4% of ladies globally. And there are immunological causes, of course. And if I give you the split of these patients, you can see that 3 most important causes for RPL are basically seen in this red, blue and this green. After that, everything is not very clear. These are the 3 things that we know and we can always rule out. Then we have this large yellow chunk which is autoimmune, and this also includes antiphospholipid syndrome that Dr. Kunal was talking about. But you see the biggest chunk, which is the green on your left, and that is where we don't know what we are treating. What we are trying to do by our practice, so I again quote unquote, what we are trying to do by our practice is believing that this green is actually a part of yellow. We give these medicines thinking that we may have an immunopathological mechanism for these green patients that is treatable with steroids, immunosuppressants and anticoagulants, which is not the case, and I'll give you the real evidence. So all these trials that I'm going to quote have used these 3 measures. They are live birth rate, successful pregnancy rate and abortion rate. Abortion rate is very much understandable. So successful pregnancy rate is the pregnancy that has happened but may not turn into a live child, and live birth rate is the actual basically the quality difference between successful pregnancy rate and live birth. When the child lives, when the child is the child is born, it grows and it basically they live. So what are the postulated mechanisms behind the so-called therapeutic armamentarium or arsenal? Is that these are the medicines that people use. So Dr. Kunal has talked about only a few of them. I'll show you the position with respect to each one of them. The major fours are aspirin, heparin, IVIG, and prednisolone. And when I give you these four, the only thing that comes to my mind is we are expecting everything in that green zone to be seronegative APS, which is not the case. We have already identified APS. Most of our patients who we identify to be APS are having those 5 most common antibodies. So believing that the patients who are there in green also have some sort of APS that we are not able to diagnose is actually not digestible. Then people have used everything on this earth, vitamin D, progesterone, biologics, and every other thing, and not just that, all possible combinations, believing that probably we will be successful. Now, what Dr. Kunal showed, he comes from Gujarat and he has actually put it what he wants to sell. So he had highlighted all the odds ratios, but what he did not highlight was the confidence interval. So I'll show you this, like you see this study which he should have quoted, and I am giving you with low molecular weight heparin. This is not working. So I have this low molecular weight heparin as against control. I have the live birth rate and the abortion rate, and you see this is significant if you go here. But what you just see the confidence interval, it is just crossing 1.06. So can we take it clinically significant? Even if you take it clinically significant, you see the heterogeneity of the study, it is 86%. Actually, this study is of no clinical relevance. This is about using low molecular weight heparin in unexplained pregnancy losses and then believing that it has worked. And what he has not shown you is that all these studies that have been taken in this particular meta-analysis had even incomplete data. So you can't conclude anything based on these studies. Now I'll give you this story which has been going on since 1997, that the first trial which was published in NEJM on a combination use of prednisolone and aspirin in patients who had autoantibodies and unexplained recurrent fetal losses. These patients were positive for ANA, anti-Rho antibodies, etc. And what dose they have used? They have used 0.5 to 0.8 milligram per kilogram, that is almost 1 milligram per kilogram steroids with 100 milligram aspirin to all patients, randomized 1:1, and you can see there is no difference in fetal birth weights. There is no, in fact, there is the placebo group performs better. You see at term birth weight, if you see live births at term, they are better in placebo group. Similarly, if you see the birth weight, this admission to ICU, they are much more in treatment group. So can we believe that this would work in patients who we don't even know the diagnosis? Let's take another trial, again on prednisolone, 10 milligram given throughout the pregnancy, and they have tested on an implantation failure. And you can see that almost 1:1 patient randomized, 700 patients, and you can see that prednisolone and placebo almost same implantation rate, rather the intervention arm is 1% lesser. Let's go to what the steroids could cause. I am giving you the data from APS. We are all talking about seronegative APS. Let me give you the data from APS. This is a trial on prednisolone added to aspirin and low molecular weight heparin. Patients divided into 2 groups, less than 20 milligram, more than 20 milligram dose. And you see that there is no difference in abortion rates, no difference with respect to the dose of steroids. You give high dose, you give low dose, nothing matters. Sorry. And these are the adverse effects. Preeclampsia rate in the aspirin intervention arm 3 times higher, gestational diabetes 4 times higher. This is what happens if you give steroids in these patients who we don't know the diagnosis. Let me come to now low molecular weight heparin. This particular meta-analysis done with 6 studies, 4 studies has low molecular weight heparin with aspirin and 2 studies with only low molecular weight heparin, and you see that they have very little bias. And you see the data at both of these regimes. Actually it doesn't matter whether you give them or you don't give them, there is no improvement in pregnancy rates. Now let me show you at molecular level what happens. This is a histopathology. Patients who received heparin, they have looked at the placenta in patients who had heparin, who did not have heparin. And you see this Ki67 is a marker of proliferation. So trophoblasts proliferate. If we postulate giving heparin should actually induce proliferation, but nothing happens. Ki67 marker is same whether you give heparin or not. The only thing is that it has caused a little decrease in BCL2, which is an anti-apoptotic gene, That has decreased, but again, it has not translated into clinical difference. Further, low molecular weight heparin, another trial published in scientific reports. 45 patients, one group given heparin, one group not given heparin, no difference in clinical pregnancy rates. They also looked at whether what changes they cause in cytokine profile, and this is what it does. Th1 related cytokines, CXCL10 and CXCL11, they increase. Th17 related cytokines, CCL20 increases. So actually they are causing more of pro-inflammatory environment. Coming to IVIG, 12 studies, meta-analysis, more than 700 patients. IVIG tested against non-IVIG group, which had an intervention arm in some patients given heparin, some patients have been given things like normal saline, albumin, multivitamin, and you see the difference. Patients who had APS, to those patients you give IVIG and try to look at the pregnancy rates, even in them it doesn't work. We are all trying to extrapolate our experience from APS to this unexplained group. Here it is not working in APS group itself. Let me give you the data on non-APS group. Overall pregnancy rates not different. You test against placebo, IVIG doesn't work against placebo itself. Another meta-analysis, 7 studies, 4 IVIG, one for intralipid, one for etanercept, one for prednisolone, 557 participants, and you see there is no difference. Here also you see live birth rates, no different. Even for prednisolone, mild difference from intralipid, otherwise there is nothing. Let's come to miscarriages, no difference. Rather, control group performs better. And you see here all the three, the intralipid, steroids and etanercept all perform poor as compared to placebo. Let me give you another meta-analysis, 8,500 patients, 14 treatment regimens, all possible combinations that you can think of. Aspirin, heparin, progesterone, vitamin D, this, that. Low dose aspirin plus low molecular weight heparin was the most frequent regime. Almost 3 abortion before, almost mean abortion rate was 3. And if you look at the studies, you see the placebo group was higher, but then low dose aspirin, steroid plus aspirin plus unfractionated heparin, progesterone, cytokine therapy, intralipid, all possible things taken together, only this group performs slightly better. But what I would like to show you that Dr. Kunal did not show, look at this. The confidence interval ranges from 3 to 300, where it will come out in clinic. That is about these therapy. Let's look at the abortion rate. Again, this group performs slightly better. What is this group? This is steroid plus low dose aspirin plus unfractionated heparin. That seems to be working a little bit. Let's look at the successful pregnancy rate. No difference at all. There is no clinical translation. And the same group, they again looked at patients who had antiphospholipid syndrome. All these 14 regimes did not have any significant difference. Now look at the group that we are talking about, unexplained pregnancy losses. No difference. All of them did not show any difference. All these regimes put in any possible combination. The last meta-analysis that I am showing you, 6,000 patients, 38 studies. But you see the kind of evidence we have as on date today. You see the bias here. Most of the studies, more than 40% studies have got a high bias. Can we actually rely on this data? They have looked at live birth rates and miscarriages, and you see there is no difference at all. This study shows some difference, but this is in 93, 94 when we did not have knowledge about heparin being used. It has shown some difference, but otherwise you see live birth rates, progesterone placebo, aspirin heparin, GCSF placebo, low molecular weight placebo, prednisolone. You take any combination, any drug, there is no difference. Miscarriages, you can look at the chart, there is no difference. Another one, there is no difference. So what I'm trying to say is that you can think of all possible combinations that you use in your clinics, put them in any combination. As on date today, we do not have enough evidence in our hands to say any of these things works, especially thinking that it is just an extrapolation of seronegative antiphospholipid syndrome. So this is the same study, the last chart, and the same study quotes in its conclusion, no significant differences between any of the interventions were noted. What they note is there is the birth rates are slightly higher when you use steroids plus heparin plus aspirin, but again it is not statistically significant. So I'll rest my argument with that, and thank you very much.
Thank you, Dr. Ranjan. Looks like it's quite a high voltage argument, both very convincing. So I now request Dr. Kunal for a rebut. Maybe you'll finish it within 3 minutes maximum.
No, I don't need any presentation there. So I sort of agree with sir and I sort of disagree with him also. So I did say that there is a specific subgroup of seronegative antiphospholipid antibody syndrome that has those clinical features of antiphospholipid antibody syndrome that predominantly presents with an obstetric manifestation where anticoagulation has been shown even in large cohorts to be effective. And same way, probably immunomodulation also has its own cohort. So in those studies where they have seen if the uterine NK cell numbers were higher and you gave them immunosuppression including corticosteroids and CNIs, you did found that there was a better outcome. There are multiple studies. The problem with most of these studies are if they are unselected, you would get bad outcomes. If you are using a better selection of patients, your outcomes would be better. So what probably we require is a better in-depth analysis or, as I said, a better immunophenotyping of what these patients come up with. Probably not all of them are having immunological dysfunctions, but a fraction does. And in denying them therapy, you are denying them a possible successful pregnancy which they might otherwise have if they are correctly immunophenotyped and correctly treated. My point was that much in itself, sir. Thank you.
As poor gynecologist, we definitely encounter unexplained pregnancy losses, and we are definitely in distress to give the patient some medication. By hearing Dr. Kunal, I was very happy that I can give everything. After hearing Dr. Ranjan, being a thorough academician, he has given so many meta-analysis. But at the end, I request our speakers to kindly tell what we can actually give.
Before we go back to the speakers, we would like to take a vote from the House. How many of you would support for the motion and how many would be against the motion? Hands for the motion. Hands for the motion. Hands looks like all the gynecologists, looks like it's a 50-50, and hands against the motion. Looks like, yeah, so there is a huge divide. All the gynecologists are for the motion and all the rheumatologists are against. So the motion is as per the population in the House. So what do we do?
The gynecologist can refer their patients to me.
Gynecologists would be referring it to him and rheumatologists would be going by Dr. Ranjan. I think it was a very lovely debate. This is obviously a gray zone in the field of either you call it rheumatology or gynecology, and over time probably we'll come into a consensus when we'll have hardcore guidelines to tell us how to go about, and we'll be looking back at this day as to how we went for a lovely, nice, lively debate. Thanks to both the speakers.
So I'll request the chairpersons and the debaters to go to the felicitation area. So it's nice to see the students because they are the core of the conference, and from now onwards it is your time. So first we are going to have the oral presentation followed by the quiz. So for oral presentation we have clinical experts. So I will request Professor Dr. L.K. Meher sir to please come to the dais. Professor Dr. Josna ma'am, Josna Mai Panda ma'am, please come to the dais. And Professor Dr. Prashant Pradhan sir. So we have a gynecologist, we have a rheumatologist, and we have our teacher, Professor L.K. Meher sir, as a physician. So we have 3 people. And we have around 7 oral presentation. So the time for the oral presentation will be around 6 minutes. And there will be 2 minutes for the question answer.
So good afternoon everyone. You all have been loaded with a lot of information since morning. So this is a very enjoyable session after the intense debate. Now we'll be enjoying the case presentations by different authors. So now I request Dr. Pradhan to invite.
Yeah, first will be Dr. Avarna from KIMS Bhubaneswar.
Good evening everybody and respected judges. I'm Dr. Avarda, second year resident in the Department of Rheumatology at KIMS Bhubaneswar. So I'm presenting a case which I have given the title of APS, Pregnancy and Perseverance. It is a true case of perseverance as we'll see. So we'll discuss in introduction, case presentation, about a little bit of evidence and conclusion. So a brief introduction. Obstetric APS presents with recurrent early miscarriages, stillbirths, preterm birth due to preeclampsia or placental insufficiency. Conventional treatment usually involves low-dose aspirin and heparin, which improves pregnancy outcomes in approximately 70 to 80% of patients. However, we still have a cadre of 20 to 30% patients who are refractory, and we have to proceed to higher treatments. So we'll come to the case here. So this patient, she presented first time, she's a 32-year-old female, and in 2021 she first did her routine blood investigations, and she randomly was found to have low platelets, that is around 20,000. Somewhere she got a diagnosis of ITP, but she was asymptomatic. She was closely followed up and she did not receive any treatment until the second year, that is 2022, when she had her first pregnancy. She conceived naturally, and again during her routine follow-up during her pregnancy, she was found to have thrombocytopenia, that is a count of 20,000. She took only 100 grams of IVIG, but she had an intrauterine death at 20 weeks. After she had this pregnancy loss, she was subsequently worked up. And then her antiphospholipid profile consisting of lupus anticoagulate ratio was high. Beta to glycoprotein IgM and IgA also, which is a non-criteria antibody, was also done, and that was also very high. And other workup for any other associated CTD, like the ENA screen, the complements, the dsDNA, everything was negative. She was diagnosed as a case of primary APS, and hydroxychloroquine and oral anticoagulation were initiated for her. Then the second pregnancy was from December to June of 2023. This pregnancy was managed with low-dose aspirin and LMWH at 40 mg of once daily dose with hydroxychloroquine, which we have already seen is the standard management. This also resulted in severe fetal growth restriction at 20 weeks, and the pregnancy was medically aborted. Coming to the third pregnancy, that was from November 23 stretched to May of 24. This time the dose of LMWH was increased to twice daily, but still this resulted in a preterm delivery at 27 weeks with neonatal death. So this is the final pregnancy that began at October 2024, and the dose of LMWH was stepped up to 60 mg twice a day with hydroxychloroquine, low-dose prednisolone, and this time she was started on IVIG infusions. She was given 120 grams at first 6 weeks, 12 weeks, 17 weeks, 22, and then 27 weeks of her pregnancy. And finally, during June of this year, 2025, she delivered by C-section and had a successful pregnancy. This is a photo sent by the patient herself, which her baby is a boy surrounded by all the needles that she used for her LMWH injections. And throughout her pregnancy, the platelets remained above 50,000 without any bleeding complications. After that, she continued LMWH for a period of 6 weeks, and now she is on anticoagulation, oral anticoagulation with low-dose prednisolone and hydroxychloroquine. So this is the summary, where the first pregnancy, she had thrombocytopenia, she took 100 grams of IVIG. The second pregnancy, she took LMWH with HCQS. Third pregnancy, increased dose of LMWH. And the fourth pregnancy added IVIG to her pregnancy. So the challenges that we faced during the case was that 3 consecutive pregnancy loss despite standard therapy, risk of bleeding because she had severe thrombocytopenia also, and that there was, we were scared to increase the dose of anticoagulation because of there was severe thrombocytopenia, and the balance between thrombosis and bleeding, and obviously that there's an evidence gap for second line higher therapies for refractory obstetric ABS. So what does the evidence say in brief? I'll not go through this in detail. There are a list of 10 mechanisms of actions of IVIG. We do not really know how it really works. So this was the first one RCT I found that was published in 2004 actually, in which IVIG was combined with low dose aspirin and heparin, and they found that this was IVIG versus LMWH and aspirin, and they found that IVIG alone did not result in a greater pregnancy good outcome. And this was one published recently in 2024 in Modern Rheumatology, in which only 2 of the 8 cases actually, when they added IVIG to the conventional therapy, had a successful pregnancy. Rest all of them actually required something else like rituximab or pravastatin. These are few case reports and case series only which have shown successful pregnancies outcomes with IVIG. So the model, and this is the guidelines that have been published by the ULAR in the year 2019. They say that in women with criteria of obstetric APS, the standard is low dose aspirin and heparin, and you can add HCQ and low dose prednisolone and IVIG only in very highly selected cases. And the grade of evidence, as you can see, is quite low. So coming to the conclusion, as we learned from the case, that a very individualized approach is very important. A combination strategy may sometimes help and save the day in such cases. We need the help of the gynecologist obviously, and persistence in protocol flexibility is important. Always following the guidelines step by step might not be very helpful. That's all. Thank you.
Thank you. Now the case is open for discussion or question and answer. Any questions from the floor? Anybody? Okay, if there are no questions, I can ask one question. What is the rationale of giving monthly IVIG?
So the duration of action of IVIG lasts for 3 to 4 weeks only. So it's when you want to give IVIG, it will not work beyond 4 weeks. That is the rationale, because it will get cleared off the body after 4 weeks. So we give monthly doses.
Okay, if the patient doesn't agree for IVIG monthly, then do you have any other option?
Not sure, sir.
Not sure. Anybody from the floor? Okay.
So what is your conclusion from this study?
So the conclusion from this case is that a lot of, like the RCTs that I showed, they have shown that IVIG has actually failed, has not worked every time. But there are case series and case reports which have shown successful use. So we should not be scared to go to a higher treatment. We can use IVIG and that can have a successful outcome like in this patient. So important is perseverance from the patient and the doctor, not to give up and to actually go to a higher therapy, especially if the patient can afford it. We should try IVIG.
You have tried only in one case. Yeah. Look, what you could have done, you could have made a series. One group receiving IVIG and the other group receiving maybe LMWH and aspirin.
Sir,
like that. That would have established simple success of one report will not conclude that IVIG is effective in refractory cases. This is my opinion.
So that is true, sir. We obviously required that, and that
okay.
is the.
Thank you. We go to the next case. So we go to the second case to be presented by Dr. Siddhant Sahu from SC Medical College.
Shall I start? Good evening all. I am Dr. Siddhant, postgraduate general medicine from SC Medical College. My topic is 2 women, 2 stories, reproductive clues to hidden autoimmunity. As the title suggests, I have 2 cases and their extensive evaluation and how we reach at the final diagnosis. The first case, 16-year-old female from Moyurganj with a history of previous history of nephrotic syndrome and treated in the line of MCD and responded beautifully to steroid. On 2023, patient presented to us with 6 months history of mucocutaneous candidiasis in the form of oral thrust bulbovaginal candidiasis, and patient did not take any medicine for that. After 6 months, he presented to us in casualty with classical signs and symptoms of diabetic ketoacidosis. As you can see in the investigations, the RBS was 618 with metabolic acidosis, BICOR was very low, and the urine ketone body was positive, HbA1c was 18, and the precipitating factor might be UTI because POS cell was high, urine culture shows E. coli, there is neutrophilic leukocytosis, creatinine was 1.9, so urosepsis and AKI. The story does not end here. Patient also had signs and symptoms of hypocalcemia. We evaluated hypocalcemia. The cause turned out to be hypoparathyroidism. The intact VTS was 11.9, total adjusted calcium was 6.9. And patient also had, as I told earlier, chronic mucocutaneous candidiasis with signs of ectodermal dystrophy. You can see in the picture there is Spammer hyperkeratosis. So connecting the dots, type 1 DM, hypopara, chronic mucocutaneous candidiasis, and ectodermal dystrophy. The final diagnosis was autoimmune polyendocrine syndrome 1, autoimmune or otherwise called as autoimmune polyendocrinopathy with candidiasis with ectodermal dystrophy. What else we have? Patient had menarche at age 14, followed by irregular menstrual cycle for few months, followed by stoppage of menstrual cycle for last 1.5 years, and breast and pubic hair tan stage 4. Also had symptoms of persistent hypotension, absence of hyperpigmentation. So we go by the protocol. We thought this could be a case of secondary amenorrhea. We did a UPT which was negative. Then we, according to the algorithm, we did prolactin, TSH and FSH. TSH was normal, prolactin was normal, FSH was low. We did LS, LS was also low. And TFT shows secondary pattern, central pattern. That's why we did a MRI brain pituitary protocol to look at the hypothalamo-pituitary axis, and it shows mild inflammation involving the infundibulum and the anterior pituitary. On subsequent follow-up after 10 months, what we got partial empty cell syndrome. It has progressed. Yes. During the MRI, we also got a midbrain stroke which did not manifested. You can see in the diffusion weighted imaging in the below, we have marked also diffusion restriction was there. During follow-up, it was normal. Patient also had nephrotic syndrome. So the final diagnosis was APS1, and the non-endocrine manifestations were nephrotic syndrome and vasculopathy. My second case, 25-year-old female from Cuttack, with history of 2 spontaneous first trimester pregnancy loss and history of hypothyroidism, for which she did not take any medicine. Patient presents to ER with classical signs and symptoms of Addisonian crisis. There is hyponatremia, hyperkalemia, cortisol was low. Yes. You can see in the picture there is mucosal hyperpigmentation and there is Spammer hyperpigmentation. So my diagnosis was primary adrenal insufficiency. On probing further, patient had 2 spontaneous first trimester pregnancy loss followed by a normal delivery without any PPS, without need of transfusion during the delivery. And now patient is prolongation of amenorrhea till 18 months. It could be lactational, but lactational amenorrhea can persist up to 18 months, but it is rare. And also the context was peripartum. So we thought it could be a case of hypophysitis, which is transient, might be. So according to the protocol, we did prolactin, TSH and FSH. FSH was low, less than 5. TFT shows central pattern. Prolactin was normal. That's why we thought it could be a case of transient hypophysitis. Anti-TPO was also positive. Another clue. You can see in the picture, patient had classical ear pinna involvement, which was relapsing, tender, classical lobar sparing, and without any signs of itching. Also, patient had pain over dorsum of nose, and you can see anterior neck swelling without thyromegaly or any lymphadenopathy. So this could be a case with raised inflammatory marker, of course. This could be a case of relapsing polychondritis. And now it's involving the marrow also. Patient had pancytopenia, hypoproliferative marrow, with low retic and the nutritional parameters with normal limit. You can see in the picture there is marrow precursor cell vacuolation. Yes, connecting the dots, Addison, transient hypophysitis, Hashimoto-thyroiditis, relapsing polychondritis, precursor cell vacuolation in the marrow. What could it be? The mutation, along with those symptomatology, with UBA1 gene mutation, it could be a case of classic VEXAS syndrome. VEXAS stands for vacuolation, U1 enzyme, X-linked, autoinflammatory phenotype, and somatic mutation of UBA1 gene in the X chromosome. So we did a whole exome sequencing. UBA1 was negative, but we got certain other mutations, ITPKB, PDGFRA, and MAP2 kinase. So our final diagnosis was UBA1 negative VEXAS-like syndrome, likely clonal hematopoietic disorder involving CHIP or CCUS, clonal cytopenia of unknown significance. We got the mutations, that means we had clonality, and we have pancytopenia. So clonal cytopenia of unknown significance with inflammatory phenotype is we have RPC. So thank you Department of Clinical Immunology and Rheumatology, SCB Medicine for this. When the three specialties intersect, it's no longer a case, it's a conversation. Thank you.
So thank you, Dr. Siddhant, for excellent case presentation, in fact. So any question from the floor? I have a doubt regarding the case with hypopid that we are showing. You told that this was a case of autoimmune hypophysitis?
Sir, which one? First case or second?
Second case, autoimmune?
Sir, second case, we thought it could be a case of transient hypophysitis.
What is the basis?
The context was peripartum, first, the postpartum setting. Second one is what he thought, if it could be a case of lactational amenorrhea, the mechanism behind that is prolactin-induced GnRH suppression. Here the prolactin is normal. That's why we did other hormonal investigations, and the TSS was low, central pattern of hypothyroidism was also there, and there is low LH and FSS, so multiple pituitary hormone insufficiency was there. So we thought this could be a case of hypophysitis. But the imaging was normal.
Yes, and
it
during that stage, you expect increased prolactin.
Yes,
as well as MRI also should have shown swelling of the pituitary,
yes, yes,
but
sir.
it was not there. So it is better not to assume autoimmune hypophysitis at this stage.
Yes,
was
sir,
there
yes.
any possibility of seance?
No, sir. The patient did not have any signs of postpartum hemorrhage or requirement of transfusion during that case, and patient classically did not have lactational failure. Patient was lactating well. Seance have lactational failure.
Okay, thank
you. Any questions from the floor? Okay, thank you.
Thank you.
So next case is Dr. Swaraj Nandini Pandey from AIMS Bhubaneswar.
Good evening all. Thank you for staying back long. I'm Dr. Swaraj Nandini Pandey, fellow of high risk pregnancy and perinatology in AIMS Bhubaneswar. I'll be talking regarding a topic, navigating a high risk pregnancy with chronic immunothrombocytopenic low platelets and APLA by a multidisciplinary team approach for a successful pregnancy outcome. The case was managed by Department of Obstetrics and Gynecology and Hematology at AIMS Bhubaneswar. Coming to background, the incidence of APLA in general population is 0.15%. It is associated with adverse fetal-maternal outcomes. It is an acquired thrombophilia and can cause recurrent pregnancy loss. The risk of abortion in such women is as high as 30 to 40%. Coming to the next disease, that is the incidence of immune thrombocytopenia is 1 to 2 cases per 10,000 population in India. But the combination of both APLA and chronic ITP is rare. Coming to introduction, APLA syndrome is characterized by thrombosis and fetal losses. It is caused due to endothelial activation, C3 activation and TNF alpha production, which will cause the clinical symptoms. This is the clinical criteria of diagnosis given by the ACR ULAR in 2023, where they have given 6 domains of clinical domains followed by laboratory domains, where now they are weighted. According to the new guidelines, they are weighted. We have to give points, and a total of score of more than 3 will define the case to have antiphospholipid syndrome, APLA syndrome. So aims and objective of this case was to identify challenges and outcomes in management of a woman who have recurrent pregnancy loss with APLA and chronic ITP. Coming to the results, she was a 26-year woman from West Bengal who was following up from the past 3-4 pregnancy. For this pregnancy, she was gravida 4, para 1, live 0, abortion 2, diagnosed as APLA with chronic ITP. She was managed by a multidisciplinary team approach. These are the history of her previous pregnancy. The first pregnancy was in August 2022, which was where the pregnancy at TIFA scan was diagnosed to have oligohydramnios, and at that time, first time she was diagnosed to have low platelets with counts of 20,000, for which hematology call was given. But the platelets subsequently improved. But what happened to the fetal outcome is that the baby lost the cardiac activity and underwent expulsion with 300 grams. Followed by she again conceived spontaneously in 2023. Again, after TIFA scan, she developed REDF for a follow-up scan, and there was stage 3 FDR. So she was planned for expulsion, and placenta was sent for histopathology, and it showed infarct. Again, she became pregnant in September 2023. But after TIFA, the pregnancy was prolonged, and she had spotting PV in the initial first trimester and second trimester once. TIFA was suggestive of early onset FGR, followed by which she developed absent end diastolic flow, which is stage 2 FGR, and the baby, and she delivered a 450-gram child who received comfort care for 2 days, but subsequently expired. In between these 3 pregnancies, giving her previous histories, she was evaluated for APLA, and LAC was found to be positive. Persistent LAC positivity was found, and then subsequently she became pregnant in October 2024 with a positive outcome, where she was admitted at 34 weeks with a CPR of 1, and she underwent an emergency cesarean section with myomectomy to give a preterm baby of 2.2 kg. Both mother and baby are doing well now. So initially she presented with thrombocytopenia. The peripheral smear had thrombocytopenia with few giant forms. The platelet counts always ranged from 60,000 to 1.5 lakhs. The DCT was negative. Other coagulation profile, which we sent PT, APTT, D-dimer, fibrinogen, were negative. These are her reports which were positive. Anti-dsDNA and ENA blot were negative. LAC was persistent positive, 12 weeks apart. APLA, IgM and IgG were negative. Cardiolipin was negative. So according to this ACR ULAR criteria, she had fetal death, which gives score of 1, and persistent positive LAC, which gives a score. So she was diagnosed case of APS. And in this pregnancy, in the previous 2-3 pregnancies, she had received low-dose aspirin, HCQ. Initially, she was given a trial of prophylactic heparin, but in this pregnancy, to be cautious, she received therapeutic dose heparin, HCQ, prednisolone, and IVIG also she received throughout the pregnancy, and these were her platelets throughout the pregnancy. She did not develop any gestational hypertension, IUGR, bleeding manifestation. The NT-NB dual were normal. She was admitted and gave birth to a healthy child. The challenges were availability of immunoglobulins, long duration of stay because patient was from Bengal. She had to stay back in Bhubaneswar, and there were 7 to 8 episodes of hospitalization because the IVIG has to be given in daily doses for 5 to 6 days as per her body weight. So for this case, the challenge was balancing both. We had to avoid thrombophilia, and at the same time, low molecular weight heparin she was receiving. And this type of clinical case is a rare occurrence, and rarely we see such cases. And the conclusion is that though the case is rare, but the patient has severe psychological trauma and economic and emotional burden throughout her pregnancy. But finally, she had a positive outcome with a multidisciplinary team approach by the obstetrician, hematologist, neonatologist, and immunologist with better facilities and IVIG medication available to her in low cost. These are my references. Thank you.
Any question from board? Any question? So in the last pregnancy, she had not received anything.
She received, ma'am, I showed in there, she received HCQ, prednisolone, low molecular weight heparin.
So
in
this pregnancy only IG was added.
Extra, and the heparin was in therapeutic dose. Though she did not had any thrombotic events in the
There is a
past.
similar case to the first one. Yeah. Okay.
What was about ANA? You didn't mention about ANA.
Sir, ENA blot report I found.
No, ANA. You tell us ANA first. Once ANA is positive, then you go for ANA.
Yes, sir.
You
ENA
have never
report
shown,
I could find. I did not put that, but it was there. For her
It was
only
positive?
lac was positive. No, that was negative. It is a primary APS only.
So no point in doing a DSDNA again.
She
If ANA is
outside she was showing, sir. She had investigation, so I had put. We had not done lac reports. She followed up later, so we followed up according to the lac reports. Multiple hospitals she had gone, sir. She had gone Delhi also once, and outside also she was showing.
Okay, thank you.
Thank you, sir.
The next one is Elia Fatima from KIMS Bhubaneswar.
Good evening, one and all. Myself, Dr. Elia Fatima, a second-year PG resident from KIMS Bhubaneswar, would like to present a rare case of thrombotic thrombocytopenic purpura in pregnancy. My patient, a 35-year-old female, gravida 3 para 1 abortion 1 living 1 at 32 weeks 3 days of gestational age with previous caesarean section was referred from Bhadrak, showing ultrasound report of polyhydramnios and Beckwith-Wiedemann syndrome in fetus. She had complaints of back pain, pain in thighs, pain in lower abdomen since last 15 days, which were gradual in onset and progressive in nature. She had regular past menstrual cycles. Her obstetric history was she was married for 8 years. She was a gravida 3 para 1 abortion 1 living 1. Her first pregnancy was a caesarean 7 years back, which was uneventful, and she had an abortion 3 years ago. Her first trimester and second trimester in this pregnancy were uneventful, and during third trimester she had complaints of abdominal discomfort since 30 weeks of gestational age. She had no significant past history or family history, and she had completed 2 injection doses of betnesol at 31 weeks of gestational age. On examination, patient was conscious, coherent and restless. Her vitals were stable. She had no significant abnormality in systemic examination, and on perabdominal examination, abdomen was over distended, abdominal wall looked shiny and thin. There were no visible pulsations. On palpation, previous caesarean scar was healthy and no scar tenderness was present. She came to us with an ultrasound report showing polyhydramnios with AFI of 29.8 and macrosomia, macroglossia, hepatomegaly, nephromegaly suggestive of Beckwith-Wiedemann syndrome in the fetus. Her provisional diagnosis comes to be G3P1L1A1 at 32 weeks 3 days of gestational age with previous caesarean section with polyhydramnios, Beckwith-Wiedemann syndrome in fetus for safe confinement. She was planned for conservative management in the hospital. Prognosis and condition of the baby was counseled by fetal medicine specialist. All the relevant investigations were sent and were within normal limits. In due course of hospital, severity of abdominal discomfort gradually increased, and patient on 7th of November, patient had reported severe discomfort for which she has been taken up for caesarean section, indication being previous caesarean section with severe maternal distress and scar tenderness. During caesarean section, we have noticed that her lower uterine segment was papery thin, and she delivered a female baby of weight 2.8 kg with a percentile of 95%. After delivery of the baby, atonic PPH of 1.5 liters occurred, and during abdominal closure, lots of oozing and bleeding points were encountered in the rectus sheath and muzzle. This is the Beckwith-Wiedemann syndrome baby with the syndromic features of absent nasal bridge, macroglossia, macrosomia, sandal gap and Crimean grease. During her postoperative period, patient complained of uneasiness. On examination, pulse was not palpable. There were cold extremities and urine output was only 20 ml in last 2 hours. So medicine consultation was given, and they have advised 1 pint PRBC to be transfused in view of hypovolemic shock. And she was shifted to ICU. In ICU, on POD1, patient was stable with mildly deranged sodium and potassium values with a platelet count of 30,000. Medicine consultation was done, and they have made provisional diagnosis of query DIC, query help, and they have advised 4 pint RDP to be transfused. On POD2, her platelet count comes to be 50,000 with ABG revealing metabolic acidosis, and a provisional diagnosis continued to be the same. On POD 3, patient was stable, but hemoglobin comes to be 6.2 and platelets were 27,000. POD 4, patient became breathless, febrile and desaturated. Hemoglobin was 6.2 and platelet were 12,000. Her LDH was 797. Hematology consultation was done and they have advised immediate plasma exchange, injection methylprednisolone to be started and to stop RDP immediately. They have made a provisional diagnosis of TTP with a plasmic score of 6. On POD 5, patient was breathless and was kept on non-invasive ventilator. Hemoglobin was 6.2 and platelet was 5,000. Transfusion medicine consultation was done. They have advised that as the platelet count was only 5,000, the plasma exchange cannot be done, so they have advised plasma transfusion. We have transfused her with 4 FFP. POD 6, patient was breathless, tachypneic, so she was intubated. All the blood parameters were deranged. So there was a diagnosis, so it was TTP with progressive organ damage and persistent thrombocytopenia. We have transfused her with 4 FFP. On POD 7 of LSCS, patient developed asystole and BP was not recordable and she was declared dead. Summary, a G3P1L1A1 at 33 weeks, 1 day of gestational age with previous CS with polyhydramnios and Beckwith-Wiedemann syndrome in fetus. LSCS done on 7th of November, baby kept in NICU. Patient had persistent thrombocytopenia and fall in FB, shifted to ICU. Hematology call was given, provisional diagnosis as TTP. Patient got intubated in view of desaturation and metabolic acidosis and she developed asystole, CPR was given and she was declared dead. Cause of death, immediate cause of death was anemic heart failure and underlying cause was TTP with progressive multi-organ failure. Take home message, high clinical suspicion is crucial, early diagnosis saves lives, multidisciplinary management is essential, plasma exchange is the cornerstone of the treatment, increasing awareness of the platelet disorders in pregnancy and not to miss the diagnosis. Thank you.
Thank you. Now the case is open for discussion. Are any questions from the floor? What do you think could have been done earlier to prevent the mortality in this patient?
Sir, we could have suspected TTP beforehand or any immune thrombocytopenias in the first hand when her platelet was 30,000 on POD 1 itself. So we could have saved her by starting plasma exchange. We could have not waited until her plasma fell down to 5,000. As her platelets were 5,000, we could not start her with plasma exchange. So we could have saved her life by doing that, sir.
Second thing, what are the indication to give IV methylprednisolone in this patient?
Sir, actually, in TTP, steroid is an indication to give IV methylprednisolone 1000 mg per day for 3 days along with plasma exchange, and if it is refractory, then we have to start with rituximab or keplakizumab.
Okay, thank you.
Thank you.
So we have the next case from Dr. Sonali Barik from AIMS Bhubaneswar.
Good evening, everyone, respected chairpersons and my dear colleagues. The silent war within. The study is Pregnancy Outcomes in Autoimmune Diseases, a Clinical Perspective. Autoimmune disorders are chronic multisystem conditions which predominantly affect women of reproductive age. Pregnancy in such women is often complicated by disease activity and the immune-mediated effects on the fetus due to the transplacental passage of autoantibodies. Hence, the objective of the study was to evaluate maternal and fetal outcomes in pregnancies complicated by autoimmune diseases. It was an observational study done in the Department of Obstetrics and Gynecology at AIMS Bhubaneswar. All the primary and multigravidas with pre-existing or newly diagnosed autoimmune diseases were included. Coming to the results, during the period of 2 years, there were total 33 pregnant women with autoimmune disorders, among which 27% had systemic lupus erythematosus, followed by Apla syndrome in 19% of the patients, followed by immune thrombocytopenic purpura in about 11% of patients, followed by, as we can see, Hashimoto thyroiditis, hyperplastic nodular goiter, and one case each of adult onset nephrotic syndrome, Raynaud's phenomena, mixed connective disorder, atypical HS, etc. The typical age group was maximum of the patient lied between the age group of 25 to 34 years. Most of them were multigravida, and multigravida who had obstetric history, among those almost 1/4 had bad obstetric history. Coming to the maternal complications, patients who did not have any complication were around 23%, with complications like fetal growth restriction, thrombocytopenia, thrombocytopenia with FGR. We can see maximum developed fetal growth restriction and thrombocytopenia, and as expected, preeclampsia. Coming to the pregnancy outcomes, almost more than half delivered by cesarean and around 26% delivered by vaginal delivery. 43% had preterm deliveries and only 36% had term deliveries. 7 patients among 33 were aborted. Coming to the neonatal outcomes, around 46% had NICU admissions, 2 were intrauterine fetal deaths. ICU admission, maternal ICU admission was seen in 1 patient, and maternal death also was seen in 1 patient. Coming to the disease specific, I will like to just specifically focus here. Patient with SLE and lupus nephritis came with lupus flare. This patient was referred to us from the Department of Nephrology for MTP. And as we can see here, most of them developed fetal growth restriction and preeclampsia as expected. Coming to the APLA syndrome, secondary and primary both, complications like fetal growth restriction, oligohydramnios were most common, and pregnancy outcomes were including intrauterine fetal death, FGR, and ICU admission, and preterm deliveries were seen. Coming to the ITP also, complications like gestational diabetes, preeclampsia, fetal growth restrictions were very common, and outcomes like preterm deliveries were regularly seen. There was 1 patient of catastrophic APLA syndrome also, where plasma exchange was done, and currently the patient is continuing her pregnancy. Coming to the discussion, our current study included 33 women, and earlier studies on SLE as well as on APLA syndrome have seen the mean age as expected is the reproductive age group, which gets commonly affected by this, and our study emphasized that early detection and pre-pregnancy counseling and multidisciplinary care is the cornerstone of treatment here. And in other studies also, it has been seen that if preconceptionally the score, the SLE disease activity was less, and the use of hydroxychloroquine was seen to have a better outcome. And in cases of APLA, secondary or primary, use of low molecular weight heparin along with low dose aspirin had been shown to have a better outcome. The maternal complications as expected were seen in like preeclampsia, gestational hypertension, thrombocytopenia, lupus flare. In other studies also it has been seen. Fetal outcomes, we had for preterm births in around 43% patients. It was seen, but with in like SLE cases, if preconceptional flare is not there and the disease is inactive, these fetal outcomes were seen to be very lower. So conclusion, pregnancy in women with autoimmune disorders pose a significant maternal and fetal risk. Therefore, early preconceptional counseling, close monitoring, and multidisciplinary care is the cornerstone of treatment. Obstetrician along with the rheumatologist have to come together to improve the outcomes in high-risk group. These are my references. Thank you.
So, whether you control the study where you started the drugs, so that is not there in the study. I think when you started and
yes, ma'am. It was an observational cohort study, ma'am, which we had taken a cohort of patients with autoimmune.
Most of the complications that occur in the latter part of the pregnancy, when it is very pertinent that whether you started the drugs from the beginning or not. That depends on that only.
Yes, ma'am.
Because of the trophoblastic invasion. So whether the drugs are started from the beginning or not, that is not there. So we cannot correlate the complications with the patient's number of the...
Yes, ma'am. That is where the preconceptional counseling, so the role of preconceptional counseling comes.
Actually, it was just an observation of a series of autoimmune diseases, the pregnancy outcome you were studying.
Yes, sir.
So, what is the result Actually, the whatever conclusion we have shown,
Yes, sir.
that is not really the result.
Yes,
Your,
sir.
your, yes, yes, your result doesn't match, your observation doesn't match the result actually. You
Yes,
could
sir.
get my point or not?
Yes, sir. Yes, sir. I get your point, sir. If I have to conclude this particular study, the favorable outcomes was seen in very less patients. That is only 21% of the pregnancy had favorable outcomes. That is why I concluded as saying that preconceptional counseling is very important and multidisciplinary approach is important. Yes, ma'am. Yes, ma'am.
That is your recommendation. You should
Yes.
have told this is the commonest complications, the commonest autoimmune disease that you encounter, like that.
Yes, sir. Okay.
That should have been the result. And this is your recommendation.
Okay, sir.
Thank you. So
Thank
we
you,
go
sir.
to the next topic.
Yes, Dr. Supriya Rao from Capital Hospital, Bhubaneswar.
Good evening, everyone. Respected judges and delegates, I, Dr. Supriya Raut, first year PG resident from PGRN Capital Hospital, is going to present before you my case on pregnancy with recurring pregnancy loss with SLE and secondary APAs with thrombocytopenia. To start with the introduction, SLE is a systemic autoimmune disease with multisystem involvement and is associated with significant morbidity and mortality. The condition has several phenotypes with varying clinical presentation from mild mucocutaneous manifestations to multi-organ and severe CNS involvement. SLE is the most common cause of secondary antiphospholipid syndrome. To start with my case, my patient Mrs. X was admitted to the LR of ONJ department at PGRN Capital Hospital at 5:30 p.m. on 28 December 2024. She didn't have any specific complaints. She was admitted for the termination of the ongoing pregnancy with ultrasound reported finding of missed abortion. She was a G3A2 with pregnancy of 16 weeks gestation. She was a known case of SLE on routine ultrasound scan. She was reported as missed abortion and was admitted seeking further management. There was no recent history of fever, skin rash, oral or nasal ulcer, hair fall, arthralgia, headache, frothing of the urine, hematuria, chest pain, cough or shortness of breath. Her menstrual cycles were regular. She was a G3A2 of gestational age 16 weeks 4 days. Her first pregnancy was in 2016. She had spontaneous abortion at 6 weeks 2 days for which she was managed medically. Her second pregnancy was in the year 2021. She was evaluated for secondary infertility. She conceived through IVF and again spontaneous abortion occurred at 18 weeks 4 days. And there was history of SLE fled then like fever, rash and arthralgia. And she expelled a dead fetus, male 200 grams. There were no external anomalies or no cord or placental anomalies. History of present pregnancy, she was of gestational age 16 weeks 4 days. She conceived spontaneously. She was taking folic acid 5 milligrams daily. Her dating scan showed DCTA twin pregnancy. First twin was 6 weeks live and second twin 5 weeks. Heartbeat was not recorded. Dual markers were negative. NT scan was normal, which showed single live intrauterine gestation. She was on tablet hydroxychloroquine, low molecular weight heparin, and there were no history of fever, hyperemesis, or bleeding per vagina. On second trimester, her obstetric scan showed gestational age of 16 weeks 6 days with fetal demise, placenta posterior. There was increased hair fall, ecchymotic patches at the injection site. There was no history of fever, rash, or bleeding manifestation. No evidence of hypertension, pedal edema, or frothing of the urine. The patient was on tablet hydroxychloroquine, prednisolone, tacrolimus, injection low molecular weight heparin, which was later stopped in view of thrombocytopenia. Her investigations in the first trimester, her hemoglobin was 9.2 gram per deciliter, platelet was 79,000. All other investigations were normal. In second trimester, her platelet count increased to 25,000, which later decreased at 14 weeks 6 days to 46,000. And this was her APLA report. It showed APTT of the patient being 65.3 as compared to the control, which is 32.80. So there was an increase in the APTT, suggesting either there is lupus or presence of lupus anticoagulant or clotting factor deficiency. So we performed the mixing test, APTT 1:1. Patient plasma plus normal pooled plasma was mixed, which was again not corrected, suggesting the presence of lupus anticoagulant. Then we performed a dilute Russell Viper Venom screen test, which uses low phospholipid. So because it uses low phospholipid, the presence of lupus anticoagulant, it interferes with the clotting factor, so clotting time will be increased. The DRVV screen ratio was increased, and in the DRVV confirmed ratio, it uses high phospholipid. So the extra phospholipid, it neutralizes the lupus anticoagulant, so the DRVV confirmed ratio was normal. So a high DRVV screen ratio, normal confirmed ratio, leading to an increased normalized ratio, more than 1.20, suggested the presence of lupus anticoagulant. In her past history, she was diagnosed as a case of SLE in 2020 with symptoms of malar rash, generalized skin rash, photosensitivity, oral ulcers and alopecia. She was started with prednisolone, and this was the antibody profile. In 2021, she had history of multiple joint pain, severely in the hands and feet with multiple stiffness along with photosensitivity skin rash, especially in the malar region. Her drugs, she was started with hydroxychloroquine and prednisolone. In view of thrombocytopenia, in the further years, her drugs were gradually upgraded from azathioprine to mycophenolate, which was given in escalating doses. Again, in the year December 2023, she developed ecchymotic patches with decreased platelet count. So in view of refractory thrombocytopenia, she was admitted and received 2 doses of rituximab. After detection of pregnancy, her platelet count was 2.15 lakh, and she was started with injection low molecular weight heparin, 0.6 mg subcutaneous daily. She was continued prednisolone, hydroxychloroquine, tacrolimus, calcium, vitamin D3 and folic acid. There was no history of diabetes mellitus, hypertension, thyroid disorders, epilepsy, asthma or heart disease or any renal disease. There was no history of drug intake to cause drug-induced lupus or flare-up of the established SLE. And this was her APLA profile. It showed anti-beta glycoprotein IgM was increased, which was 26.77. Family and personal history was nothing suggestive. General examination and systemic examination were within normal limits. On inspection, her abdomen skin was healthy, umbilicus central everted, no engorged veins, rash, telangiectasia or visible pulsation. Uterus was 14 weeks non-tender relaxed. On per vagina, cervix was long, soft, on os closed. So my diagnosis was a G3A2 at GA16 weeks 2 days with recurrent pregnancy loss with SLE and secondary APS with thrombocytopenia. And these were the investigations advised, and the platelet count was reduced to 75,000. This was the course of treatment after admission. She was given these injections, and she was given tablet misoprost, 400 microgram 3 hourly until expulsion. She finally expelled a dead male abortus weighing 250 gram, which was expelled along with the placenta. The post-expulsion vitals were normal, and the whole exome sequencing, microRNA assay and DNA storage of the placenta and the abortus was sent. The whole exome sequencing report is as follows. The summary being, the index patient was found to be heterozygous for an uncertain significant variant in the SLC25A24 gene associated with Fontaine-Progeroid syndrome. The index patient was found to be a carrier of a variant in the CPT1A gene associated with carnitine palmitoyl transferase deficiency, which was found to be a pathogenic variant. So my summary being, 31-year female G3A2 with pregnancy of 16 weeks 4 days, a known case of SLE, symptomatic since 2020 with secondary APS and thrombocytopenia. On treatment was admitted for missed abortion. She had a history of first trimester spontaneous abortion of first pregnancy in 2016 and mid-trimester fetal demise of second pregnancy in 2021. She was evaluated for SLE with APS with an anti-nuclear antibody, extractable nuclear antigen and APLA positivity, and diagnosed with thrombocytopenia. She was treated with immunosuppressive agents like hydroxychloroquine, prednisolone, azathioprine, mycophenolate, phenolate mofetil. She received 2 doses of injection rituximab in view of refractory thrombocytopenia. She again conceived in the 2024, had regular ANC, was on prednisolone, hydroxychloroquine, tacrolimus with thrombocytopenia, no episodes of SLE flare. Her APLA was positive. She again had a pregnancy loss at 16 weeks 4 days. Expulsion was done. Whole exome sequencing, microRNA assay, DNA storage was sent with the report heterozygous for uncertain significant variant in the SLC25A24 associated with familial progeroid syndrome, which was the autosomal dominant trait, and a carrier of a variant pathogenic in the CPT1A gene, which was autosomal recessive. So my recommendation for the next pregnancies being, we recommend low-dose aspirin beginning at 12 weeks gestation until delivery in patients with SLE to decrease the occurrence of preeclampsia. We recommend that all the patients with SLE, other than those with Poisson disease, either continue or initiate hydroxychloroquine in pregnancy. Prolonged use of NSAIDs, COX-2 inhibitors, full dose aspirin should be avoided during pregnancy. Treatment with a combination of prophylactic unfractionated or low molecular weight heparin and low dose aspirin for patients without a previous thrombotic event who meet obstetrical criteria for APS. At last but not the least, we recommend that patients with SLE undergo pregnancy counseling with both maternal and fetal medicine and rheumatology specialists, which includes a discussion regarding maternal and fetal risk. We recommend that pregnancy be generally discouraged in patients with severe maternal risk, including patients with active nephritis, severe pulmonary, cardiac, renal or neurologic disease, recent stroke or pulmonary hypertension. Thank you.
So any questions? So time is already exceeded. So no question. Thank you. Thank you. Dr. Alaka Panda from SCV Medical College, Cuttack.
Good evening, one and all. I am Dr. Alka Panda, PG resident at the Department of Obstetrics and Gynecology at SV Medical College, Cuttack. So my case is about a pregnancy with ITP with multiple obstetric complications. It was a 28-year-old female from Kendrapada. The patient was being followed up right from her preconceptional period till her complete delivery on an outpatient basis. Her first admission at our site was on 31-week 4 days gestation with a chief complaint of bleeding per rectum for last 2 days. Her menstrual history was quite normal. She had no history of menorrhagia or any complaint as such. She was married since 5 years and had one history of spontaneous abortion at 10 weeks gestation 4 years back. And she was continuing her second pregnancy. She had no chronic illness and was not a known hypertensive or diabetic. She has had a tendency of easy bruisability, occasional epistaxis and gum bleeding right since childhood, for which she did not seek any consultation. She was diagnosed as a case of ITP 4 years back after ruling out other hematological and immunological causes, and she was started on tablet aspirin 150 and tablet prednisolone 20. The dosage was increased to double at 31 weeks gestation. She had a history of taking IVIG twice previously, once 2 months prior to testing positive for pregnancy, and the second at 15 weeks of gestation. Her blood group was O negative and her husband was B positive. Her general and systemic examination was fairly normal. On obstetric examination per abdominally, the uterus was about 24 to 26 weeks sized and relaxed. There was no leaking or no bleeding from vulva. The relevant investigation showed that her ultrasound finding, her average gestational age was 28 weeks and her baby weight was 1.1 kg. Her liquor was fairly normal. At that time, the platelet count was 11,000. The investigations were repeated during her inpatient stay and the platelet count came out to be 21,000 while the rest of her parameters were normal. ICT was negative, so the patient was discharged after 2 days of conservative management and after being given anti-D injection with an advice to attend ANC OPD regularly and to continue iron calcium along with amino acid and vitamin supplementation. On her second admission at 36 weeks, 6 days of gestation, she had come for a routine checkup and at that time she was continuing tablet prednisolone, aspirin and she had started tablet L-Trombopeg 25 OD 1 week prior to her admission. At that time, an ultrasound was done. Her average gestational age was 30 weeks, 5 days and baby weight was 1.6 kg. Liquor was reduced. She had an A5 of 4 and there was abnormal umbilical artery Doppler. Her vitals were stable. On per abdominal examination, the uterus was about 28 to 32 weeks size. FHR was normal, that is 142 beats per minute. Her cervix was long, os was admitting tip of finger and the pelvis was adequate. At that time, the platelet count was 23,000. Aspirin was stopped, 2 units of RDP were given and the patient was planned for an elective LSCS after 2 days in view of oligohydramnios with IUGR with abnormal Doppler. On the second day of her admission, 5 units of RDP were transfused and she was given injection methylprednisolone 1 gram for 3 days and she was, her dose of L-Trombopeg was doubled and she was advised to continue that for 5 days and she was advised to be given 6 units of RDP or 1 unit of SDP for 3 days. The third day of her admission, she was transfused 1 unit of RDP and she was advised to continue injection methylprednisolone and she was advised to be given injection IVIG again over 12 hours on the day of her LSCS along with 6 units of RDP or 1 unit of SDP. On the 4th day of her admission, her blood pressure shot up to 180 over 100 millimeters of mercury which was brought down to normal with injectable antihypertensives. Urine albumin was negative. The patient was planned for emergency LSCS in view of severe preeclampsia with uncontrolled BP, with IUGR, with oligohydramnios. The platelet count was 23,000, so she was given 1 unit of SDP. So at this point, the provisional diagnosis of my patient was gravitative abortion 1 at 37 week 2 days with ITP, with preeclampsia, with severe features, with RH negativity, with severe IUGR, with oligohydramnios. She underwent cesarean section under general anesthesia and delivered a 1.3 kg female baby. The baby cried soon after birth and was attended by pediatrician. Her Apgar was 6/10 or at 1 minute of birth, and after 5 minutes it was 8/10. She was sent to SNCU for low birth weight. She had an episode of atonic PPH which was not controlled with uterotonics and antifibrinolytics. So bilateral uterine artery ligation and uterino-ovarian artery anastomosis ligation had to be done. There were multiple oozing spots over the rectus muscle bed. The abdomen was closed after securing proper hemostasis, and there was an approximate blood loss of about 1 liter. So the patient was shifted to HTU post LSCS for intensive monitoring. The BP remained on the higher side, which was controlled with oral antihypertensive medications, and she was continued with proper antibiotic coverage, uterotonics, and adequate analgesics. Post CS, she was given 2nd unit of SDP, and she was given IVIG of 55 gram, that is 11 vials. On post-op day 1, her blood pressure was again on the higher side, which was controlled with injectable as well as oral antihypertensives, and she was given anti-D. The entire post-op period of this patient was entirely uneventful. On post-op day 3, she was again restarted on tablet prednisolone and tablet L-Tromboplek along with other supplemental medications. The patient was eventually discharged from our side on post-op day 9 along with further hematological and general medicine consultation. So summarizing my case, it is a case of about a 28-year-old female known case of ITP under treatment from the last 4 years with RH negativity, preeclampsia with severe features under medication, who underwent LSCS at a platelet count of about 23,000 for preeclampsia with severe features with uncontrolled BP and IUGR and oligohydramnios. She delivered a 1.3 kg female baby and was administered 2 units of SDP and 8 units of RDP and 11 vials of IVIG. So the platelet count at the time of her discharge was 34,000, and she was continued with usual medications. So concluding my case, this case highlights the importance of a multidisciplinary approach and the need of an intensive monitoring throughout her entire pregnancy, which could avoid certain possible complications. Thank you.
So thank you. What is the learning from this case?
So my entire presentation shows the importance of a multidisciplinary approach and the importance of diagnosing a case prior to her conception and continuing proper medication, proper follow-up throughout her pregnancy.
Do you know the dose of IVIG, how it is calculated in these patients?
1 gram per kg.
No, it's not 1 gram per kg. Okay. Any other questions from the floor? Thank you.
Thank you, sir.
So we conclude this session now? Okay.
Then we'll have the quiz. After the quiz, we'll have the prize discussion. So, thank you, chairpersons and our clinical experts. Sir, please move to the this presentation arena for the felicitation. And actually, I must congratulate those who are present here, because till now, whatever you have shown, it all were individual efforts. So now you are going to actually feel what is the strength of interface between gynecology and rheumatology, because now we are going to start our quiz, and the quiz masters are Professor Dr. Sakir Ahmad, who is a rheumatologist, and another quiz master is none other than Dr. Mohini Sinha. So let's enjoy the interface between rheumatology and gynecology. Sakir and Dr. Mohini, the stage is yours.
Thank you. I would also like to invite Dr. Shreya to help us. She'll be our scorekeeper. And Dr. Archana, please. You can please sit here. So I think this is the final agenda of the day, and if you have been attentive enough, most of the questions, the answers have already been presented by the various speakers. First, we'll have a prelim. I think there are 18 groups registered for the quiz. If anyone else wants to join, I think we can accommodate. So just sit 2 by 2. All the quiz participants, please come forward, sit 2 by 2. Leave at least one chair vacant in between. Please come to the front. Please make sure there is at least one empty chair between teams. Take a blank paper, write down the name of your team as well as the participants. We have some very interesting names of the quiz teams, but let us see how many come true. After the preliminary round, we'll select the top 5 teams. Basically, in the preliminary round, there will be 13 questions, or 12. There will be 13 questions. 1 to 10 will be MCQs. 11, 12, and 13 are single answers. You have to write down the answers. And if there is a tie, we'll determine who scores more on this 11, 12, and 13 number questions. Questions 1 to 11 will have 1 mark each. 12 and 13 will have 2 marks each. So hopefully all the teams are ready. Can we start? Yes? No, no negative marking, but in case there is a tie, then we will consider negative marking. Everyone is ready? So we can start. I'll ask my better half, Dr. Mohini, to take over and start the proceedings.
So, we'll start with the first question. What is the preferred mode of delivery in a woman with well-controlled APLA or SLE? The first option is elective cesarean section at 37 weeks of gestation, induction at 34 weeks of gestation, vaginal delivery at term unless obstetric indications arise, and planned cesarean at 32 weeks of gestation. Next, which of these helps in protecting the fetus from rejection? First option is HLA-G, next one is calprotectin, third one is calnexin, and fourth one is MRP 8/14. Coming to the third question, which of these is the major antigen presenting cell in the uterus? First is CD209 expressing macrophages, number 2 CARD9 expressing monocytes, number 3 CD209 expressing lymphocytes, and number 4 is CARD9 expressing lymphocytes. Coming to the fourth question, a pregnant woman with APLA on low molecular weight heparin and low dose aspirin. When should low molecular weight heparin be stopped if a planned induction is scheduled at 39 weeks of gestation? First option is 24 hours before labor induction. Second option is 12 hours before labor induction. Third one is at the onset of contractions. And number 4, continue low molecular weight heparin until delivery. Fifth question, a pregnant woman with SLE has high risk of preeclampsia. Which of the following findings would differentiate lupus nephritis flare from preeclampsia? Option 1, active urinary sediment RBC CAS. Number 2, neutrophil gelatinase associated lipocalin. Option 3rd is raised uric acid, and fourth one is none of the above. Colchicine is contraindicated in pregnancy. Second option, lactation. Third option, both of these. And fourth, none of these. Which is false regarding press? It is not always reversible. Second option, it does not always affect the posterior part of the brain. Third option, cyclophosphamide does not cause press. And fourth option, it is associated with preeclampsia. Which anti-TNF drug does not significantly cross the placenta? First one, infliximab. Second option is etanercept. Third one is adalimumab. And fourth one is cetrolizumab. Next question. Despite low molecular weight heparin plus aspirin uses during APS pregnancies, what percentage of pregnancy loss is still seen? First option, 5%. Second one, 10%. Third option is 15%. And the last one, 30%. On which cells is the neonatal Fc receptor present? Option 1, placental cells. Second option is epithelial cells. Third one is endothelial cells. And the last option is cells of hematopoietic origin. So, you can see the picture, fetal cell and maternal cells. Fetal cells entering the maternal circulation have been implicated in the pathogenesis of autoimmune diseases like systemic sclerosis and rheumatoid arthritis. What is this phenomenon called? So this is 2 marks question. TRIM21 is a E3 ubiquitin ligase. If antibodies against TRIM21 are transmitted from the mother to the fetus, what complications is the baby likely to have? Coming to the last question, a 35-year-old SLE patient with a living issue of 5 years presented in our 12th week of second pregnancy with severe anemia. Which enzyme level will help confirm the diagnosis of TTP? And write its full form.
please hand over your papers. I would ask Kalandi, Rashmi, please help collect the papers. Make sure you have written your names and the name of your teams. I would request Dr. Shreya, Dr. Archana and Dr. Mohini to correct the scripts while we'll just look at the answers one by one. Madam can also help in the correction. We are waiting for everyone to submit the scripts. Yeah, we'll have 5 people here. 3 will be sitting that side, 2 will be sitting this side. So everyone has submitted. Let us look at the answers.
Anybody who has not given their paper are disqualified. Simple.
So what is the preferred mode of delivery with well-controlled lupus or antiphospholipid syndrome? Vaginal delivery at term. So there is no contraindication unless there is some other obstetric indications. So answer here is C. Then, which of these helps in protecting the fetus from rejection? It is HLA-G. It is expressed on the syncytial trophoblastic cells. Calprotectin, calnexins these are molecules mostly present on the mucosa or skin, which are integral part of the innate immunity. Another name for calprotectin is MRP8. So MRP814 is again acute phase reactant complex. So here you can see this HLA-G is present on the trophoblast, which will inhibit the NK cells. If this HLA-G is not there, the NK cells will destroy the cell. So next, number 3, which is the major antigen presenting cell in the uterus? Anyone? From common sense, it will not be a lymphocytes. Lymphocytes will always read the antigen. So it has to be a monocyte or a macrophage. So if you eliminate 50%, you can toss a coin and see. But actually it is CD209. CD209 is also called as DC sign. DC, you know, is a dendritic cell. This is a marker of conventional disease, and even the macrophages in the placenta will have this DC sign or CD209, and they act as the major antigen presenting cell in the placenta. Question number 4. Lady on low molecular weight heparin and aspirin for APS. She is planned for elective cesarean section. How long before we should stop the heparin? The gynecologist should be all telling the answers, at least this answer. Pardon? 12 hours? 24 hours. The correct answer is 24 hours before you have to stop. And again, post-surgery, within 48 hours, if there is no major bleeding, you have to restart. Number 5, pregnant women with lupus has a high risk of preeclampsia. What is going to differentiate whether this is preeclampsia or lupus nephritis flare? RBCs, but RBCs are not found in preeclampsia. Casts, it is the same thing now. Once the RBCs come, they become dried up and they take the shape of the what you call the tubules. They are known as casts. So Classically, though preeclampsia has only proteinuria, but you can see the literature, RBC cast, granular cast, RBC sediments, everything has been reported in both preeclampsia as well as eclampsia. No one has answered uric acid? So uric acid is a marker for preeclampsia, but unfortunately it is also present in lupus nephritis flares because uric acid is a danger associated molecular pattern. When there is an infection, when there is a cell breakage, always uric acid levels will go up. When you lose weight, uric acid will go up. When you gain weight, uric acid will go up. So uric acid is not a specific marker, though it is helpful in prognostication of preeclampsia. So the correct answer is D, none of these. Then colchicine is contraindicated in, very easy. No one? It is in both of these? Yes? It is a very old drug. It has been known for centuries. The golden fleece of the Argonauts. If you read the legend of Argonauts, possibly colchicine has been referred to as the golden fleece. So even 2000 years before Christ, colchicine was known. And people have used it, and it is safe both in pregnancy as well as lactation. Though we think this is a mitotic inhibitor, it will cause so many defects, but actually it is very safe. What is false regarding PRES? Posterior reversible encephalopathy syndrome. There are lots of knots in the question, false and knots, that is just to confuse you. So we know posterior is not always posterior, it can affect anterior parts, middle parts of the brain. It is not always reversible, sometimes sequelae can be long lasting. Then C or D. It is associated with eclampsia, but is it associated with preeclampsia or not? Yes, it is associated with both eclampsia as well as preeclampsia. So, cyclophosphamide, can it cause PRES? Yes, cyclophosphamide can cause PRES. So, the incorrect statement is C. One of the causes of PRES is cyclophosphamide. Number 8, this is an easy one. Which anti-TNF drug doesn't significantly cross the placenta? Today morning it has been mentioned more than once. Even Malviya sir in his talk has this mentioned. D, certolizumab. It is not available in India because it doesn't have the FC portion. And since it doesn't have the FC portion, it will not be taken across the placenta by the neonatal FC receptor. The placenta has neonatal FC receptors which takes the IgG immunoglobulin from the maternal side to the fetal side. But since this antibody doesn't have a FC portion, it will not cross the placenta practically. But all other anti-TNF have now been shown to be safe in pregnancy. But we have to ideally stop maybe before delivery. Again, there is some controversy. There is no logical basis to stop except that it might cause difficulty in vaccination of the neonate. So we had a lot of discussion. We have seen 2, 3, 4 cases being presented, low molecular weight heparin plus aspirin. Even if you treat them, how many of the women will still have pregnancy losses? 5%, 10%, 15 or 30? No guesses? It is up till 30%. So that is why nothing is absolute. We have seen a great debate. The evidence is, obviously, we have to definitely use it, but it doesn't give a 100% success rate. We have to counsel the couple when we are doing this. Then again, very simple looking question, but actually this is a trick question. Anyone can tell me the answer? Answer is? Definitely it will be on the placenta. I just told you 2 questions ago. It is also present on all epithelial cells, all cells originating from the epithelium, all cells which have an endothelial origin, or all cells which have a hematopoietic origin. So answer is A, B, C, D. I never said that only one answer is correct. Did I ever say one answer is correct? So only those who have marked A, B, C, D, all 4 will get the mark. Otherwise you will not get marks. Then this one, difficult question maybe. Bolo? Microchimerism. So they know because we have discussed it in our medical college. Then this is TRIM 21, which is a very hi-fi names. Any idea what is TRIM 21? It is the antigen of Rho6. It is the Rho6 antigen is basically TRIM 21. So basically what is described here is the anti-Rho60 antibody. So if anti-Rho60 antibody is there, what will be the complication in the baby? 2 complications. You have finalized the top 5. Is there any tie? Okay. Then answer is very clear, neonatal lupus and congenital heart block. We have been talking about it all day, but no one actually mentioned TRIM21. That is actually the Rho60 antigen. This one, ADAMTS 13. So can you tell me the full form? Anyone courageous enough to tell the full form? A disintegrin and metanoproteinase with thrombospondin type 1 motif, member 13. Some questions have to be tough, just as a tiebreaker. So I would request Mohini to please come up and announce that who have made it through to the final round.
So we were really very scared about the tie break in prelims, but we got clear-cut team who will participate in our main quiz. First, I'll take name of that Shan Shiners, Dr. Pratibha and Dr. Swati, I think, from AIMS, Bhubaneswar. They have scored 11 marks, highest. You come, both of you come here. Then the next team is lupus team from AIMS, Bhubaneswar.
The first team can choose wherever they want to sit.
Yeah.
It will be A, B, C, D, E.
Yeah, because
They can select whichever seat they want.
because they have scored the highest, so they have got the right to select their place. So the second team is lupus team from AIMS Bhubaneswar only, Dr. Sanjita and Dr. Tukhin. Welcome, both of you. You have also got the advantage. Third team is of Dr. Siddhant Sahu and Dr. Chandan Kumar Sahu. From which college you have not mentioned? From SCB, okay. Then the next is BNSist, Dr. Bagni Biswajita Mahapatra and Dr. Subhashri Subhashmita. And the last team is Dr. Kamala and Dr. Lekhna from AIMS Bhubaneswar. Let them come.
2 means
आजा ना तो पहले मत दिखाना
Okay, we'll start. Please take your seats. I'll just tell you there will be 4 rounds here. Three standard rounds followed by the final rapid fire round. Mohini will be taking round 1 and 2. So for each direct question, if answered correctly, there will be 10 points. For a past question, there will be 5 points. There is no negative in rounds 1 and 2. Then I'll make it things more complicated from the third round onward. We'll have doubling. I'll explain it when I'm there. So over to Mohini.
So we'll start with the first round. All of you are ready and comfortable? So now we'll start. We'll start with team A. So we'll number the teams from this side to that side. Okay, 1, 2, 3, 4 and 5. Okay, all of you got your numbers? Be clear. Shreya, Rules again? Okay, okay. Rules. Previous slide.
We'll just identify the teams. First team is, you have a mic, Sunshiners. Team A is Sunshiners. Team B is Loopers. Team C is B Analyst. Then team D is Med Bros. So they are the Med Bros and not Medcist. So finally are the neonatal loopers. So very simple. You will have a direct question. If you cannot answer, it will pass on to the next and next until someone answers. If you answer the question put to you, you will get 10 marks. If you answer a past question, you will get 5 marks. There is no negative in round 1 and 2. Round 3, I'll explain later.
So for team A, the first question is 26 years old SLE patient pregnant for the first time at 16 weeks of gestation comes with severe headache. What does the MRI show? So we'll award 10 marks to team A. She has answered correctly, so she will get 10 marks. Team B, enumerate 3 non-criteria clinical manifestation of APS. Any 3. Number 1. We want 3.
Next, you will get 5 points. You will get 5 points per head. Name 2 more you need.
One more. 2 he said. Yeah, you answered 2 more.
Last question will not be enough. Clinical,
Non-criteria.
those are criteria. D.
Another one.
Another 2.
Preterm more than 30.
Headache, polyarthralgia, fever. Headache, polyarthralgia, fever.
Polyarthralgia is not there. Fever is not there. Headache also is not specific. No? Okay, no one will get, or they will only get.
Team A will get, one will get the chance. No, we are asking about clinical non-criterias. So these are the 6: chorea, dementia, cardiac valvulitis, livedo reticularis, thrombocytopenia. These 2 they have said: diffuse alveolar hemorrhage, pulmonary hypertension, and APS nephropathy. So now going to team C directly. A 29-year-old pregnant lady at 20 weeks of gestation with Crohn's disease on treatment with sulfasalazine present with this ulcer. What is the diagnosis? Team C. Good. So they are awarded with 10 marks. Coming to team D. 37-year-old patient with RA on sulfasalazine presented at 32 weeks with low-grade fever and pain abdomen. Elevated levels of which cytokine in amniotic fluid can predict increased chances of preterm labor?
TNF alpha.
Interleukin 6, 8.
Next. If no one will answer the question, we'll go to the audience. Stand up and answer. It's interleukin 4. Okay. Yeah. So 0 marks to Team E. A couple had a neonatal death due to IPEX proven by Sanger sequencing. Now they want to exclude the same in their next baby. What is the ideal time for chorionic villus sampling?
After 10 weeks, 10 to 15 weeks, we can do the chorionic villus sampling. After 15 weeks, we can go for amniocentesis.
The question is very straightforward. You give me the time frame. Within that time, we have to go for CVS.
10 to 14 weeks. 8 to 12 weeks.
We'll pass it to the next.
Chorionic villus sampling after 10 weeks only we have to do.
You have what you want to say, you say it very clearly. 10 to
12 weeks.
Huh? Go on.
Chorionic villus sampling final.
6 to 10.
Not at all. 10 weeks. Egg cancer, 10 weeks.
Gone. So, audience, who has answered? Please stand. A big clap to her. So, between 11 to 13 weeks, first of all, we should go for anti-scan double marker to rule out any anomaly. Then only we have to go for the CVS. That is the normal protocol. That is the norm. Okay. Now, coming to the next round. Round 2, we'll start with Team A. Team E. Okay. So, Team E, Klinefelter syndrome have higher tendency of developing lupus due to dosing effect of X chromosome. What is the normal mechanism of inactivating one X chromosome in normal females called?
Lionization. Lionization.
Good. So 5 marks to Team D. It is lionization. Now Team D. IL-10 helps in maintaining the immune privilege of the placenta. Which subset of T cells secrete IL-10?
TS2.
Pass. So will audience so a big clap for Jyoti sir. It is T-Rex. Okay. Now we'll go to Team C. Which protein is this? What did you say? Good, very good. 5 marks to team B. So direct question to team B. To diagnose catastrophic APS, antiphospholipid antibodies must be tested positive at least.
हम पास करेंगे
Good, good. 10 marks. Classical APS, it is 12 weeks, but for catastrophic APS, it is 6 weeks. Direct question to team A. Why is a lady with giant cell arthritis, Sakir, your full question is no, unlikely to get pregnant? We have not said not pregnant, unlikely to get pregnant. Next, team E. Team
Vasculitis leading to placental insufficiency.
Team C. Team C. Very good, proud of you. So, normally giant cell arthritis we get in postmenopausal women, so they are unlikely to get pregnant. We have said unlikely because they may undergo some treatment or IVF, something may come. So, this is the end of first two rounds. Okay. I think Shreya can give us the hint that which two teams are leading ahead.
Just read out the scores.
Just read out the scores, Shreya.
Okay, we'll go to the third round. Third round, there is an option of doubling. So if you are confident about your answer, you can say we want to double. If you double, instead of 10 marks, you will get 20. But if you double and get the answer wrong, you will get -5. I hope it is clear. If you direct question, if you answer correctly, 10 points. But before saying the answer, if you say we want to double, then you get the correct answer, you will get 20. But if you double and say the wrong answer, you will get -5. There will be no pass in this round. -5. Plus 20 -5 if you double. If you don't double, it is 10 and 0. We'll start from team A. As per the angiographic classification of Takayasu, what types are associated with bad obstetric outcomes? Be careful because you have to give the correct, full answer, not partial. You don't want to double on this, no? Give me one answer. First you tell me you want to double or not. Or you're not confident to double. Type 4 is your final answer. And the answer is incomplete. It can be type 3, type 4, type 5. 3, 4, 5 all will involve the abdominal aorta, leading to bad obstetric outcomes. Type 1 and 2 are limited to the just above the diaphragm. So they will get 0. Team B, which drug can retard the progress of congenital heart block in babies of mothers having anti-Rho or La antibodies? Can be anything. No doubling. So answer is incorrect. If you, the question is which drug can retard the progression. Hydroxychloroquine is one drug which will prevent, but once it is there, it will not reverse. Initially people thought dexamethasone was reversing. Now it has been proven. There is still controversy. It may retard the progress, it may not retard the progress, but hydroxychloroquine is very good drug for prevention, but once it is there, then hydroxychloroquine has very limited role. Team C, what is the mean reduction of this hormone AMH in women having SLE who has received low dose cyclophosphamide as per what we call the Eurolupus protocol? 50% reduction, no doubling. So answer is wrong. If you use a low dose Eurolupus protocol, AMH levels do not change and there is perfect preservation of fertility. Now everyone will be afraid to double. So team D, a 35-year-old, slightly elderly lady with axial spondyloarthritis is taking etocoxib and sulfasalazine. But she is not unable to conceive. So which of these drug is likely to interfere with her chances of conception and why? Why is more important? But you have to give the complete answer.
Don't want to double.
Okay.
It's etocoxib.
Why?
Because of the chances of unruptured follicle syndrome.
Unruptured follicular syndrome, very good. So there is an entity called luteinized unruptured follicular syndrome. So the women will have all the signs of ovulation like temperature rise and things, but actually the follicle will not rupture and ovum will not be released. This is seen because drugs like NSAIDs block the prostaglandin pathway which is responsible for the rupture of the follicle. This is much more important for COX-2 inhibitors like etocoxib. Team E, which immunosuppressant is known to cause reversible infertility?
List of drugs or one drug? So methotrexate, leflunomide.
Reversible infertility. Why would methotrexate or leflunomide? Obviously, answer is wrong. Anyone from the audience? Sulfasalazine, very good. So, methotrexate, leflunomide, they cause teratogenicity. They do not cause infertility. And the advantage of sulfasalazine is once you stop, after 3 to 6 months, the infertility or azoospermia improves. So, shall we have the scores once more before we go to the fourth round?
Team A is at 10 points, Team B at 25, Team C at 10, Team D at 15, and Team E at 0.
So, in round 4, you can score a maximum of 25. I think there are 5 questions for each of you, but we have to limit to 30 seconds. I would request Mohini to please keep the time. The timer will start as soon as I finish reading the first question. There are no negative, but once you have passed the question, you cannot go back to it. There will be a maximum of 5 questions or 30 seconds, whichever goes out first. So I'll read out the question. As soon as I finish reading the first question, timer will start. And within 30 seconds, how many questions you can answer. So if you're not sure, you can just pass, but will not go back to the past question. There is no negative. Each correct answer will be 5 marks. So team A ready? No, I'll do it. Yeah. Ready? Okay, sorry. We'll start with the lowest score. We'll E are yet to open the score, so this is the chance they can catch up maybe with the top scorer also. Are you ready? Please take the mic. you have less time. So the first question is, mycophenolate must be stopped at least how many months before planning pregnancy? Timer will start after first question.
6 weeks.
Wrong.
Months.
Sapporo is in which country?
3 months, ma'am. Sir.
Sapporo is in which country?
Sapporo is in which country?
If you don't know, say pass.
Pass.
APS can cause arterial thrombosis. True or false?
True.
Treatment of choice of TTP.
IVIG and platelet transfusion.
Direct, just I'm giving this question, direct factor 10 inhibitors are superior to vitamin K antagonists in APS. True or false?
True.
Okay, I'll let them. So if we go to the answers, mycophenolate should be stopped at least 3 months. Initially they said 6. She will not get a score for that. Sapporo criteria, you know, is the primary APS criteria, and Sapporo is a city in Japan. Arterial thrombosis causes, APS can cause arterial thrombosis, true, they will get 5 points. Treatment of choice, plasmapheresis they have mentioned, so true, though we do not give platelet transfusion unless there is life-threatening bleed. And direct inhibitor, this is false. So they have 2 correct, they will get 10 marks. So next team will be C and A are tied. So who wants to go first? A? Okay. We'll go with next team A. So timer will start after I finish reading out the first question. Cyclophosphamide is contraindicated in lactation, true or false? Timer should start. Sapporo criteria was revised in which city? Full form of IDO. Higher parity is a risk factor for rheumatoid arthritis, true or false? HLG is which class of MSC? Be specific. So, cyclophosphamide is contraindicated. They answered, or they did not answer this. This is false. Sapporo, the revised Sapporo criteria is also known as the Sydney criteria or the modified APS criteria, which we are following till recently. Full form of IDO, this was mentioned at least by 2 speakers today, especially by the first speaker, he spoke about the kynurenine pathway, and it is indolamine 2,3-dioxygenase. Higher parity is an independent risk factor for rheumatoid, this is true, and HLA-G is in 1B, MSC 1B, non-classical, class 1. So I don't think they have scored anything in this round. So next will be team C. Ready? Name the drug used to wash out leflunomide before planning pregnancy. They may be your friends, but don't give hints. Hughes syndrome is also known as? Correct. Aspirin should be given to all patients with APS in pregnancy. Aspirin should be given to all patients. True. Full form of MSC? Correct. RA tends to flare in postpartum? True. So they have got cholestyramine, they did not say. This second question, antiphospholipid syndrome is correct. Aspirin is true. MSC, they have got it correct, and this is true. So they have got 4 correct. They will be scoring 20. Then the 4th round. Are you ready?
Yes.
So, cyclosporin is contraindicated in pregnancy, true or false?
False.
Dilute Russell Viper venom is used for which test?
Lupus anticoagulant.
Correct. Target INR on anticoagulation for APS. What is the target INR?
2.5 to 3.
Wrong. Treatment of cutaneous neonatal lupus? Treatment of choice?
Dapsone.
Severe pulmonary arterial hypertension is a contraindication to pregnancy in systemic sclerosis. True.
True.
So, This they have got correct. Cyclosporin is not contraindicated. Dilate Russell lupus anticoagulant test, this is correct. INR should be 2 to 3. There are exceptions, but the standard is 2 to 3. Treatment of neonatal lupus is you just wait and watch. The antibodies will go out and the cutaneous this thing will improve. And last also they have got correct. So they have got 3 correct, 15 marks for them. Then for team B, you can share it. So if you are ready, for a couple with inability to conceive, recommended steroid dose of is prednisolone equivalent less than 25 milligram per day. True or false? Russell Viper venom activates which clotting factor? Correct. Which upload test is unreliable once anticoagulation has started? Correct. Babies of patients with Sjogren's syndrome can have neonatal lupus. Which domain of beta-2 GP1 attaches to phospholipids? So they have got a few correct. So the recommended dose is if someone is having inability to conceive, they should be kept at doses of less than 15 milligram. Some other indications, suppose myositis or lupus nephritis is there, then the steroid dose should be reduced to less than 15 per day. Russell Viper venom activates factor 10, and once anticoagulation is started, the lupus anticoagulation test is not reliable. And this is true, Sjogren's syndrome will have Rho antibodies, and domain 5 of beta-2 GP1 attaches to phospholipids. So we have come to the end. I hope results are clear. So they have answered first one, second one, third and fourth. 4 are correct, 20 points. For second. So we can have a tiebreaker. We'll give them 2 papers and give them 2 questions to write. Since we had so much of discussion regarding antiphospholipids, let us keep the question on antiphospholipid. First question is, write all the criteria antibodies for antiphospholipid syndrome. What are the antibodies included in the criteria? Write down all the antibodies. How many are there? Done?
Criteria, or we can write whatever antibodies?
No, you have to mention all the criteria antibody, not one less, not one more. If there are 3, you write 3. If there are 4, you write 4. How many there are, you have to mention each and every one. If you are done, we'll go to the second question. Second question is, how many Rho antigens are there and what are the molecular weights? We have anti-Rho antibody. How many antigens are there for anti-Rho antibody and what are the molecular weights? Molecular weights. criteria antibodies are there? How many criteria antibodies are there? There are 5 criteria antibodies. Lupus anticoagulant, anticardiolipin IgG, anticardiolipin IgM. Then beta-2 glycoprotein IgG and IgM. So there are 5. So D have mentioned IgG, IgM, anticardiolipin. IgM, they have mentioned 4 correctly. Okay, IgG, they have mentioned this correctly. But team C has mentioned 1 extra, IgA. So IgA, and they have so IgA is not a criteria, it is a non-criteria antibody. And so just by a small fraction, second question both have got correct. So by a small fraction, team D has taken, I think, the second spot. So I'll ask Shreya and Archana, thank you, to please announce the final results.
On first position is team B with 45 points. On second position is team D with 30 points.
Third position, team C.
So by the time we are finalizing the certificates, I'll request everybody to stay because the final prize distribution ceremony will be there, and I think this is very heartening to see so many students are there. So I'll ask them to stay for 5 more minutes. Every good thing has to come to an end. So I thank all of you to be here, to support us, learn together, and this is the valedictory time. So I must thank first the Almighty of God, because if your star positions are not, I think they decide everything. So, sir, asleeni, sir, आपण पळेसून सीधा आम्ही प्राइज डिस्ट्रीब्यूशन आहे कोच. Sir, please, we need you. Sir, असून पूरा डायरेक्ट कन्वेंशन सेंटर पळेसून. So, first I want to thank Almighty God, because I think it is His supreme wish that irrespective of this unconventional meeting, so many people get together today and we learn together so many new things. I want to thank all the speakers who have taken their time. Professor Anand Malabia, who is 86-year-old, and nobody thought that because he stopped traveling outside Delhi because of his health reasons, and we are very fortunate that he has given his consent and traveled so far to join us. And there are so many other dignitaries, Professor Girija Bag, Professor Gauri ma'am from Jipmar. So many other fraternities because of whom today's session was so exciting. I must thank all the head of the departments of Gynec and Medicine departments of All India Institute, SCB, MKCG, SHAM, KIMS, because when we started to have this meeting, there was doubt in everybody's mind that how you are going to make it. Because even if whatever I have heard, even in Gynec meeting also, they have very difficult, because every day in and day out they are having meetings. So I am very thankful to Dr. Purna Mahapatra sir, because I had gone to visit his clinic night 11 o'clock and we talked till night 1 o'clock. That how to conduct this meeting, and with his guidance and everything, things have become possible. I must not forget Preeti, Dr. Preeti Dubey, who is my classmate. Although she was not well, but she came today and she was instrumental in bringing all the gynec faculties that you have seen, because I was not knowing them. So Preeti has done a tremendous job. I must thank all the participants and students present here, because the whole purpose is for the next generation. Because if you learn, if you show interest, because the next clinical practice is going to be a collaborative practice. You cannot have individual practice. I must thank Professor L.K. Mayer sir, who have taught me rheumatoid arthritis. And he is my inspiration. My first class of rheumatology he has taken in MKCG Medical College, Barampur. And I am astonished actually. I can imagine me at that age listening from, staying here from morning to last and listening to each and every quiz questions. I am really, I think this is something that we all have to learn. Only learning conference doesn't allow you to learn science. It also allows you to learn organizational skills, to follow your seniors, to see that what a teacher is a teacher not because he knows the facts. Like we have seen, we have discussed during Dr. Malabia that discipline, punctuality, and the eagerness to learn whatever age you may be, and the eagerness to share your knowledge, what makes a teacher different from others. And I think I should thank Professor Dr. Sakir Ahmad and Dr. Mohini Sinha to be here with us and made this organizational very beautiful quiz. So please give them a applause. No function is complete without the participation of pharma people, because a doctor's life is black and white. I think whatever you have seen, whatever we are discussing, we must thank them for making us to conduct, for making us enable to conduct these kind of meetings, because without their support, I think this is not possible. So we want to felicitate them, each of them, at the end of the meeting. We are thankful to the media personnel. We are thankful to the organizational team. Particularly, I think Preeti I have mentioned, Dr. Prashant Pradhan sir, who is the scientific chair, Dr. Debasis Maikaf, who is the joint organizing secretary, but has left the meeting, I think, before. Okay. And I should not forget my wife, because so many people have told me that you are able to do this because of your wife. So, which is 100% truth. And my brother Smruti, who is not a medical student, but whatever you are seeing today, starting from the souvenir design to design of everything, I think this is because of his understanding of the subject now, because he has already conducted 4 conferences. I have hardly given time for this conference because this has gone to auto mode. If we decide to do something, he knows how to send mail to the faculties, how to organize the souvenir he has prepared in 3 days, how to send it for the quiz, how to make those posters, send for the quiz competition, send for the poster presentation. So I think because of him, we are able to do this in a much more innovative way. And finally, I should thank all the media personnel that were present today, because whatever we discuss, we do, they are the personnel who will take this to the patients, to the society. And finally, I must thank Mayfair, because this is all our consecutive meetings at Mayfair. Because of their hospitality, because of their good food and ambience, I think that has become a major attraction for our function, because if you are telling of Mayfair, it assures you quality. So thank you all. I think now we are ready with the prize distribution ceremony. Before that, I will be happy if any of our professors or sir will tell something about the conference. That will, I think, make our efforts will be satisfied, sir. Sir, Mayor sir.
Just few days back, he called me, sir, this is the thing, and you have to chair a session. So immediately I replied, yes. And I really enjoyed the conference from the first session itself, from the very first minute. Throughout the day, I am sitting. A wonderful arrangement indeed. And I at least learned a lot. And I hope all of you must have updated your knowledge. And thank you all very much, Jyoti. Again, God bless you. And all my best wishes with you.
So I will not call Sakir first, I will call Dr. Mohini Sinha ma'am first to tell few things about this interface meeting.
Good evening, everyone. Actually, saying thanks to Jyoti sir is really very small thanks because this was really a very good academic feast to all of us. We all know that nowadays, this side, that side, we are facing so many CMEs we are getting, but the topic, the content, and the speakers, what they have chosen was really very good, and I think we all have got benefited from this. Apart from the food, apart from the hospitality, everything was good, but what I say, the academics was the first and the foremost priority, and I really want to thank Jyoti sir for this. And as far as quiz is concerned, it was really a big challenge for us to make because we cannot give hardcore rheumatology questions, we cannot put hardcore gynecology question, we have to stay interface. So it was a challenge, but we really enjoyed the process, and we really enjoyed the quiz also because few students did so well. They have the very good knowledge. I think we studied and we got the knowledge during this course, and they studied well. They have done very well here. So I think our future is secure. So thank you everyone. Special thanks to Jyoti sir, ma'am, and all the organizing persons.
I think Mohini, this is not a challenge for you. You are very privileged because everyday interface is happening at your home. So I think Dr. Sandeep has came from Pune to attend this meeting. Dr. Sandeep is a practicing rheumatologist at Pune, but he is a son-in-law of Odisha. So Sandeep, please.
Thank you very much, Jyoti bhai, for inviting me and including me at almost 3 to 4 days before I finalized coming over here. Thank you very much for arranging meeting for me. And thematic discussions is now in trend. So we have got large conferences, but we have seen in large conferences the specific issues tend to get ignored. So this has become the trend, and this OARC has set up a trend of having a new thematic meetings every year. Now, since it has run the 4th episode, now we'll always be looking forward to the further updates every year. So now this will be a conference which everyone will vouch for, and we are eagerly awaiting what you are going to bring up in the fifth issue. So all the best for all the future conferences, and I would always be like to be a part of these events. Thank you very much.
So thank you, Sandeep. So now I think I will invite Professor L.K. Meher sir, Dr. M.P. Das ma'am. She was there, I think she left. Okay. Professor Dr. Sakir Ahmad, please come. So we will have the prize distribution. Mohini, you can join us, please. You are also faculty, please. So the third prize for poster presentation, it goes to Dr. Saranya Kumari from, I think Saranya Kumari. Dr. Saranya Kumari, is she there? Saranya. Sorry, Srabya, sorry, yes. Please come. Oh, I have to put my specs. Please come. This 1,000 rupees Amazon card along with the certificate. Sir, So she was from Sam Hospital. The second goes to Dr. Rajeshwari Mahanti. So Dr. Rajeshwari Mahanti, please. I think you are from KIMS. Okay. So KIMS got the second prize in poster presentation, Dr. Rajeshwari Mahanti. That is an Amazon card of 2,000 rupees along with the certificate. And the first prize go to Dr. Kamla Jamra of AIMS. So that is rupees 3,000 rupees with a certificate. Next. So next is for the oral presentation. So the third prize goes to Dr. Elia Fatima. You are from? KIMS. Oh, KIMS. So Dr. Elia Fatima, a prize money of 2,000 Amazon card along with certificate. The second prize goes to Dr. Siddhant Sahu. Dr. Siddhant Sahu from SB Medical College, Kota. So prize money of 3,000 rupees along with the certificate. I think this is going to be unfair. So again, the first prize goes to KIMS. Dr. Abarna Agarwal. Where is Abarna? It's there. So it is all KIMS and AIMS. Dr. Abarna, any of her colleague can receive this? Yes. Dr. Avanna is a DM resident of Rheumatology, so she got a Amazon prize card of 5,000 rupees along with the certificate. So for the quiz, I'll invite Dr. Mohini, who also has done all the hard work. Please come. Yes, sir. So the third prize goes to Dr. Subhasri Subhasmita and Dr. Bagmi Vishwajita Mahapatra. The second prize goes to Dr. Siddhant Sahu and Dr. Chandan Sahu, again from SB Medical College. And the first prize goes to Dr. Tuhin Shubhra Bandopadhyay and Dr. Sunita Dali. Cash prize of 3,000 each along with certificate. All the participant of quiz and oral presentation, paper presentation, they have a participant certificates. They can collect it from the reception. But I'll invite everybody to come here for a group photo. Please, all the students and all the delegates, please come here for a group photo. you, sir. Thank you, sir. So I think this is the time we should remember, as I have already told, that without pharma participation, this would not have been possible. So I, on behalf of OARFT, we want to thank each and every pharma members who have supported us, and I'll call one by one, and why we want to felicitate you. So when it comes any RIMA function, I think without the participation of IPCA, this is a perception, whether this is a national conference, this is a state conference, this is a society function, I think they are always at the forefront of dissemination of knowledge. And not only the participation, I think Manoj is instrumental in organizing such kind of events. I think for the last 4 updates, he is there always with us. Whenever I get tense, he always tell me, sir, ho jayega. So this time they are not there for a week, but still in the last week we are able to pull out the show. So first I would invite IPCA and on that behalf Manoj to come here, and with the whole team we want to felicitate you. Please, the IPCA team. Or is it? ठीक है अच्छा सब लिख अच्छा क्या है लाइन लगी So the next is overseas pharma. The next is overseas pharma. Please come to the dais. Overseas, anybody is there? The next. Okay, Rocky there. Next is MSN. MSN. Next is Torrent, Rasmi. Next is Basu Organics. Prashant. Next is Farmed. All three division. Farmed. Tara. Nobody is there. Okay. Next is Dr. Reddy's. Reliance. Reliance Life Science. Priya is there or left? Wallace Pharmaceuticals. Priya, please. Next is Ivy Life Sciences. So the Ivy Life Science is behind many things actually. So we thank them for their wholeheartedly participation, starting from the designing to the media coverage and everything. Microlabs. So I think before calling Helton, I must thank to Prafulla. Prafulla is there. I think although he is not in the rheumatology sector, he is very vital in actually helping me in having this registration from the gynec side. I think he has gone for one registration, he has spent one whole day, and he also got scolded by many people, and he has taken all the pain for us. So Prafulla, a personal thanks to you, and I must call all the team along with Satya, not only for the stall, for the beautiful photos that you have given to our delegates. Please. So again, if Prafulla has done that job in the gynec section, another person that I want to name in the last 4 updates, somebody who is able to penetrate AIMS, because usually people, AIMS has so many several restrictions. If one person single-handedly done all the registration from AIMS, not only the registration, all the presentation, poster, everything, I think Santosh, please come to the dais. And along with that, please, Jagdish and all the team members, Alok, please come. So, so Santosh, without Santosh, actually, this conference would not have possible, because yesterday also she had gone and made posters for the doctors, because of which they came today. So she had gone to AIMS yesterday night, 8 o'clock, brought the things in a pen drive and printed the posters for them. So Santosh has a huge role to play. Intas Pharmaceutical. You have. So we have Hariba India Private Limited. From the lab side, all participations were from the pharma side, but Hariba was the only lab person who got associated with this conference. And I must welcome Professor Dr. Jayant Kumar Panda, my teacher, who was directly came from Mumbai. And that is what the commitment should be like. Sir, I welcome you directly to the stage. Sir, I understand.
Apollo Hospital ଲଗେଇ ଦେଇଛି ଆଉ 20 ମିନିଟ୍ ଆଗରୁ ମୁଁ ଆସନ୍ତି ମୋର ମୋବାଇଲ ଠିକ ଅଛି actually I'll take 1 minute. I had to be there since morning. I had committed Jyoti, and unfortunately I had a exigency and I had to travel to Mumbai, and I have already reached 6:30, landed 6:30, and by mistake the new driver has taken in the NH, and again it was delayed by half an hour. I'm very sorry for that. We had a very good program. I thank all of you, those who are still there. Congratulate Jyoti. It's a very nice theme of connecting the immunology with fertility and the all women and the immunologist. So I'm excited. I'll go through the proceedings and also encourage my postgraduates and give a big hand for such an effort which should continue year after year. Thank you.
So this is something that whatever field you are, you may be a doctor, you may not be a doctor, because in pharma also you are going to lead the team. And here is one person, my teacher, I always get inspired that you can, who never tires actually himself, and who have come, because he could have easily avoided, because we know that there is a very reasonable cause, he was in Mumbai. But that is the love and affection, and that's why we always thank him. I think no thanks will be a very small word. We always feel that somebody is there behind us. That's why we are able to do all this. So again, I bow my head before my teacher, and all of you know him, Professor Dr. Jayant Kumar Panda. I request now him at least to join us in felicitating our other pharma colleagues. Show RPG Life Sciences. Please come. RPG Life Sciences. They are not there. Zydus, anybody from Zydus? we'll have a group photo with sir. Please, everybody come to the dais.